Good morning and warm greetings to our distinguished delegates, respected faculties, postgraduate and undergraduate students, and esteemed guests joining us both in person and online for this hybrid CME.
Good morning. On behalf of the Department of Biochemistry, Government Kadal Medical College and Hospital, it gives us immense pleasure to warmly welcome you all to the BioEndora 2026, a hybrid CME on endocrine epic from the first cry to the bone dry. This special occasion is also dedicated to honoring the superannuation of our beloved Dean, Dr. K.U. Suresh Balan sir, the Dean of GCMC&H CHIDAMBARAM, whose guidance and leadership have greatly inspired us. Thank you.
Good morning, everybody. Without any further ado, we shall now proceed to our first scientific session titled Skeletal Shields, and with the topic osteoporosis and endocrine perspective. Osteoporosis is far more than a simple calcium story. It is truly an endocrine narrative. This session promises to provide valuable insights into the pathophysiology, clinical significance, and monitored management of osteoporosis from an endocrine perspective. To chair this session, we are honored to have our Dr. S. Sudarshan sir, Professor and Head of Department of General Medicine, GCMC CHIDAMBARAM. I now invite Dr. Prasanna Balaji sir, Senior Assistant Professor, Department of Biochemistry, GCMC, to kindly introduce our esteemed chairperson to gathering. Over to you, sir.
It is my great privilege to introduce our distinguished chairperson, Dr. Sudarshan sir, Professor and Head, Department of General Medicine, Government Kadalur Medical College and Hospital. He has completed his MBBS from Raja Muthiah Medical College and Hospital in 1987 and his MD in General Medicine from Jawaharlal Nehru Medical College, Belgaum in 1994. Serving at Raja Muthiah Medical College since 1997, he has made remarkable contributions to teaching and patient care. With over 30 years of experience as a senior consultant and postgraduate teacher, he has mentored numerous medical professionals and is highly respected in general medicine. We are honored to have him with us today. Sir, I welcome you to chair the sessions.
Thank you. Good morning. So we'll start the session directly, no? We'll start the session directly. So enter. Okay. So good morning, everybody. So delightful to introduce Dr. Arun Nathan. Actually, I was talking to him. He is from basically from Chidambaram itself. So shifted to Virudhachalam now. So he graduated from Stanley Medical College. From there, he went to, I think, Indira Gandhi Medical College, again in Pondicherry, second state. So for his DNB in medicine. From there, he went to Assam. How he got in Assam? Through All India.
Yes.
Okay, good. So he has done a lot of research papers, and only thing is, he got an award for ECG questionnaire. So why he went to, that's why I left cardiology and he gone to endocrinology, I think. So, and now he is working as an endocrinologist in Dhanalakshmi Medical College. So, I welcome him and to give the first session. So, thank you.
Good morning, everyone. Thank you, Department of Biochemistry, for this opportunity. Today, I will be discussing on osteoporosis, endocrine perspective. My agenda will be introduction, bone and endocrine organ, diagnosis of osteoporosis, prevention and treatment of osteoporosis. Osteoporosis is a condition characterized by deterioration in the bone mass, which increase the bone fragility, and it will lead to fracture. Prevalence of osteoporosis in India is 8 to 62%. 20% of patients with osteoporosis are diagnosed and treated in India, and remaining 80% of people are undiagnosed and they were not treated and they end up in fracture. Why we have to know about the osteoporosis? Because of the impact. Hip fracture result in 8 30.4 to 36 percentage mortality, and this mortality is higher in men compared to the woman. And 20 percentage require long-term nursing home care, 60 percentage fail to regain the pre-fracture independence, and there is increased risk of other subsequent fracture. Vertebral fractures are often subclinical, silent, and for some people it causes pain, disability, spinal deformity and kyphosis. It also results in restrictive lung disease. Lumbar fracture result in constipation and abdominal pain, and these fracture also increase the risk of subsequent fractures. So we have to know and read about osteoporosis. And few points I will discuss regarding the bone. Bone is not a dead tissue, it's an endocrine organ. It will have bone matrix and cells, and we all know the epiphysis, metaphysis, diaphysis, all these things. Embryology begins in early life, 6 to 7 weeks of gestation, starts with condensation of the mesenchymal cells. Bone formation takes place through either encontral ossification or intramembranous ossification. Formation of the long bone, that is the axial skeleton and appendicular skeleton, takes place by encontral ossification. What is encontral ossification? First, it starts with the mesenchymal progenitor, and these progenitor differentiate into chondrocytes. These chondrocytes will, there will be a resting chondrocyte, and slowly it will grow and become a hypertrophic chondrocytes, and then there will be formation of the matrix and then mineralization of the bone. This is encontral ossification. This will occur for appendicular skeleton and the axial skeleton. And intramembranous ossification occurs in the cranial and facial bone. Here there won't be a calcified cartilage. There will be a mesenchymal stem cells which will form the bone forming cells that will straightly form the osteoid. And there are two types of bone. One is cancellous bone and another is cortical bone. Cortical bone is the hard durable part of bone. It forms the 80% of bone mass, and it forms the shaft of the bone, safeguard and supports the body. Cancellous bone, on other hand, it forms the 20% of the bone, and it forms the bone ends, that is epiphysis. It have the trabecular network, and it has high metabolic activity. This is the cortical bone, and this is the cancellous bone or lamellar bone. And we should know regarding the oppositional bone growth, that is there will be bone degradation inside the medullary cavity and bone formation outside that is periosteal region, so that the bone will grow. That is the oppositional bone growth. What are the cells that are involved in bone remodeling? There are few cells that will participate in the bone remodeling. These cells include osteoblast, osteoclast and osteocytes. Osteoblast are the bone forming cells. They will be formed from the mesenchymal stem cells. They are connected via the gap junction. They will produce the bone, that is collagen and non-collagenous protein, and they will die by apoptosis, or they will be converted to the osteocytes. That we should know that hematopoietic stem cells will be there. That stem cells will be converted to pre-osteoclast and osteoclast. They will have a rank receptor, and this is mesenchymal stem cells. This mesenchymal stem cells okay, this is lower part is mesenchymal stem cells. This mesenchymal stem cells will produce the osteoblast. Osteoclasts are derived from the hematopoietic stem cells. They will have high mitochondrial content, and rank ligand is a principal stimulator for osteoclast formation. And there is a molecule named osteoprotogerin. This molecule acts as decoy receptor for the rank. Thereby it causes suppression of the osteoclast activation. This osteoprotogerin is activated by growth hormone and estrogen, and it is inhibited by calcitriol, PTH, glucocorticoids, etc. And this is rank ligand. Rank ligand is produced by osteoblast, which will act on the osteoclast and causes activation of the osteoclast. Osteoprotogerin inhibits the rank ligand, thereby it inhibits the osteoclastogenesis. There is a fully monoclonal antibody named denosumab that is against the rank ligand. This rank ligand is inhibited by estrogen, testosterone, TGF beta. All these things will help in formation of the bone. And there is another group of cells named as osteocytes. These osteocytes are formed from the osteoblast. They have a reduced metabolic activity. They will have dendrite-like process, and they will sense the mechanical stimuli. It plays an important role in the bone remodeling process. We have discussed regarding this. This is the hematopoietic stem cells which will produce the osteoclast in multiple steps. We can see the last process is inhibited by the estrogen. And glucocorticoids is GC that will stimulate the formation of the osteoclast, and it will inhibit the formation of the osteoblast. Bone remodeling. Bone remodeling is a process of like bone degradation, bone formation, and there is something called peak bone mass. Peak bone mass is the mass which that is the maximum amount of the bone mineral density. Initial first 2 decades of the life, we will attain the bone mineral mass, and peak mass will be acquired at 3rd decade of the life, and thereafter bone loss will take place. This is the steps in the bone remodeling. First step is bone, there is activation. That activation will be activation followed by resorption, reversal, formation and termination. Initial step for activation of the osteoclast is the mechanical stimuli. If there is any mechanical stimuli, osteocytes will get activated, and it will cause activation of the osteoclast. This osteoclast will get adhered to the bone surface. It will form the ruffled borders. From the ruffled borders, it will produce cathepsin K and acidic environment. Thereby, it will cause a degradation of the collagen. Thereby, it will cause resorption of the bone. This is followed by reversal phase. In the reversal phase, osteoblast will come, and it will slowly produce the bone, and the osteoblast will undergo apoptosis, or it will become either osteocyte like that, and it will get on, all this process will get terminated. Like this it will go quiescent, then it will get activated for resorption of the bone, followed by formation of the bone, then mineralization of the bone. This process will take on, and there will be mineralization of the bone. This is a pathway called WNT beta catenin pathway. This pathway will result in increased formation of the bone, and that pathway is inhibited by sclerostin. And one more molecule is there, that is DKK1. And what are the endocrine regulators of bone remodeling? Growth hormone, glucocorticoids, parathyroid hormone, calcitonin, thyroid hormone, insulin, growth hormone, all these things will act on the bone. First I will go one by one. First is parathermone. How parathermone acts? Parathermone is produced in response to low calcium or increased phosphorus. It will act by stimulating the 1-alpha hydroxylase, thereby increasing the alpha calcitriol levels. And it acts via the osteoblast and osteocytes, thereby decreasing the rank, increasing the rank ligand, decreasing the OPG. That is, it will increase both osteoclastic and osteoblastic activity. There will be increased bone remodeling. If we give intermittent PTH, it will result in bone formation, and if we give continuous PTH, it will result in bone resorption. And calcitonin. Calcitonin is a peptide hormone. It is produced by the parafollicular C cells. It will inhibits the osteoclastic function by reducing the ruffled borders. Thereby, it can increase the bone mineral density. And estrogen. We have already seen estrogen inhibits the osteoclast by inhibiting the last step in the osteoclast formation, and it also decreases the rank ligand and increase the osteoprotogerin, thereby increasing the bone formation. And similarly, testosterone also increases the bone formation. Glucocorticoids. Glucocorticoids has multiple action. It will decrease the calcium reabsorption from the intestine. It increases the osteoclastogenesis, decreases the bone formation, decreases the WNT signaling, decreases IGF-1 expression in the bone. All these things we should know that glucocorticoids will cause increased bone resorption, decreased bone formation. It will cause osteoporosis. This we can see in many patients who will take long-term steroids. They will come with fracture. That is because of glucocorticoid induced osteoporosis. This is growth hormone. Growth hormone has it will also increase the bone remodeling. It will increase the both osteoblastic and osteoclastic activity, thereby increase the bone remodeling. GH deficiency patient will have very much decreased bone mineral density. And thyroid hormone. Thyroid hormone has a complex action on the bone. It will not act on the osteoclast straightly. It will act on the osteoblast. Through osteoblast, it increases the osteoclastic activity. Thereby, this will have effect on the chondrocytes and both osteoclast and osteoblast cells. And in thyrotoxicosis, there will be increased osteoclastic activity, increased bone turnover, and it can result in pathological fractures. This is what I was telling. In the first two decades, there will be formation of the bone, and they will reach the peak bone mass, and they will reach the menopause. After reaching the menopause, BMD decreases. If there is inadequate environmental factors in the form of decreased calcium, decreased vitamin D, delayed puberty, all these things will decrease the peak bone mass accrual, and thereby they will result in high fracture at the end of 5th or 6th decade. And how to diagnose osteoporosis? We will diagnose osteoporosis with the help of, if a person has fracture without BMD, we can tell the person is having osteoporosis, especially the spine and hip fracture. If T-score is less than -2.5, or if they have osteopenic range and they have fracture of proximal humerus, pelvis and distal forearm, and if they have high fracs, all these things are diagnostic points for osteoporosis in postmenopausal women. And there are multiple secondary causes for osteoporosis. I don't want to go into detail, but few things we should know. Diabetes can cause osteoporosis. Hyperthyroidism can cause osteoporosis, and all the cause of hypogonadism can result in osteoporosis. And all the CKD, CLD, everything can cause osteoporosis. And mandatory investigation which we have to do in all patients is calcium, phosphorus, alkaline phosphatase, RFT, LFT, PTH, vitamin D. And in case of secondary, if we suspect the secondary osteoporosis, for example, if we suspect myeloma, we have to look for ESR and M-band. For celiac disease, we have to look for the TTG. For hypogonadism, for men, we have to look for the testosterone. For women, we have to look for the estradiol levels. If we suspect Cushing syndrome, then we have to do ONDST for the patient. For diabetes, we have to look for the PPS and HbA1c. How we will assess the bone mineral density? We need DEXA scan for this. DEXA scan is dual energy X-ray absorptiometry. The radiation is very less for when we compare to the X-ray also, it's very less. And we will measure the areal density, that is we will measure as gram per centimeter square. Normal is T-score less than -1, more than -1. Osteopenia is -1 to -2.5. Osteoporosis is -2.5 or less. And there are multiple studies which showed that if BMD decreases, there is increased chance of fracture. This study shows that if BMD goes on increase, it will decreases the vertebral fracture and hip fracture. There are many pitfalls in BMD. If patient moves, BMD reports get altered, and if they have kyphosis, scoliosis, then also a result will get altered. If they have fracture, BMD will increase. If they have aortic calcification, then also BMD will get increased. If they have osteophytes, that also increases the BMD. All these things can affect the BMD results, and if they have any calcified node, then also BMD will get increased. If they have osteomalacia, that will decreases the BMD. And there is an important thing which we should know. It will measure the aerial BMD. It will not measure the volumetric BMD. Here we can see 3 cubes are there. And the last cube is, all these cubes have same bone mineral content. And we can see that if we measure aerial BMD, the last cube is showing a higher BMD, but same volumetric BMD in all the cubes. This also happen in DEXA. If bone is large, it will show higher BMD. If bone is small, it will have a lesser BMD. These are some of the pitfalls in DEXA. Then we will assess the risk of fracture in old woman using a FRAC score. This score we have to use in women more than 40 years of age. And we will get 2 results. One is 10-year major osteoporotic fracture risk or 10-year hip fracture risk. And VFA is vertebral fracture assessment. This will come with BMD. It's a software. It will detect the vertebral fracture. And we will do this for women aged more than 70, men aged more than 80 years. If there is height loss more than 4 centimeter, history of glucocorticoid intake, because glucocorticoid will predominantly, it will cause vertebral fracture, not hip fracture. Then one more, that is one more software is there, that is trabecular bone score. This will measure the bone will be measured as variogram, and it will detect the microarchitectural deterioration. This is very useful for diabetic patients, because diabetic patients will have increased bone mineral density, but they will have microarchitectural deterioration that will be diagnosed with the help of TBS. TBS will come with a normal value, partial degraded bone value or degraded bone value. And we can use it along with the BMD T-score. If the bone is degraded with the TBS and if they have osteoporosis, they have very high chance for fracture. Multiple studies which show the importance of TBS. And who and all should undergo bone mineral density testing? Age more than 60 years for women and men more than 65 years. Or if they have increased risk, they have history of fragility fracture before 50 years of age. If they have any secondary cause for fracture in the form of diabetes, rheumatoid arthritis, or they are taking glucocorticoids for long duration. How we can prevent the bone loss and fracture? First, we have to optimize the skeletal development, maximize the bone peak mass, prevention of falls and fracture, and how much calcium we should take. If a person got diagnosed with osteoporosis, how much calcium he should take is 1200 mg per day, and vitamin D they have to take 1000 to 2000 international units. And there are multiple studies which showed that if a person takes high dose vitamin D, it will result in reduction of fracture by 26% and 23% by non-vertebral fractures. If we see this study was done, this is a Women Health Initiative study. There they have seen around 36 women. They found that taking vitamin D along with calcium has no significant effect on the hip fracture, spine fracture, and total fracture. But there was increase in bone mineral density by just 1%. And few studies showed there is significant risk reduction for the fracture. Few studies shows there are no significant risk reduction. And this study showed that there is no risk reduction. Larger studies were showing some amount of fracture risk reduction if you use vitamin D. And this is vitamin D guidelines. This guideline shows that for 19 to 74 years of age, there is no need for empirical vitamin D. If they have deficiency, we have to treat them. If they have osteoporosis, we have to give to them. For normal person, there is no need for vitamin D, empirical vitamin D. Magnesium does not increase the bone BMD. Vitamin A taken in higher quantity is detrimental to the bone. Increased caffeine is detrimental to the bone. And alcohol increases the fracture risk. by decreasing the bone formation and increasing the falls. Smoking increase the metabolism of the estrogen, thereby causing the osteoporosis and fracture. And exercise will increase the BMD and helps in prevention of fractures. What are the indication to start osteoporosis therapy? If they have vertebral fracture, if they have T-score less than minus 2.5, if they have osteopenia with high fracs, and in diabetes mellitus patient, T-score less than minus 2. And ISBMR guidelines give a very nice guidelines. For vertebral fracture, they should start with teriparatide and followed by anti-receptive. And for hip fracture, we can use IV zoledronate. For high risk individual, we can use bisphosphonate. For osteoporosis with CKD, we can use denosumab. These are the drugs. It's a large list. And most commonly, we will use denosumab or zoledronate or teriparatide. All postmenopausal women, if they have a high risk or very high risk for fracture, we can either start bisphosphonate or denosumab or teriparatide. Bisphosphonates, oral agents include alendronate, ibadronate and risidronate. IV agents include the zoledronate or ibadronate. Maximum we will use alendronate or zoledronate. We can see the reduction in the fracture for zoledronate. It is 56% for vertebral fracture. For hip fracture, it is 42%. For non-vertebral fracture, it is 20%. For alendronate also, there is somewhat lesser quantity of fracture reduction is there. How these drugs acts? These drugs will inhibit the mevalonate pathway, thereby inhibiting the osteoclastic activity, thereby it reduces the bone resorption. These drugs are called anti-resorptives. And long-term therapy, we can use it, IV bisphosphonate we can use up to 3 years, oral we can use up to 5 years. If we use more than that, then a person can develop atypical femoral fracture or they can develop osteonecrosis of jaw. And there are multiple trials which showed that oral, if we use for 5 years and we stop the drug, there is some amount of BMD loss is there. IV also similarly, if we use and stop, there is some amount of bone loss is there. And when to consider drug holiday, which I said oral, for oral it is after 5 years, for IV it's after 3 years. What we have to do if we stop the drug? We have to look the BMD, bone turnover markers. And we have to restart the therapy if there is significant BMD loss, rising bone turnover marker, new fragility fracture, or if the risk becomes very high. Denosumab is a rank ligand. It's a monoclonal antibody against the rank ligand. It also acts as an anti-resorptive agent. It's given in the dose of 60 mg subcutaneous every 6 monthly. For denosumab, drug holiday is not recommended. Every 6 monthly we have to give the drug. If we stop the drug, there will be a rebound fracture. And fracture risk reduction is 62%, more than 60% for vertebral fracture, 39% reduction in the hip fracture, and a 20% reduction in the non-vertebral fracture. Calcitonin is for analgesia. It's not for osteoporosis. Even though FDA approved it for osteoporosis, the fracture reduction efficacy is very less for calcitonin. It will just reduce the pain. Raloxifene is used for reduction of high-risk breast cancer women. Here also only reduction is there for vertebral fracture but not for other fracture. And anabolic agents. Anabolic agents, there are two anabolic agents. One is teriparatide and another is abaloparatide, which we have to give daily. Maximum we can give up to 2 years. And there are multiple trials. All these trials showed there is increase in the vertebral BMD compared to the hip BMD. And bone turnover markers, there is no role for diagnosis of osteoporosis. It's only useful for monitoring and adherence of the treatment and to measure the treatment efficacy. There are two bone turnover markers. One is CTX and another is P1NP. For anti-resorptive therapy, we have to measure it at the baseline, 3, 6 and 12 months. For anabolic therapy also same. And if there is good anti-resorptive effect, there will be reduction in the CTX by more than 30%. or for anabolic therapy, if P1NP increase by more than 20%, that is also an indicator for good treatment. And take home message, osteoporosis, the prevalence is very high, but it's undertreated in our country. Osteoporosis leads to the fragility fracture, and it will result in bedridden state. Diagnosis is by DEXA, not by normal X-ray. Anti-disruptive or anabolic therapy based on the clinical profile of the patient. Prevention of fracture helps avoid a bedridden state. Thank you.
Thank you, sir. I request Dr. Sudarshan sir to share his insights regarding the session.
Thank you. It's a wonderful lecture, and you have covered almost A to Z, starting from the basic physiology, biochemistry, up not to the treatment. But I have few things which we encounter in our routine practice. Number one is, next to steroids and diabetes, what we see, most of the patient, they take PPIs. So on most of the PPIs are associated with osteoporosis and other things. So what's your experience?
Sir, it can decrease the absorption of the calcium. Thereby, if calcium absorption decreases, then PTH will increase. PTH will erode the bone, so it will result in osteoporosis, sir. But we cannot actually. We don't have BMD like DEXA machine in our region. It's only in Pondicherry. We have to send the patient to Pondicherry. But at least for old age patient, post-menopausal patient who are taking long-term PPA, we should do BMD measurement for the patients, sir.
So next is, we do the hormone replacement therapy for post-menopausal. We go to any orthopedician, all the patients with fracture, whether it is with the osteoporosis or without osteoporosis, they give the combination of calcium, calcitonin, vitamin D3 and other everything. So how many, what is the percentage of this hypercalcinosis related, say for example, stones and other things you have encountered?
Sir, actually, here also I mentioned one study. That study shows that there was around 20% increase in the that is increase in the renal calcium, and actually that study also said that if a person has a osteoporosis, then you can give calcium. If for normal patient, don't give calcium, like that it was mentioned, sir.
Without an investigation, we are not supposed to.
Yes, sir.
Okay. We had one drug called nandrolone. It was an anabolic steroid. Most of the orthopedists they used to give previously. So whether it is available or for all osteoporotic patients, can we give anabolics?
No, sir, anabolic in the form is here, anabolic means not anabolic steroids, sir. Anabolic means it's teriparatide.
Yes.
Actually, those drugs have no role, sir. Now we have very potent drug in the form of zoledronate. Zoledronate is not so costly, which we will give yearly once. That's around 5,000 rupees only, so it's not so costly.
So whether you are advising for all patients who have osteoporosis. Say for example, many patients we get fractures and menopausal, and most of them they will have diabetes, they will be taking PPA. Many patients with immunological diseases. So we have rheumatoid arthritis and other things. So whether you advise regularly for these patients?
Yes, sir. Actually, they are at risk of increased, if they have fracture, then it's indicated, sir, actually.
Now, to prevent fracture.
For prevention of fracture, we should do DEXA scan, sir.
So
We should do DEXA scan if they have either high FRAS score, or if they have very low T score, then we can start the patient on either anti-disruptive or anabolics.
Okay, thank you. Any questions from the audience? Thank you. Thanks
Thank
once
you,
again
sir.
for the wonderful lecture. Thank you.
Thank you, sir. I now invite our respected HOD ma'am to share a few words with us.
Good morning, all of you. Sir, we would like to thank you very much, sir, on the behalf of Department of Biochemistry, Kadalur Medical College, for having accepted to be a speaker instantly beside a busy schedule. So, sir beautifully covered from the basics to the total advanced. He talked about the preventive aspects and investigative aspects. Sir also cleared some queries. If any questions from audience, we can proceed. Any queries from the online audience? Okay. So, sir will be coming, sir. We'll soon start the inauguration. The interim, we shall have a small fun game. This is only for the final year MBBS students. They are only eligible to participate. No, final year MBBS. Can we include MLT also? Yes? Okay. Final year MBBS and MLT. Anybody who is sharp and fast will win the prize. Are the prizes ready to give instantly? Yes. Okay. Can proceed. So, Madam will tell about the guidelines.
Now I request Dr. Satyajitra ma'am to conduct a fun activity.
Here is a fun session. Exciting prizes are awaited. Next. Next. Before going to the fun part, here are some exclamatory features of Pheochromocytoma. It is an adrenal medullary tumor which has the features of certain tints. It is 10% malignant and bilateral. It is 10% extra-adrenal and found in children. It is 10% familial and incidental without hypertension. Now the game session starts. The rules for the games are, it is only for the MBBS final year students and MLT. Those who know the answer should get up and say BioEndora. Once called upon, they should come here and only then you should tell the answers. Are you ready? So you should be ready to answer. The questions are very easy. Those who know should stand up and say BioEndora, then we will call that particular person. Yes, you should find out these eyes. Only for students, ma'am. BioEndora, you should say, stand up and say BioEndora. Yes, come forward. Yes, get up. Hope your endorphins are kindled now.
If one person comes forward only, we can give the prizes. Otherwise, it will go to the admin only. Yes, cheer up. You introduce yourself first.
I am Jitendra Haryado, final year MBBS.
Yes.
First
one.
Naintara.
Second
is Samantha.
Okay, fine.
Third one Abdul Kalam.
Very good. The prize goes to your name, Pa?
Jitendra.
Jitendra. Hope your endorphins are kindled now. Thank you.
Thank you, ma'am. I am pretty sure our endorphins are very kindled. Thank you, Jayashree ma'am, for presenting the award.
Thank you, Dr. Satyajitra ma'am, for conducting this fun game in between the session.
May I request the audience to wait for a few minutes as we proceed to our inauguration. as there is a delay in proceedings of the inauguration ceremony, we will be now proceeding to the session 2. And we shall now proceed to our second scientific session titled PCOS Pearls. The topic for this session is diagnostics updates and emerging trends in PCOS. Polycystic ovary syndrome is one of the most common endocrine disorders affecting women of reproductive age, and with evolving diagnostic criteria and newer clinical perspectives, this session promises to bring us the latest updates and emerging trends in PCOS. To chair this session and introduce our speaker, we are honored to have Dr. M. Sudha Ma'am, MD PhD, Professor and Head of the Department of Physiology of GCMC&H, CHIDAMBARAM. I now invite our respected chairperson to kindly address the gathering and introduce the speaker. Over to you, ma'am.
So good morning. Good morning, one and all gathered here. First, I thank the organizing chairman, Biochemistry, for giving me an opportunity to chair the session. I am also very happy to chair the session of Dr. Jayashree, who was doing CRRA when I was a tutor in TB clinic. I was very much attached to OG department because I started my career in OG. And this topic is almost related to reproductive physiology. Just I want to... So she is alumni of Annamalai University. She completed her MBBS in 2002. She has 2 decades of teaching experience and has contributed immensely in academics, patients care and mentoring. She has played a key leadership role in healthcare services, including heading COVID hospital operations. I think she was a AMS for a few years and she was doing a good job during COVID time. And she is well known for her contributions in research, CME activities and maternal health, as well as rural outreach programs. And now I just call upon Jayashree to take over the session.
Chairperson.
Yes, before going to the session, I would like to invite Dr. Shanmupriya Ma'am, Senior Assistant Professor, Department of Biochemistry, Government Cuddle Medical College, to introduce our chairperson, Dr. Sudha Ma'am.
A very good morning to all the esteemed faculty, delegates, postgraduates and students present here. It gives an immense pleasure and pride to introduce the chairperson, Dr. M. Sudha Ma'am, Professor and Head, Department of Physiology, a teacher, researcher, administrator par excellence. Dr. Sudha completed her MBBS from Tanjore Medical College and pursued her MD and PhD from Annamalai University. Her academic journey reflects her deep commitment to the field of physiology and medical education. She is a prolific researcher with 19 international publications and 1 national publication in industry journal. She has won the first prize on an international conference for her scientific work. As an academician, she has a unique distinction in handling classes for UGs and PGs, shaping the foundation of multiple healthcare streams. She has served as PhD coordinator, MU coordinator, presently the MBBS coordinator, playing a pivotal role in UG medical education and curriculum implementation. With her vast experience in teaching, research and administration, her passion for integrated learning, Dr. Sudha is truly the right person to chair this session and guide our scientific discussion. Thank you, ma'am. Let us welcome her with a thunderous round of applause.
I now invite Dr. V. Jayashree Ma'am to enlighten us with a talk on diagnostic updates and emerging trends in PCS. Over to you, ma'am.
Good morning, everyone present here. I thank the Department of Biochemistry for giving me this opportunity. And I would like to, I'm feeling honored to be a part of the session in front of my teachers, Dr. Inmoli and Dr. Shanta Ma'am, and also Dr. Sudha Ma'am. Thank you. Today's the topic given to me is on PCOS. Diagnostic updates and emerging trends in PCOS. Today's objectives are to refine about the updated diagnostics. So the latest criteria and updated diagnostics, I'll come to the future slides, about emerging biomarkers, AI usage in PCOS and its clinical implications. Coming to the definition of PCOS, as we all know, it is one of the most common endocrine disorder in women of reproductive age, characterized by hyperandrogenism, ovulatory dysfunction, and polycystic ovarian morphology. It is also associated with metabolic syndrome, infertility, and long-term cardiovascular disease and psychological morbidity. The key epidemiological facts, the prevalence varies according to the diagnostic criteria. We have different diagnostic criteria. What we presently follow is the modified Rotterdam's criteria. According to that, the prevalence rate is around 18%. Next, we have the previously NIH criteria, National Institute of Health criteria was used. According to that, the prevalence is 8 to 12%, and Androgen Access Society, following that, it is only 10 to 15% of prevalence. It is more prevalent in South Asian, Australian, and Middle Eastern population, and in the urban setup, the incidence is on the higher side, and now you can see the rising trend of PCOS among the adolescents. Coming to the pathophysiology, the pathophysiology is still very controversial. We don't know where the beginning is. We don't know which is the primary defect, whether it is insulin resistance or hyperandrogenism or the HPO axis dysfunction, and definitely genetic and environmental interplay has a role. So for the sake of undergraduates, I think you all know about this menstrual cycle. So you have the menstrual phase or the follicular phase, and next is the luteal phase, and ovulation usually occurs around the 14th day of the menstrual cycle. What happens here is, so the primary okay. So there is a formation of primordial follicle. The follicle matures. By 14th day, around 14th day, there will be formation of dominant follicle, and the follicle ruptures. What happens after rupture of follicle? There is formation of corpus luteum, and the corpus luteum will start secreting progesterone. So as in short, the initial phase is taken care of by estrogen, that is the estradiol, and around ovulation there is an LH surge, and following that, the second half of the cycle is taken care of by progesterone, which is secreted by the corpus luteum. In the uterine endometrium, what happens? The uterus, the endometrium starts to grow in the initial phase because of the effect of estrogen. In the initial phase, it starts to grow, and after ovulation, the endometrium is also primed by progesterone. It starts to grow further, and when there is a progesterone withdrawal around 28 days of cycle, when there is progesterone withdrawal, the uterus, the endometrium starts shedding. So this is about the normal menstrual cycle. What happens in PCOS? So there are a lot of hormonal changes which occur in PCOS. So here the normal LH surge fails to occur. There is alteration of LH-FSH ratio. So the FSH starts falling, the luteinizing hormone is increased, and the usual estrogen which is present in the first half of the cycle is the estradiol. But estradiol is low in PCOS because the follicle maturation, what happens, you can see this diagram in follicular maturation. So you can see different stages of follicle compared to the earlier style. Here it matures and it ovulates. But what happens here? It does not have a mature follicle, and it fails to ovulate, and there is no corpus luteum, so no progesterone secretion. So similarly, the mature follicle does not secrete estrogen. It secretes estrone, and it is always in the higher side. So the whole cycle, whole menstrual cycle is taken care only by estrogen, and there is very less progesterone which is present. So what happens? The endometrium starts growing and growing. So it is fully taken care of by this estrogen and very little amount of progesterone. So the estrogen continues to make the endometrium grow, and it fails to shed around 28th day of the cycle. So the typical menstrual cycle of a PCOS lady, how does they say? They will have prolonged menstrual cycle. So the menstrual cycle, they will get they will not get once in 28 days as any other girl. So they will have menstrual cycle every 35 days, 40 days, every 2 months, 3 months, it can, because the endometrium keeps growing because the progesterone is not there. So the endometrium keeps on growing. At one point of time, the endometrium stops getting the blood supply and sheds on its own. After shedding, they will have prolonged bleeding because the progesterone is not being supported. They will have a typical bleeding once in 2 to 3 months, and the bleeding will last for around 10 to 14 days without, and it might need medical treatment to stop the bleedings most of the times. This is the typical menstrual cycle in PCOS. So coming to the pathophysiology, as I told, it is quite controversial. The main cause is peripheral insulin resistance. So what happens because of the peripheral insulin resistance? There is compensatory hyperinsulinemia. So whenever there is insulinemia, hyperinsulinemia, it acts on the theca cells of the ovary. It acts on the theca cells of the ovary. So it will start producing increased androgens. So the androgen production from the theca cells of the ovary is increased. So the peripheral androgens are more. So when there are increased androgens, so normally also there will be presence of androgens in the women, but that will be peripherally converted to estradiol. So whereas here the androgens are so high that it is usually not getting converted, and there will be increase in the number of free androgens. So this free androgens is also because the liver fails to secrete sex hormone binding globulin. Even it secretes, but the sex hormone binding globulin levels are quite less compared to a normal woman. So the sex hormone binding globulin is less, so the androgens are not bound to sex hormone binding globulin, and there is an increased amount of free testosterone which is circulating. So they will end up in having clinical features of hirsutism or acne. So, and what happens because of the increased LH, it also has the ovarian, it acts on the ovarian stroma. So there will be the follicle arrest. I told the menstrual cycle, the follicle maturation does not occur, the follicle stops growing. So there will be follicular arrest. You can see multiple follicles in the ovary, and the ovarian stroma also increases. So the ovarian volume increases, the ovarian volume increases, the number of follicle in the ovary all increases, which all adds on to the problem, causing increased androgen production and hyperandrogenism. So because of the hormonal imbalance, because of the hyperandrogenism, which is because of raised testosterone and reduced amount of sex hormone binding globulin, increased insulin resistance, the PCOS features are there, which is evident as hirsutism acne, or reproductive features. Because of that, they will have oligoanovulation, irregular menstrual cycle, and subfertility, and metabolic features also will be present. So what is this evolution of diagnostic criteria? So there is a paradigm shift from precision inclusion and evidence-based now. So it was in way back in 1990, National Institute of Health has given these two criteria only, hyperandrogenism and anovulation. So what happened is, in the initial phases in 1990, the usage of ultrasound was not so high. It was not present everywhere, and it was not used very frequently. So the main parameters which were considered were clinical and biochemical markers. So the clinical markers, they will have clinical features of anovulation, clinical features of hyperandrogenism, all these were present, and along with that they will have irregular cycles, and all these will be considered according to the National Institute of Health in 1990. It was evolutioned by Rotterdam criteria in 2003. What happened in 2003? Ultrasound usage was increased. The ultrasound marker was also taken into consideration. Here, the number of follicles per ovary, if it is more than 12 per ovary, it was considered as a polycystic ovarian morphology. So if 2 out of these 3 criteria, one is hyperandrogenism, anovulation, and ultrasound criteria, if out of these 3, if 2 were present, Rotterdam criteria was fulfilled. So the Rotterdam criteria is presence of 2 out of 3 criteria. And it was further evolutioned to 2023 guidelines, which is more refined and evidence-based approach. This is about the recent 2023 guidelines. Normally, when there is a menstrual cycle, normal menstrual cycle, she will ovulate every cycle, and they will have menstrual cycle at least 12 cycles per year. If this a cycle is less than 8 cycles per year, it is considered as oligo-ovulation or anovulation. And if there is any clinical or biochemical evidence of hyperandrogenism. So if there is any evidence of hyperandrogenism, that is presence of hirsutism, that is abnormal hair growth in the body, presence of acne, or biochemical changes, that is increased elevation of free testosterone or dihydroepiandrosterone, or presence of polycystic ovarian morphology by ultrasound. So if there is any polycystic morphology by ultrasound, or recently we consider elevated anti-Mullerian hormone as the recent development in PCO, that can replace ultrasound if it is done by a proper assay. And the diagnosis is made if any of the two is present out of these three. So it can be oligo or anovulation, polycystic ovarian morphology, or clinical or biochemical evidence of hyperandrogenism. If PCO can replace, PCO morphology can be replaced by elevated anti-Mullerian hormones in the recent developments. That is the recent development for assessing the PCOS criteria. This is the current diagnostic criteria. So how do we diagnose PCO? So first we have to take a detailed history from the patient. So usually the menstrual history is very important. So you ask about how many cycles she gets per year, how frequently she gets her cycles, how long the cycles last, any history of infertility or pregnancy loss. So this is the basic history which has to be taken from the patient. Next is the clinical evaluation. Clinical evaluation, the most important is hirsutism. Look for hirsutism. That is abnormal hair growth, male pattern of hair growth. So that is assessed by Ferryman-Galloway score. So I'll come to that in the next slides. And look for acne, alopecia, male pattern alopecia, and acanthosis nigricans. So acanthosis nigricans is the discoloration of the nape of the neck or near the axillas or in the groin areas. So it is because of it is a sign of insulin resistance. So if there is discoloration in any of these areas, it is called as acanthosis nigricans. You can see many of the obese women who have discoloration in the nape of the neck. So this is a typical feature of insulin resistance called as acanthosis nigricans. And you have to look for waist circumference and body mass index. So all these signs of hirsutism, insulin resistance, and hyperandrogenism has to be looked for in clinical examination. Next is the hormonal profile. Hormonal profile, the ideal and the most important is the free testosterone levels. Normally there will be testosterone, but because of the reduced production of sex hormone binding globulin, the amount of free testosterone will be more. So you have to look for free testosterone. Assessment of LH and FSH, it is not directly a marker, but the ratio of LH to FSH is important for PCO. And look for prolactin, thyroid stimulating hormones, 17-hydroxyprogesterone, and AMH levels. All this for excluding other conditions. The metabolic screening, because these patients are more at risk for developing metabolic disorders later in their life because of they have persistent hyperinsulinemia. So they have to screen for all, they have to be screened for all metabolic conditions, do oral glucose tolerance test, lipid profile, blood pressure, and insulin levels if indicated. And imaging is routinely done. A transvaginal ultrasound is more significant, more accurate in all these cases. If the patient is not married, then you can still go ahead with the abdominal ultrasound. So endometrial assessment by ultrasound is also needed if indicated, because if they have persistent or a very severe PCO, they are more prone for endometrial hyperplasia. So this has to be evaluated. Exclusion of other conditions. So you have to have a differential diagnosis, rule out other conditions like thyroid dysfunction, hyperprolactinemia, congenital adrenal hyperplasia, or any androgen secreting tumors. All this have to be ruled out because you have to rule out other conditions before coming to the diagnosis of PCOS, because all these conditions also will have features of hyperandrogenism. This is a Ferryman-Galloway score for assessing the hirsutism in women. This is to assess the extent of abnormal hair growth in women. All these areas has to be assessed: face, chin, chest, arms, upper and lower back, and abdomen. All this has to be assessed. A total of more than 8 is considered hirsutism. These are the different phenotypes of PCOS. So they present it in 4 different phenotypes. So phenotype A is the full blown PCOS. They have all the 3 characteristics: oligoanovulation, hyperandrogenism, and classic features of PCO morphology in ultrasound. So this is by phenotype A. And phenotype B is you have only hyperandrogenism and anovulation. And phenotype C, it is ovulatory PCOS. Phenotype D is non-hyperandrogenic. So this is the comparison table of all the phenotypes. So phenotype A is has all the conditions, both hyperandrogenism, ovulatory dysfunction, and polycystic ovaries. They have high metabolic risk. The fertility issues are high, and the cycles will be irregular. Whereas in phenotype B, the polycystic ovarian morphology will be absent, but compared to phenotype A, the metabolic risk is slightly lower. In phenotype C, usually they are all, they have no ovulatory dysfunction. They have considered as lean PCOS. Even lean patients can have PCOS. So phenotype C is usually lean PCOS. Phenotype D, here there are no hyperandrogenic features. So these patients will present to us very late because they don't have hyperandrogenic features. The cycles will be irregular. They will not have much fertility issues. So they present to us very late. The clinical features, clinical pearls, highest risk will be for A and B phenotype because you have to go for rule out metabolic risk also. Lean PCOS is usually phenotype C. Missed cases are phenotype D because there are no androgen complaints, and fertility issues are mainly for A and B. Adolescent PCOS, the diagnosis is very tricky, and this diagnosis is very important because lot of adolescent girls come to us with irregular cycles. So what the main criteria which we have to remember is, so in the adolescent stage, because of the immature hypothalamo-pituitary axis, there will be irregular cycles in the immediate menarcheal stage. So whenever, as soon as the girl attains menarche, the periods will be irregular for at least a minimum of 2 years. So if the patient has persistent menstrual irregularity, even after 2 years of post-menarche, that is considered as abnormal. It is considered either anovulation or irregular cycles. So along with that, if the patient has hyperandrogenism, any features of hyperandrogenism, acne, hirsutism, acanthosis nigricans, all this will be considered as PCOS. So here in this patient, adolescent women, ultrasound is not frequently recommended because they have just attained menarche. The number of follicles will be more for them. So when you do an ultrasound, it is quite confusing. So just by history and by doing a biochemical marker and a clinical marker for hyperandrogenism, you can diagnose PCOS. So it is diagnosed only after 2 years post-menarche. So this is a recent development in PCO according to the 2023 guidelines. So AMH, usage of anti-Mullerian hormone, is used as a diagnostic tool and an alternative to ultrasound. So, but this can be considered as an alternative only if a proper assay is being used and it replaces the older cutoffs. So if the level is 3.4, more than 3.4, it is considered as diagnostic tool. It is not cycle dependent, and it correlates with the follicular number per ovary. It replaces only if the good assay is being followed. Here the only limitation is there is no universal cutoff. It cannot be used in adolescents. If you do a AMH for an adolescent girl, the AMH levels will be high because the number of follicles will be more for her. So it is affected by age, obesity, and if there is usage of oral contraceptive pills. So it can be used as a diagnostic tool, but it is not the sole diagnostic tool. It can replace ultrasound if it is, if a proper assay can be used. Higher AMH indicates follicle excess, but definitely not better fertility. It correlates with antral follicle count. Very high AMH has the risk of ovarian hyperstimulation syndrome in conditions where they use in vitro fertilization. Normal AMH does not rule out PCOS. These are the recent imaging advances. We come across usage of high resolution ultrasound, 3D ovarian imaging, and the usage of standardized follicle counts. So this is the updated criteria for ultrasound. The previous criteria is more usage, the number of ovarian follicles, if it is more than 12 in number in a single ovary, it is considered as polycystic ovarian disease. But now the recent criteria is more than 20 follicles by high resolution ultrasound. So this is a picture of ultrasound picture of an ovarian follicle where you can see the string of pearls appearance, or otherwise called as a necklace pattern. So this is a typical feature of polycystic ovarian disease, where you see more than 20 follicles per ovary, and the ovarian volume should be more than 10 milliliter. So it is only diagnosed by high resolution ultrasound compared to less than 12 follicles in the previous data. So to diagnose PCOS, you have to use Rotterdam criteria. It should not be relied only on ultrasounds in adolescents because the number of follicles are more. OCPs can underdiagnose PCOS because the number of follicles will be suppressed. Transvaginal ultrasound is usually preferred compared to transabdominal ultrasound, and the most sensitive marker is follicular number per ovary by ultrasound. The management algorithm is, so whenever you get a patient with PCOS, you have to assess her goal, why she has come to you, whether it is because of fertility issue, whether it is cosmetic, or it is because of metabolic issues, or any anovulatory issues. You find out why she has come to you and treat accordingly. So first and foremost important management in PCOS is lifestyle modification. So that is the main treatment, and following that, if the patient needs cycle control, if the patient has irregular cycle, you have to go for cycle control by using combined oral contraceptive pills. You can use 3rd generation or the 4th generation or contraceptive pills like cyproterine acetate, which has less anti-androgenic effect because already the androgen levels are more. Here we have to use anti-androgenic contraceptive pills. If the patient has insulin resistance or if the BMI is more, then you can add metformin for such patients. Hyperandrogenism, again, anti-androgens, combined oral contraceptives can be used. If for hyperandrogenism, spironolactone or finasteride can be used. In infertility, the first choice of drug is letrozole, an aromatase inhibitor. And if it fails, you can go for clomiphene citrate. Still fails, artificial reproductive techniques can be used. So we should never miss about the psychological aspects in these individuals. We're not just treating the pharmacological causes, we have to look for psychological effects. Because of these hormonal changes, they will have neurotransmitter changes, they will have mood disturbances, because of the body image, because they will have hirsutism, obesity, they will have low self-esteem, anxiety and depression. All this has to be taken care by holistic approach. So they will have fertility and relationship impact, fear of fertility, marital stress, and they will have social pressure. The red flags never has to be missed. They will have sleep disturbances, social withdrawal, eating issues, and sadness. So all this has to be taken care by proper counseling. So always screen mental health in PCO patients. Psychological impact is usually underdiagnosed. You have to treat both physical and emotional aspects. These are the biomarkers which is used in PCOS. Hormonal, you have to do luteinizing hormone, follicular stimulating hormone, free testosterone levels, Metabolic, you have to look for signs of insulin resistance, do a oral glucose tolerance test and fasting glucose. Inflammatory markers, which is recently on the trend, CRP, interleukin 6, tumor necrosis factor alpha. The new genetic and the epigenetic markers are androgen receptor gene and insulin receptor gene. The diagnostic challenges which we face in PCOS is, it is a heterogeneous disorder because most of the patients will be asymptomatic or they will have a severe disease. So each one has to be treated differently, and there are a lot of ethnic variation, and most often it is underdiagnosed. So this is about artificial intelligence. It combines both clinical and biochemical data. Early detection can be possible. The challenges are it requires validation and standardization. The future directions are precision medicine, AI-assisted diagnostics, biomarker-based classification, and screening programs. So these are the emerging supportive management trends. Inositol therapy. Usage of inositol reduces the insulin resistance. It improves the insulin sensitivity. Ovulation rate is higher. Metabolic parameters are better. Usage of this GLP agonist for obesity. It promotes weight loss. Again, improves the insulin resistance. Usage of biomarkers for individualized patients can be used, and there is a research on gut microbiome as it also plays a role. This is a recent trend for the sake of postgraduates. Previously, laparoscopic ovarian drilling were commonly used few years back, but it is totally obsolete nowadays because it is done under general anesthesia. But this is a recent trend called as ovarian rebalancing. It is an alternative to laparoscopic ovarian drilling, but this is done in an OP procedure. It is a daycare procedure. It is done by using ultrasound guided. Only the selected stromal is being ablated. Whereas when you do laparoscopy, the ablation was more, even the normal follicles were injured, and there were a lot of adhesions. So to avoid this procedure has been in the research. Still it has not come up in many countries. Abroad it is being followed, but here it is still not being followed. But it is not done for all patients. It is done for patients who are not responsive to medical management. So when we do this, the stroma is being damaged, and because of that, there will be reduced androgen production. Take home message, it is not just hormonal, it is a metabolic, psychological, and social disorder. Diagnosis is not with just those 3 criteria, it evolves beyond Rotterdam criteria. AMH and AI are future tools. Early intervention reduces long-term risk. So there is a need for age-specific criteria because the same criteria cannot be used for adolescent girls. And the holistic care improves the outcomes. It is not just pharmacological care. The holistic care improves outcomes. Just a few questions on PCOS for the undergraduates. 22-year-old woman presents with irregular cycles, acne and hirsutism. Her body mass index is 28. Ultrasound shows polycystic ovaries. What is the most appropriate diagnostic criteria which is used? Rotterdam criteria. Adolescent PCOS, a 15-year-old girl presents with irregular cycles since menarche. So she has attained menarche just 1 year back. Has mild acne. Does she come under the criteria of PCO? No. When does she come? After 2 years. After 2 years. Infertility, a 28-year-old woman with PCO presents with infertility. Which is the first line of drug? Yes, letrozole is the first line of drug. AMH interpretation, just a patient has a high AMH levels but with normal cycles. She does not have any other complaints. Does she confirm PCO? No. Just pure increase in the AMH level does not confirm PCOS. Only if it is present with features of hyperandrogenism or features of polycystic ovary or irregular cycles or anovulation, it will lead on, it will make the diagnosis of PCOS. Thank you for patient listening. Thank you.
Thank you,
Thank
ma'am.
you for the opportunity given.
Thank you, ma'am, for those pearls of wisdom on PCOS. This session has truly enriched our understanding and updated clinical diagnostic approach. And thank you, ma'am, for enlightening us on new innovative approach of using AMH and artificial intelligence towards the diagnosis and treatment of PCOS. Thank you, ma'am. May I now request our chairperson.
Good morning, ma'am. Ma'am, from online participant, we have one question, ma'am. They've asked, like, what is the pathophysiological mechanism by which insulin resistance leads to acanthosis nigrans, ma'am?
So because of the insulin resistance, there will be increased production of androgens from the ovary. So it acts on the theca cells of the ovary. It leads to increased androgen production. Not only that, it also leads to decreased sex hormone binding globulin from the liver. So the liver normally produces sex hormone binding globulin, but in patients with insulin resistance, the sex hormone binding globulin is less, is produced less. So the bound testosterone is less. So the free testosterone is more. We are worried more about the free testosterone, which leads to hyperandrogenism in PCOS.
Thank you, ma'am.
So I congratulate Jayashree for her elaborate presentation on PCOS. Initially started with the etiology, pathophysiology, diagnostic tools and recent advances. And we are going to diagnose PCOS. But I have a question that whether we are over-diagnosing PCOS in all people, because whenever they come for irregular cycles, no, we'll name them as PCOS. We'll go
that is what is happening many a times, ma'am. It is either over-diagnosed or under-diagnosed. Only if either of this, out of 3 criteria, if only 2 is met, it will come under the diagnosis of PCOS.
So once we diagnose PCOS, we are going to treat. What is the way of prevention? That is better.
Prevention is only mainly by lifestyle modification, ma'am. That is the main prevention. Definitely, the genetic predisposition has a role, but lifestyle modification is the main treatment for PCOS. Obesity is the main factor. That itself will lead on to insulin resistance.
So before they attain puberty itself, during the childhood itself, or in the pediatric age group, you have to advise the diet or
lifestyle modification has to be incurred to the premenarcheal women.
Okay, thank you. It's open for discussion. Anybody?
Good morning, ma'am. That was a detailed discussion about the PCOS. I have a doubt regarding the hirsutism. If there is a treatment, if the treatment is proper treatment is given for the patient, will the hirsutism also subside subsequently?
No, so no, the hirsutism, already the growth of hair will be present. That will not be corrected. So it can just correct the further progression of the disease. So already the hirsutism will be, the presence of facial hair will not disappear, but further progression definitely can be prevented. But this can be done only by cosmetic treatment.
Okay, ma'am. Thank you so much.
Thank you very much, ma'am, for the very insightful session. We'll now proceed into our inauguration ceremony and welcoming the dignitaries.
Good morning, all. We are very honored to have in our esteemed presence our Dean, sir. And our medical superintendent, sir, Dr. N. Junior Sundaresh, sir. Our academic vice principal, Dr. S. Sasikala, ma'am. Our vice principal, administration, Dr. Balaji Swaminathan, sir. And our organizing chairman, Dr. K. Tamilmani, ma'am, professor and HOD of Biochemistry, Government Cuddler Medical College. Now we will listen to the narration by Dr. Anita Shri, ma'am, Senior Assistant Professor, Department of Biochemistry, Government Cuddler Medical College. Over to you, ma'am.
காலை வணக்கங்கள். நமது பெரும் மதிப்பிற்கும் மாண்புக்கும் உரிய கல்லூரி முதல்வர் அவர்களின் பணி நிறைவை போற்றும் நிமித்தமாக நடைபெறும் இந்த சிந்தனை சபைக்கு ஆன்றோர் சான்றோரை அழைத்து மகிழ்கிறேன். சிதம்பரத்தின் புராதன சிறப்புக்கும் நமது சிஎம்இக்கும் ஒரு இணைப்பு உண்டு. யோகக்கலையை உலகுக்கு அளித்த பதஞ்சலி முனிவரும் வியாக்கிரபாத முனிவரும் பரமசிவனின் ஆனந்த நடனத்தை காண விரும்பி கடும் தவம் ஏற்றினர். அவர்கள் தவத்தின் பயனாக சிவபெருமான் அருள் புரிந்து சிதம்பரத்தில் தனது ஆனந்த தாண்டவத்தை காணும் பாக்கியம் அளித்தார். இந்த ஆனந்த தாண்டவம் உடலின் ஆற்றல் மையங்களான 7 சக்கரங்களுடன் மெய்ஞான தொடர்பு உடையது. இந்த 7 சக்கரங்களும் 7 முக்கிய உள் சுரப்பிகளுக்கு ஏற்ப ஒத்து போகின்றன. முதல் சக்கரமான மூலாதாரம் கோனட்ஸ்களை உள்ளடக்கியது. இரண்டாவதான சுவாதிஸ்தானம் அட்ரினல்ஸ் கிளான்ஸையும், மூன்றாவதான மணிப்பூரகம் பான்க்ரியாசுடன் தொடர்புடையது. அநாகதம் என்னும் 4வது சக்கரம் தைமஸையும், விஷுத்தம் என்னும் 5வது சக்கரம் தைராய்டையும் ஒற்றி இயங்குகிறது. 6வதான ஆங்ஞை சக்கரம் பீனியல் கிளான்ஸையும், 7வதான சஹஸ்ராரம் பிட்யூட்டரியும் சார்ந்தது. ஆனந்த தாண்டவத்தின் டைனமிக் பேலன்ஸ் எனப்படும் இடையறாத இயக்கம் சக்கரங்களின் செயல்பாடுகளையும் ஹார்மோன் உற்பத்தியையும் சரியாகவும் சீராகவும் இயங்க வைக்கிறது. இதனால் உடலின் நியூரோஎண்டோக்ரைன் மற்றும் இம்யூன் தொடர்புகள் சமநிலை அடைகின்றன. ஆடலரசரின் ஒருமுனையான ஆற்றல் முழு அண்டத்தையும் கட்டுப்படுத்துவது போல நமது எண்டோக்ரைன் சிஸ்டம் மனித உடலின் இயக்கத்தை நுட்பமாகவும் சக்தியோடும் கட்டுப்படுத்துகிறது. சிறிய ஹார்மோன் மாற்றங்கள் கூட பெரிய உடல் உபாதைகளை உண்டாக்கிவிடும். நமது எண்டோக்ரைன் கிளான்ஸின் சாலச் சிறந்த செயல்பாடுகள் ஆனந்த தாண்டவத்தின் சர்வ வல்லமை நிறைந்த பேராற்றலை நமக்கு நினைவூட்டுகிறது அல்லவா? இதோ நமது சிஎம்இயின் ஒரு சிறு கண்ணோட்டம் உங்களுக்காக.
Yes, now we'll proceed to Dean's as AV.
மகிழ்ச்சி.
We invite our honorable dignitaries to the dais. I kindly request our dignitaries to come forward and take their seats on the stage. I kindly request our beloved Dean Sir to come forward to the dais. I request Dr. Junior Sundaresh Sir, our medical superintendent, to come forward. I request Dr. Balaji Swaminathan Sir, our Vice Principal Academic, to come forward. I request Dr. S. Sasikala Ma'am, Vice Principal Academic, to come forward. And I request our organizing chairman, Dr. Tamilmani Ma'am, to come forward and grace the dais. Thank you, ma'am. Thank you, sir.
As we begin for proceedings, we kindly request everyone to please rise and stand for the Tamil Thai Valthu.
நீராரும் கடலொடுத்த நிலமடந்த கெழிலொழுகும் சீராரும் வதனமென திகழ்பரத கண்டமிதில் தெக்கணமும் அதிசிறந்த திராவிடன திருநாடும் தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனகே தமிழனகே உன் சீரிழமை திறம்பி எந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Thank you all. Please be seated. That was a heartfelt Tamil Thai Valthu, setting a positive and reverent tone for today's session on the topic Endocrine Epic.
Ladies and gentlemen, we now proceed to the highlight of our morning to make the auspicious beginning of today's program. We shall proceed with the traditional lighting of the Kuthuvilakku. May I kindly invite our esteemed dignitaries on the dais to come forward and light the lamp, invoking blessings for the success of this event. Thank you all. It is a privilege to welcome our organizing chairman, Dr. K. Tamilmani ma'am, professor and at OD of Department of Biochemistry, to deliver the welcome address.
அனைவருக்கும் இனிய காலை வணக்கம். பஞ்சபூத தலத்தில் ஒன்றாக விளங்கும் ஆகாய சலத்தின் இந்த சிறப்பு நிகழ்வுக்காக நாம் அனைவரும் இன்று ஒன்று கூடியுள்ளோம். ஆதியும் அந்தமும் இல்லா ஆகாயம் போன்று நாம் காண முடியாததெனினும் நம்மை கட்டுப்படுத்தும் ஹார்மோன்களை பற்றிய தொடர் மருத்துவ கல்வி நிகழ்வுதான் இந்த BioEndora ஆகும். எண்ணிய எண்ணியாங்கு எய்து எண்ணியார் திண்ணியர் ஆகப்பெறின். ஒரு செயலை செய்ய நினைத்தவர் அந்த செயலை செய்து முடிப்பதில் மன உறுதியுடன் இருந்தால் அவர் எண்ணியபடியே எண்ணியவற்றை அடைவார். இந்த குரலுக்கு ஏற்றாற் போன்று மிக சிறப்பாகவும் சுறுசுறுப்பாகவும் இயங்கிக் கொண்டிருக்கும் மற்றும் இந்த நிகழ்வுக்கான காரணமாக விளங்கும் நமது கல்லூரி முதல்வர் அவர்களை அகமகிழ்வோடு வருக வருக என வரவேற்கிறோம். அவருக்கு உறுதுணையாக பணியாற்றி கொண்டிருக்கும் நமது MS சார் அவர்களையும் மிக்க மகிழ்ச்சியோடு வரவேற்கிறோம். எங்களுக்கு அனைத்து வகையிலும் வழிகாட்டுதலையும் ஒத்துழைப்பையும் நல்கும் VP சார் அவர்களை அன்போடு வரவேற்கிறோம். மன மகிழ்ச்சியோடு இந்த அழைப்பை ஏற்று வந்தமைக்கு VP மேடம் அவர்களையும் அன்போடு அழைக்கிறோம். இந்த நிகழ்வுக்கு இன்றியமையாத பேச்சாளர்களாக இருக்க இசைவு தந்து இங்கு வந்திருக்கும் சிறப்பு விருந்தினர்களையும் வருக வருக என வரவேற்கிறோம். இவ்விழாவில் பங்கேற்பதற்கு தமது அரிய நேரத்தை ஒதுக்கி அயராத பணிகளுக்கிடையே வந்திருக்கும் TNMC அப்சர்வர் அவர்களையும் அனைத்து துறை தலைவர்கள், பேராசிரியர்கள், இணை துணை பேராசிரியர்கள், இளநிலை முதுநிலை மாணவர்கள், ஆய்வக நுட்புணர்கள், மருத்துவ பணியாளர்கள் அனைவரையும் அன்போடு வரவேற்கிறோம். மேலும் இந்த நிகழ்வை காணொளி மூலம் பங்கேற்கும் அனைத்து மருத்துவக் கல்லூரியின் துறை தலைவர்கள், பேராசிரியர்கள், இணை துணை பேராசிரியர்கள் மற்றும் முதுநிலை இளநிலை மாணவர்களை மகிழ்ச்சியோடு வரவேற்கிறோம். இந்நிகழ்ச்சி நம் அறிவை விரிவுபடுத்தும், அனுபவங்களை பகிரவும், திறமைகளை மேம்படுத்தவும் இது ஒரு சிறந்த வாய்ப்பாக அமையும். இந்த நிகழ்வுக்கு வந்திருக்கும் அனைவரையும் நன்றி கலந்த அன்போடு வரவேற்று எல்லோரும் நலமுடன் வாழ எல்லாம் வல்ல இறைவனை பிரார்த்தித்து விடைபெறுகிறேன். On behalf of Department of Biochemistry, Kadalur Medical College, we welcome one and all. Thank you so much.
Thank you, ma'am. Thank you, ma'am, for that warm welcome address and for setting the vision for today's CME. It is now time to honor our legendary dean, our leader, mentor, and inspiration to all of us. We felicitate Dr. K.U. Suresh Balan, sir, Dean of Government Kadalur Medical College and Hospital, on a superannuation with deep respect and heartfelt gratitude. I request Dr. Tamilmani ma'am, HOD of our department, to felicitate our dean, sir. I request Dr. Saravanan sir, Assistant Professor of Department of Biochemistry, to felicitate our Medical Superintendent, Dr. N. Julie Sundaresh sir. I request Dr. Prasanna Balaji sir, Senior Assistant Professor, Department of Biochemistry, to felicitate our Vice Principal Administrative, Dr. Balaji Swaminathan sir. I request Dr. Gayatri ma'am, Associate Professor, Department of Biochemistry, to felicitate Vice Principal Academic, Dr. Sasikala ma'am. I request Dr. Sasikala ma'am to felicitate our HOD, Dr. Tamilmani ma'am. I request our Dean sir to felicitate Dr. Arunathan sir, Consultant Endocrinologist from Dhanalakshmi Srinivasam Medical College. request our Dean Sir to felicitate Dr. Nandisha Sir, Professor of Department of Biochemistry, Jipmar, Puducherry. I request Dean Sir to felicitate Dr. Ramanathan Sir. I request Dean Sir to felicitate Dr. Ramanathan Sir, HOD Department of Pediatrics. I request our HOD Ma'am to felicitate Dr. Jayashree Ma'am. I also request our Dean Sir to felicitate Dr. Sarvanan Sir and Dr. Veermani Sir in recognition of their distinguished years of dedicated service and invaluable experience. I request our Dean Sir to felicitate our chairperson, Dr. Sudha Ma'am. I request our Dean Sir to felicitate our chairperson, Dr. Tamilmani Ma'am. I request our Dean Sir to felicitate Dr. Dharani Ma'am, Professor and HOD of Anatomy Department. Judge for our competition held in our department for MLT students. I request our Dean Sir to felicitate Dr. Sarvanan Sir and Veermani Sir in recognition of their distinguished years of service and invaluable experience. I also request our Dean Sir to felicitate Mr. Ganapati and Mr. Murugabas for their unwavering support and who acts as a pillar of our department. I also request our Dean Sir to felicitate our senior lab technicians, Mr. Selvam, Mr. Muthukarpaya Sir, and Mr. Sankaravadivelin for their dedicated service for clinical lab. also request our Dean Sir to felicitate our female lab technicians, Mrs. Uma Mageshwari and Mrs. Sumitra, for their assistance towards special investigations. I also request Dean Sir to felicitate one of the pillars of our department, Mr. Tilak, Mr. Veeramani, Mrs. Devaki and Mrs. Selvi, for their sincere and hard-working help towards us. I now request the Dean Sir to and delegates to distribute prizes for the model making and drawing competition held at the department for MLT students. The eminent judge for the model making and drawing competition is Dr. Dharani Ma'am, Professor and HOD of Department of Anatomy. The winners of model making are:
The first prize goes to Mohammed Hassam, third year MLT student. The second prize goes to M. Aishwarya, third year MLT student.
I request Dr. Dharani Ma'am to grace the dais.
For drawing competition, the first prize is backed by J. Keertana, second year MLT. The second prize goes to M. Namita, second year MLT. The third prize goes to AE Dilli Raja, MLT intern.
Thank you all. Thank you to all our dignitaries for this warm and memorable felicitation. I now request our medical superintendent, Dr. N. Junior Sundaresh Sir, to deliver a few words.
அனைவருக்கும் காலை வணக்கம். மாசல் வினயம் மாலை மதியமும் வீசு தென்றலும் வீங்கில வேனிலும் ஊசு வைகை போன்ற வீச இந்த நிலையிலே அவரின் திசை நோக்கி என்னுடைய உரையை தொடங்குகின்றேன். பெருமதிப்புக்குரிய நமது விழா நாயகன் டீன் சார் அவர்களே மற்றும் துணை முதல்வர் அவர்களே மற்றும் பல்வேறு துறை தலைவர்களே, மாணவர்களே, மாணவிகளே, இந்த ஈவெண்ட் வந்து ஆப்டாக நடந்திருக்கு. குமரியிலிருந்து இந்த தில்லைக்கு வந்திருக்கின்ற நமது முதல் வந்து அலுமினி வந்து நம்ம அலுமினி ஃபஸ்ட்டு அதுக்கே ஒரு பெரிய கரகோஷம் இருக்கணும். சரியான நபருக்கு சரியான நேரத்தில் பாராட்டு. வந்த முதல் நாள் அப்படின்னு ஒரு பாட்டு இருக்குது. அது மாதிரி வந்த முதல் நாளே முதல் கையெழுத்து போட்டு அடுத்த நிமிஷமே நம்ம எந்த டீன்னு நினைப்போம். ஞாயிற்றுக்கிழமை கரெக்டாக காலையில் வந்து பதிவேற்ற நாள் ஞாயிற்றுக்கிழமை கரெக்டாக ஒரு 10:30 மணிக்கு திடீர்னு எங்களுக்கு அழைப்பு வந்தது. இந்த மாதிரி சார் வர்றாங்கன்னு. சரி, எப்படி இருப்பாங்கன்னு நம்மளுக்கு தெரியாது. எப்படி இருப்பாங்க அப்படின்ட்டு வந்த உடனே கையெழுத்த போட்டு சார் போகலாமான்னாரு. எங்கே சார், வீட்டுக்கு தான் போகலாமான்னு நினச்சோம். சரி, எல்லாம் ரெடியாக கிளம்பிட்டோம். ஞாயிற்றுக்கிழமை ஆச்சு, வீட்டுக்கு போகலாமான்னு. ஸ்ட்ரெயிட்டாக ஹாஸ்பிட்டல் விடுங்கன்னாரு. ஃபஸ்ட்டு எடுத்தோடனே வந்து பீடியாட்ரிக் ICU. ஏன்னா அவர் குழந்தை மாதிரி அப்போ நாங்கள் சூசகம் தெரிஞ்சுக்கிட்டோம். அதுக்கப்புறம் ஓஜி வார்டு, அதுக்கப்புறம் கம்ப்ளீட் ரவுண்ட்ஸு. ஞாயிற்றுக்கிழமை போது ஃபுல் டே எங்களுக்கு ஒர்க்கிங் டே ஆகிடுச்சு. அன்றிலேருந்து இன்னி வரைக்கும் ஒர்க்கிங் டே தான் டெய்லி. ஸோ பல்வேறு அதுக்கு வந்து இதாக நெகட்டிவாக சொல்ல, பட் டெடிகேஷன் குறைந்த நாட்களே இருந்தாலும் நம்ம ஏன் இருக்கணும் அப்படின்னு அந்த ஒரு மனப்பான்மை உள்ள நேரத்தில் நம்ம இருக்கிற வரைக்கும் ஒரு செகண்ட், அவர் ஒரு செகண்ட் கூட எங்களை வந்து அட்மினிஸ்ட்ரேஷன் டீமில் விட மாட்டுறாங்க சார். அவ்வளோ லேர்னிங் கர்வ் எங்களுக்கு கவர்மெண்ட். ஏன்னா ப்ரொசீஜர்ஸ் நம்ம இங்கேருந்து இந்த மலையிலேருந்து இங்கே புரட்டி போட்டு அண்ணாமலையிலேருந்து புரட்டி போட்டு இந்த சைடு வந்திருக்கோம். அதில் நிறைய பேருக்கு அந்த கவர்மெண்ட் ப்ரொசீஜர்ஸ் நாம்ஸ் எது ஒன்று வந்து உண்மையாகவே இது வந்து அவர்களை பூச்சறிதலோ இல்லை அவர்களுடைய துதிப்பாடுவதோ கண்டிப்பாக இல்லை. இது வந்து என்னோடய இதயத்திலிருந்து வந்திருக்கிற வார்த்தை. ஒன்று நிறையாவே லேர்ன் பண்ணிடுவோம். நிறையானா ஒரு எக்கச்சக்கமாக லேர்ன் பண்ணி இந்த குறுகிய காலத்தில் வந்து அவ்வளோ லேர்னிங். அவ்வளோக்கு உண்மையிலே நீங்கள் வந்து ஒர்க்கிங் ஹவர்ஸ் நீங்கள் பார்த்தீங்கன்னா எங்கள் அட்மினிஸ்ட்ரேட்டிவ் டீம் நீங்கள் கண்டிப்பாக ரொம்ப ஆச்சரியப்படுறீங்க. மார்னிங் சார் ஷார்ப்பாக வந்து 8:30 ஆகுதுன்னா அவர் கார் அங்கே அவர் கார் நின்னா அது 8:30ன்னு அர்த்தம். ஓபியில் யார் வேணால் பார்க்கலாம். அது மாதிரி வந்துட்டு மத்தியானம் நைட்டு வந்து 7:30 மணிக்கு போகிறோம். அதுக்கப்புறம் திருப்பி நைட் ரவுண்ட்ஸ் வரும். இதை வந்து டெய்லி, ஒரு நாள் இல்லை, டெய்லி நடந்துக்கிட்டு ஞாயிற்றுக்கிழமை 24/7 ஹாஸ்பிட்டல் மாதிரி இப்போ வந்து அருமையாக இருந்தது. அதனால் பல்வேறு வளர்ச்சி பணிகள் சின்ன வந்து ஒரு எப்படி சொல்கிறது, ஒரு மாறுதல்கள் ஒரு கட்டத்துலேயும் மாறுதல் பண்ணிக்கிட்டே இருக்காங்க. அது மாறுதல்னால் எல்லாமே வந்து கவர்மெண்ட் நாம்ஸ். ஸோ நம்மளுக்கு நல்ல ஒரு கைடன்ஸு, நல்ல ஒரு இது அறிவுறுத்தல்கள். நம்ம எங்கே சரி பண்ணாலும் அதை வந்து சரியாக ஒரு சிலை வந்து நம்ம செதுக்கும் போது கொஞ்சம் வலி இருக்கும். அது நிறையா பேருக்கு வலி இருக்குது. ஆனால் அந்த வெளியில் வரும்போது அந்த சிலை அழகாக வருகின்றது வந்து அந்த வலியெல்லாம் மறந்து போயிடும். அந்த வலி நம்ம பெறுறதுக்கே வந்து அழகான ஒரு சிலையாக வர்றதுக்கு தான். அந்த மாதிரி ஒரு இடத்துல செதுக்கிட்டு இருக்காங்க. கண்டிப்பாக அவர்கள் பல்லாண்டு பல கோடி நல்லாண்டு அவர்கள் நல்ல உடல்நலத்துடன் வந்து வாழ வேண்டும் என்று நடராஜன் அருளால் பண்ணுறது. அதுக்கப்புறம் வந்து இது வந்து நம்ம ஃபேக்கல்ட்டிஸ்க்கு ஸ்டூடெண்ட்ஸ் வந்தாங்க. ஸ்டூடெண்ட்ஸும் சரி எப்படி இருப்பாங்க உங்களுக்கு, இவங்கெல்லாம் ஸ்ட்ரிக்டாக இருப்பார் சார் போலுக்கு நினச்சா ஸ்டூடெண்ட்ஸ் அவ்வளோ ஃப்ரெண்ட்லி. அவர்களுக்கு கிட்டத்தட்ட வந்து அவர்களுடைய பீரியடில் வந்து 3 நிகழ்ச்சிகள் நடக்குது. ஒன்று இன்ஸ்டாலேஷன் ஆஃப் ஆஃபீஸ் பேரர்ஸ், பிரசிடென்ட்லேருந்து எல்லாம் அக்கார்டிங் டு த நார்ம்ஸ் ஆஃப் த கவர்மெண்ட். அதுவும் அவங்களே கைட் பண்ணி இப்படி இருக்கணும். ஒரு சின்ன திருத்தங்கள் கூட, இன்விடேஷன் கூட ஒரு நிமிஷம் திருத்தி நம்மளுக்கு வந்துட்டு நேற்று நைட்டு தான் நம்ம ஃபைனலைஸ் ஆச்சு டேட். ஏன்னா கலெக்டர் மீட்டிங்னால தான் இந்த நைட்டு தான் இது ஃபைனலைஸ் ஆச்சு. அதாவது இந்த விழா சார்பாக அதுக்கும் வந்து வருகன்ற நல்லார் தருக மொதல் டைமில் ஹைடெக் ஹாலில் நடக்குது நம்ம வாங்கியிருக்கோம். அது சாரோட முயற்சினால் இன்ஸ்டலேஷன் செரமனி வந்து பிரசன்ட் இன்ஸ்டலேஷன் செரமனி அங்கே ஹைடெக் ஹால், மற்றதெல்லாம் இங்கே நடக்குது. அதுக்கு முன்னாடி சொல்லணுன்னா பாருங்கள் எல்லா செக்டரையும் வருது. அது மாதிரி ஒர்க்கர்ஸு, ஸ்டாஃப், செவிலியர்கள் எல்லாத்துக்கும் வந்து ஒரு மிகுந்த உத்வேகம். இந்த சிஎம்இ பாருங்கள், அடுத்த சிஎம்இ. சரி, இதுக்கு முத்தாய்ப்பான் வந்து அந்த அவங்க துறை தலைவர் தமிழ்மணி மேடம் அவர்களுக்கும் மற்றும் ஜேஓ மேடம் மற்றபடி அனைத்து அந்த நல்ல உள்ளங்களுக்கு ஆல் பில்லர்ஸ் ஆஃப் த பயோகெமிஸ்ட்ரி. ஏன்னா ஒருத்தரை நான் பேர் சொல்ல விரும்பலை, பட் எனக்கு தெரியுது. இருந்தாலும் ஒருத்தரும் அது மாதிரி எல்லா ஹெச்ஓடிஸும் நல்லாமே ஒத்துழைக்கிறாங்க. நான் பார்த்துட்டு எல்லாமே 100% அட்டண்டன்ஸ். அது மாதிரி வந்து சார் முத்தாய்ப்பாக சொல்ல ஒரு விஷயம் வந்து பார்த்திங்கன்னா அவர் கொண்டு வந்து சிறப்பான திட்டம். அது கண்டிப்பாக சொல்லிட்டு தான் நான் நிறைய பண்ணோம். எவ்ரி டியூஸ்டே வி ஆர் கண்டக்டிங் சிஎம்ஹெச் மீட்டிங். இது வரைக்கும் நடந்ததே கிடையாது இந்த மாதிரி. அது எல்லாமே இந்திய தொலைக்காட்சி முதல் முறையாக மாதிரி சார் நிறையாவே எங்களுக்கு நடத்தியிருக்காரு. செவ்வாய்க்கிழமை வந்து இது டெக் ஆடிட்டிங் மீட்டிங், அதுக்கப்புறம் சிஎம்ஹெச் மீட்டிங் ரிவ்யூ பண்ணுறாங்க. சாரை உட்காந்து ரெகுலராக ரிவ்யூ பண்ணுறாரு. அதனால் ஏன் குறையுதுன்னு கேட்குறாரு. அது நிறைகள் குறைந்தால் அந்த டிபார்ட்மெண்ட்லேருந்து எழுதி கொடுங்க, இமீடியட் ஆக்ஷன். நீங்கள் அப்புறம்லாம் கிடையாது, அந்த ஃபாலோ இருக்கிற அட்மினிஸ்ட்ரேஷனில் வந்து ரொம்ப முக்கியம். வந்து நம்ம சொல்லிட்டு போய் பண்ணிடு அப்படின்னு சொல்கிறதெல்லாம் கிடையாது. அடுத்த நாள் அந்த நிமிஷத்தில் நம்மளுக்கு கூட வந்துடும், கரெக்டாக கேட்பார் இந்த இது நடக்குதா போகுதா. இப்போ கூட ஒரு பல்வேறு ஒரு குறுகிய காலத்தில் ஒரு திட்டம் எடுத்திருக்காங்க சார். அதை சொல்லலாம் சாரோட பர்மிஷனோட. சைனேஜ் போர்ட்ஸ் ஏழை மக்களுக்கு வந்து 117, 118, 150ன்னு சொல்லி அந்த ஓபி நம்பர்ஸில் இருந்தது. அது மிகப்பெரிய குழப்பங்கள் நிறைய பேருக்கு. அதுக்காக ஈஸியாக என்ன சொல்லிட்டாங்க சார், சிங்கிள் நம்பர் போடுங்க. நம்பர் 1னா ஆர்த்தோபி, 2னா இஎன்டிஓபி, அந்த மாதிரி ஒரு சின்ன எக்ஸாம்பிள் பண்ணுறேன். ஸோ எளியவர்களுக்கு எளியவராக, வல்லவர்களுக்கு வல்லவராக அவர் பல்வேறு பரிமாணங்கள் கொண்டு இருக்கிறார். கண்டிப்பாக வந்து இதுக்கு வந்து இந்த அலுமினினால் ஒரு மிகப்பெரிய பாசம். கண்டிப்பாக அந்த பாசம் இலையோடுகிறது. எல்லோரும் நம்மளும் அலுமினி தான். ஸோ அவரை பார்த்து ஒரு பெரிய பாடங்கள் கிடைச்சுன்னா குறுகிய காலம் இருந்தாலும் நம்மளது சாதனை மேல் சாதனை செய்து இந்த கல்லூரியை இன்னும் அடுத்த படிக்கு மேலே கண்டிப்பாக ஏன்னா ஆக்சிலரேட் பண்ணிட்டாங்க. இப்போ வந்து ஒரு அட்மினிஸ்ட்ரேஷனில் எப்படின்னா வந்து ஸ்ட்ரீம் லைனிங் தான் ஃபஸ்ட்டு ஸ்டெப். அது ரொம்ப கஷ்டம். அது ஒரு பெயின். அவங்களுக்கு வளைய மாட்டாங்க, கொஞ்சம் அவங்களுக்கு கஷ்டமாக இருக்கும். அந்த இவ்வளோ நாள் இப்படி ஜாலியாக இருந்துட்டு இப்படி ஆகுது. பட் எல்லாத்தையும் பொறுத்தவரை நம்ம ஊழியரும் சரி, நம்ம மருத்துவ கல்லூரி பேராசிரியரும் சரி எல்லாமே அழகாக அவங்களோட அட்வைஸ் பண்ணிவிட்டு ஒரு விஷயமா அவங்களும் மாற்றி காமிச்சு முழு ஒத்துழைப்பு வழங்குறாங்க. யாரும் வந்து ரிப்பல் பண்ணவே இல்லை. அது மிகப்பெரிய சக்ஸஸ். சாரோட சக்ஸஸ் வந்து யாருமே சாத்வீகமாக சொல்லி அழகாக கவர்மெண்ட் நாம்ஸை புரிய வச்சு அதை வந்து நடத்துறது வந்து மிகப்பெரிய ஒரு வரலாற்று சாதனை. கண்டிப்பாக இங்கே நடக்குது, எல்லாருக்கும் தெரியும் இந்த வரலாற்று சாதனை ஏன் சொல்கிறேன்ட்டு. அதில் பல்வேறு இடர்கள் பணியில் இருந்தாலும் அவர்களால் தகர்த்தெறிந்து அவர் முடிசூட மன்னராக இருப்பார். கண்டிப்பாக வாழ்க வாழ்க வளர்க வல்லக பல்லாண்டு சார். நன்றி சார்.
Most respected Dean Sir, all the dignitaries on the dais, senior professors, staff, non-teaching staff, students, guest speakers for the day, a very good morning to all of you. First of all, a very big congratulations to Dr. Tamilmani ma'am, HOD of Biochemistry Department. Madam joined us only 2 months ago. இப்போதான் வந்த உடனே அவங்களுக்கு HOD post. And now she is out with this hybrid CME and very relevant topic and very good speakers also. And I heard that there are more than 300 registrations, both online and offline. That itself is a big indication how successful this program is. So congratulations, madam. And madam is very well supported by her team in biochemistry. All the enthusiastic APs, they also have joined us. Nadula or stage level, the biochemistry department, there was only one faculty member, but after all the special counseling and all, only we got all the faculties and very supportive staff. All the faculty members are very supportive and efficient technicians in the department. Avangala real pillars for the department and energetic PGs. With all these people only, madam is coming out with this successful program. So congratulations, madam. Best wishes to your entire team. And I want to say about Dean sir. Thank you sir for all the motivation, your support, your guidance. And MS sir sonna madri in the 1.5 months la nariya we are learning from him. Thank you sir for all that you are doing to our institute. Thank you so much for the opportunity given to me, and best wishes again. Thank you all.
Thank you ma'am for your kind words. I request Dr. Balaji Swaminathan sir, our Vice Principal Administration, to share his insights.
Most respected and beloved Dean of Government Medical College, Cuddalore. And we all very much know that this is a superannuation CME which is being conducted. And the name has been coined as Endora. I don't know whether it is fortunate enough, it has automatically fallen across. Because if you deep dive into it to find out the meaning of what Endora is mythologically and as well as on Greek, if you refer, it says that it is magical and it is feminine centric. So both has actually happened here. We have a magician as a dean now, as longly when a full length what our medical superintendent has expressed that what all has been happening in the last fortnight and also the last previous month. It is absolutely a magical happening which is going on, and as it is women centric, exactly fitting on to biochemistry department headed by Tamilmani madam, and so the name goes very much coining to what Endora means here. We saw the video of our beloved Dean. My God, it is a long lengthy journey sir. You have started from 1997 onwards from a PHC. And from there on to getting retired in your alma mater here in the Government Medical College, Cuddalore Rajamuthia Medical College erstwhile, is a pride to all of us. And more than being a happy scenario, we will be keeping it as a learning benchmark for all the activities what you have been performing consistently for the last 45 days. And coming to the Department of Biochemistry, my association is for a very long time. I have my respect to Rajagopal sir, who was then the head of the Department of Biochemistry, to whom I had my undergraduate. He took a lot of pain. All these activities have started long way ago when he was there also. He took a bunch of our first year MBBS who do not know anything other than just stepping into the college to Delhi Defense Institute and made us all make a research paper presented. Those days we used to carry a slide which is on shadow, and we used to go. So then on, biochemistry has been flying very high, and we had a small turbulence with having one faculty member who also did not belong to the parent of biochemistry department. Then today we see it's getting flourished, and we are very happy to see gloriously glorying up, and all credit goes to the head of the department who is continuously running this event and other activities. Thank you very much, ladies and gentlemen, for this wonderful opportunity. I appreciate the entire biochemistry department. Thank you.
Thank you, sir. We are now privileged to invite our beloved Dean, sir, to deliver the presidential address.
Very good morning to all. Respected Medical Superintendent, Professor J.S. Sir, Vice Principal, Professor Shashikala Madam, the most respected HOD and the Chief Organizing Secretary of this wonderful event, the BioEndora, Professor Tamilmadi Madam. One thing I can tell about Madam is she is always smiling person. Whenever I see Madam, she always smiles. It's the character of a person. சிரிப்பிலே பாதி விஷயம் சால்வ் ஆகிடும். அவங்க எதை கேட்டாலும் நம்ம கொடுக்க முடியாது, அந்த அளவுக்கு ரெக்வஸ்ட் வச்சுட்டே இருப்பாங்க. அது வேணும், லேபுக்கு இது வேணும். நேற்று முன்னாடி கூட வந்தாங்க, பார்த்துட்டு எனக்கு ஏசி வேணும், அந்த மிஷினுக்கு இது பண்ணணும், எல்லாமே எப்போ பார்த்தாலும் she used to request. That should be the quality of a leader. That should be quality of a professor and HOD. And I have seen that quality in her. And beyond that, the way she has projected this CME, I was really fascinated by the way that she has prepared each and every audio visual in a meticulous manner. முதல்ல அந்த ஒரு ஆடியோ வந்தோடனே நான் எங்கள் மெடிக்கல் காலேஜுக்கு போஸ்ட் பண்ணி விட்டுட்டேன். ஸோ சூப்பர் அனிமேஷன் உடனே அதை ரொம்ப சந்தோஷமாக எல்லோரும் பார்த்து அதை பாராட்டினாங்க. ஸோ உண்மையில் இது வந்து ஐ வெரி ஹாப்பி மேடம், ஐ எம் வெரி கிரேட்ஃபுல், வெரி தேங்க்ஃபுல் டு யூ. எஸ், உண்மையிலே ஐ நெவர் எக்ஸ்பெக்டட் திஸ் ஃப்ரம் யூ. உண்மையில் அது ஒரு சகோதர பாசத்தில் நீங்கள் ரொம்ப அழகாக பண்ணியிருக்கிறீங்க. உண்மையிலே அதுக்கு என்னுடைய இதயம் கனிந்த நன்றிகளை தெரிவித்துக் கொள்கிறேன். மோரோவர் அந்த சூப்பர் அனிமேஷனுக்குன்னு ஒரு தனியாக ஒரு வீடியோ ப்ரெசென்ட் பண்ணது எனக்கே ரொம்ப யூஸ்ஃபுல்லாக இருக்கும். இப்போ 2ஆம் தேதி நான் கன்னியாகுமரியில் ஒரு ரிட்டையர்மெண்ட் ஃபங்க்ஷன் வச்சுருக்கேன். ஸோ உண்மையில் அது எப்படி நீங்கள் அந்த அளவுக்கு கான்சென்ட்ரேட் பண்ணியிருக்கீங்க, அது வந்து ஒரு தனி சிறப்பு மேடம். ஒரு உண்மையிலே எனக்கு ஒரு கூட பிறந்த ஒரு சகோதரியாக இருந்தால் எப்படி பண்ணுவாங்களோ அது மாதிரி தான் நீங்கள் பண்ணியிருக்கீங்க. ரொம்ப நன்றி. அதுவும் இல்லாமல் இன்றைக்கு வந்து என்னுடைய ஃபாதருடைய செகண்ட் டெத் ஆனிவர்சரி 27th April. ஸோ ஐ ஸ்டாண்ட் பிஃபோர் யூ வெரி ஹம்பிள்டு டுடே பிகாஸ் ஐ ஆம் வாட் ஐ ஆம் டுடே பிகாஸ் ஆஃப் மை ஃபாதர் who was a general practitioner. அவருக்கு தெரிஞ்ச ஒரே வார்த்தை நல்லா படிக்கணும். இதை தவிர அவர் ஒன்றுமே சொல்ல மாட்டார். எப்போ பார்த்தாலும் படி 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 தான். ஸோ நான் வந்து ஸ்கூல் ஃபஸ்ட் இன் 10th, ஸ்கூல் ஃபஸ்ட் இன் 12th, அப்புறம் மெட்ராஸ் மெடிக்கலில் ஜாயின் பண்ணேன். பரீட்சை முடிஞ்ச உடனே முதல் ஃபோன் அவர்கிட்ட தான் வரும். என்ன கொஸ்டின் கேட்டாங்க, எப்படி நீ ஆன்சர் பண்ண, இப்படி தான். அவர் திட்டி பார்த்ததே இல்லை, அடித்து பார்த்ததே கிடையாது. எப்போ பார்த்தாலும் படிப்பு தான். when I finished my DCH, I was having a very good practice in Nagarkoil, but he was always insisting you should finish your MD degree. MD இல்லைன்னா இனி ஃப்யூச்சரில் உனக்கு அது ஒரு பெரிய இதாக இருக்காது. So I started my career in medical college as a tutor in anatomy in the year 2004. He was always insisting me that you should finish MD. நான் கொஞ்சம் ஸ்லோ தான். ஸோ அவர் வந்து திருப்பி 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 சொல்லும்போது எனக்கு உள்ளால் அது ஒரு இதாட்டு மாறிட்டு. அந்த மோஸ்ட் இம்பார்ட்டன்ட் திங் பியூட்டி என்னென்னா, ஐ அப்ளைட் ஃபார் MD பயோகெமிஸ்ட்ரி இன் அண்ணாமலை யூனிவர்சிட்டி. அதான் அதில் பியூட்டி. அப்படி அப்போ என்ன ஆகி போச்சுன்னா, என் கூட அங்கே நம்ம குணசேகரன் UIC மெடிக்கல் ஆஃபீஸர், அவர் வந்து எனக்கு எல்லாமே ஆல்மோஸ்ட் ஓகே தான், எல்லாம் ரெடி பண்ணிட்டேன். ஐ வென்ட் ஃபார் கவுன்சிலிங் இன் கொஞ்சம் டிவியேட் ஆகிட்டேன்னு நினைக்கிறேன் சார், தப்பாக நினச்சிக்கோங்க. So when I went for counseling, they offered me MD Forensic Medicine, Diploma in Public Health and DTCD. 3 course கொடுத்தாங்க. They said you will get stipend for even a diploma after diploma. ஸோ நான் வந்து எஃப்எம் வந்து கொஞ்சம் யோசித்தேன், பட் ஐ தாட் வேண்டாம் அப்படின்ட்டு. வெளியில் வந்தோடனே என்னை பிடிச்சி எல்லோரும் திட்டி போட்டாங்க. எம்டி எஃப்எம் எப்படி நீ எடுக்காமல் போனேன், ராயல் ரெட் கார்பெட் வெல்கம் போட்டு உன்னை வரவேற்பாங்க அப்படின்ட்டாங்க. அந்த டைம் ஐ எம் டெல்லிங் அபவுட் 2006. ஸோ தட் வாஸ் மை திங் அண்ட் ஐ ஷுட் ஹவ் சேட் இன் த பிளேஸ் ஆஃப் தமிழ்மணி மேடம் நினைக்கிறேன். அன்றைக்கி முடிச்சிருந்தால் பயோகெமிஸ்ட்ரி ப்ரொஃபஸர் ஆகிருப்பேன். ஸோ தென் next year when I applied, I got community medicine, and I always remember my professor and HOD, Professor Ethirajan sir, for what I am today, as another father to me. He has guided me, molded me. இந்த இடத்துல எத்தனையோ ப்ரெசன்டேஷன் பண்ணியிருக்கிறோம். இன்டகிரேட்டட் லெக்சர்னு ஒன்று நடக்கும், எல்லா வாரமும் நடக்கும். இங்கே வந்து உட்காந்து எல்லா டிபார்ட்மெண்ட்ஸ் கூட ப்ரெசென்ட் பண்ணியிருக்கோம். ஸோ those were all very glorious times. I remember Professor Kalyani madam, who is my HOD, who is HOD today. அவங்களையும் இப்போ நினச்சி பார்க்குறேன் ஆஸ் அ டீச்சர், ஹவு தே ஆல் மோட்டிவேட்டட் அஸ். ஸோ அந்த வகையில் இன்றைக்கி உங்கள் முன்னாடி வந்து நான் வந்து இன்றைக்கி ஆஸ் அ அலுமினி, ஆஸ் அ ப்ரொஃபஸர் ஆஃப் கம்யூனிட்டி மெடிசன், ஆஸ் அ டீன் உங்கள் முன்னாடி நின்றுட்டுருக்கிறேன். வெரி தேங்க்ஃபுல் டு ஈச் அண்ட் எவ்ரி ஒன் ஆஃப் யூ ஃபார் த wonderful words which you have told about me, especially Junior Sundaresh sir, then Balaji sir. பாலாஜி சார்லாம் ஒரு பயங்கரமான ஒரு திறமையான ஒரு மருத்துவர். அவருடைய நாலேஜ், வாஸ்ட் நாலேஜ், ஹவு ஹீ இஸ் இன்வால்வ்ட் இன் அகாடமிக் அஃபேர்ஸ், அட்மினிஸ்ட்ரேஷன் அஃபேர்ஸ், அதை நான் நேராக பார்த்துட்டு தான் இருக்கிறேன். ஸோ இஸ் சச் அ கிரேட் பர்சன், மல்டி ஃபேசட்டட், மல்டி டேலண்டட் பர்சன். சசிகலா மேடம், அவங்களுக்கும் நான் ரொம்ப நன்றியாக இருக்கிறேன். தென் ஐ ரிமெம்பர் அவர் ஜேஏஓ சண்முகப்பிரியா, அவங்க வந்து நான் ஜேஏஓ இன்சார்ஜ் கொடுத்தோன்னே உடனே ஓடி வந்துட்டாங்க. தென் உட்காருங்க. தென் ஷீ இஸ் ஆல்வேஸ் with me, with our admin team, looking after so many government procedures and protocols which have to be followed. Salary was one of the greatest issue. Stipend was another issue which we were facing. It's a really tough job to make a person who was trained in the university pattern of office work to a government office work. இப்போ வந்து ரொம்ப டிஃபிகல்ட் அந்த சேலரிலாம் ரைஸ் பண்ணுறது. ஸோ மெனி கொஸ்டின்ஸ், ஸோ மெனி டவுட்ஸ். ஸோ அதெல்லாம் வந்து இப்போ ஓரளவுக்கு ஸ்ட்ரீம்லைன் ஆகி வந்துட்டுருக்குது. தென் ஐ வாண்டட் டு ஆல்சோ ரிமெம்பர் பிரசன்னா வாஸ் மை ஸ்டூடெண்ட் அட் கன்னியாகுமரி கவர்மெண்ட் மெடிக்கல் காலேஜ். எங்கே இருக்காங்க? சாரி நீங்கள் சாரி கலைவாணி, சாரி கலைவாணி. ஸோ அவங்க வந்து என்னுடைய காலேஜ் அலுமினி தான், என்னுடைய ஸ்டூடெண்ட் தான். ஸோ வெரி ப்ரவுட் ஆஃப் யூ. ஸோ யூ ஆர் ஹியர் அஸ் ஒன் ஆஃப் த ஃபேக்கல்ட்டி மெம்பர்ஸ். ஐ ஷுட் அப்ரிஷியேட் ஆல் த ஃபேக்கல்ட்டி மெம்பர்ஸ். ஜெயபாரதி மேடம், அவங்க தானே அந்த இந்த ஃபஸ்ட்டு சொன்னது இன்ட்ரொடக்ஷன் சொன்னது யார்? அனிதா ஸ்ரீ மேடம். ஸோ நம்ம பேரில் கொஞ்சம் சின்ன குழப்பம், ஏன்னா 45 நாள் தான் ஆச்சு. ஸோ கூட ஒரு 45 நாள் இருந்தால் எல்லா பேரையும் தரவாக சொல்லிவிடுவேன். ஸோ அனிதா ஸ்ரீ, ஃபார் யுவர் நைஸ் வீடியோ ப்ரெசன்டேஷன் டெல்லிங் அபவுட் ஆல் த சக்ராஸ், all the glands, all the hormones. Thank you madam for the nice way you connected this with the program. And I remember Dr. Saravanan sir, எப்போ ஐஇஎல்எஸ் லேபுக்குள்ளே நுழைஞ்சினோம் அன்னையிலேருந்து சாரை தான் பார்த்துட்ருக்கிறேன். The way they work, how hard they work along with all the technicians. Very thankful to each and every technician. You are all working the force behind the department. வெளியில் அதிகமாக தெரியறதில்ல, பட் உங்களுடைய உழைப்பு, உங்களுடைய முயற்சி அது உண்மையிலே பாராட்டத்தக்கது. And it was really wonderful that HOD has taken efforts, the department has taken efforts to honor each and every one of you in front of this audience. அது வந்து உண்மையிலே இந்த துறைக்கு ஒரு பாராட்டுக்கள். இது வந்து I want to appreciate each and every one of the other faculties. Dr. Gayatri madam, அவங்க வந்து அடிக்கடி வந்து பார்ப்பாங்க. So then Prasanna Balaji, Veeramani and all the people. So one thing I wanted to share here, that when I was undergraduate Madras Medical College, Professor Gopalakrishnan sir was the HOD of biochemistry. He became the dean. அப்போ அந்த டைமில் வந்து அதுக்கு முன்னாடி மெட்ராஸ் மெடிக்கல் காலேஜ்லாம் வார்டெல்லாம் ரொம்ப மோசமாக இருக்கும், ரொம்ப மட்டமாக இருக்கும். எப்பவும் க்ரௌட் இதே மாதிரி தான், ஆர்எம்எம்சி மாதிரி தான் இருக்கும். பட் he took lot of efforts in shaping the Madras Medical College. அந்த ஹாஸ்பிட்டலை அப்படியே சேஞ்ச் பண்ணிட்டார். அவ்வளோ என்ட்ரன்ஸ்லேயே வாட்ச்மேன், கேட்டு, ரொம்ப டிசிப்ளின்டாக இருப்பார். காலையில் நீங்கள் சொல்கிற மாதிரி தான் 8:30 மணினா அந்த டைமுக்கு அங்கே இருப்பார். டீன் சேம்பரில் இருப்பார். கோபாலகிருஷ்ணன் சார் he used to be very meticulous in the administration. So administration வந்து ஒரு இன்பார்ன் நேச்சர் தான் நான் நினைக்கிறேன். அது வந்து ஒரு ட்ரைனிங்காக இருந்தால் கூட I got this experience because I took whatever post they offered me in கன்னியாகுமரி மெடிக்கல் காலேஜ். எந்த போஸ்ட்னாலும் சுரேஷ் பாலன்ட்ட கொடுங்கன்னா நான் அதை வாங்கிடுவேன். பிளட் பேங்காக இருந்தாலும் சரி, எய்ட்ஸ் கண்ட்ரோலாக இருந்தாலும் சரி, ஹாஸ்டல் வார்டனாக இருந்தாலும் சரி, எத்திக்கல் கமிட்டியாக இருந்தாலும் சரி, சயின்டிஃபிக் கமிட்டியாக இருந்தாலும் சரி, எதுவாக இருந்தாலும் சுரேஷ் பாலன்ட்ட கொடுத்துருங்க அப்படின்னா உடனே நான் எடுத்துக்குவேன். ஐ நெவர் சே அது எனக்கு எக்ஸ்ட்ரா ஒர்க்கு பேர்டன் அப்படிலாம் நான் என்றைக்குமே சொல்லதில்லை. ஸோ அந்த வகையில் வந்து this gave me lot of experience, learning how to write file, how to create file, how to put questions, queries, எப்படி select பண்ணுறது, இதெல்லாம் நம்ம இது பண்ணுவோம். Move with lot of people, there will be lot of issues. When we do something against routine practice, definitely it irritates somebody. வேறு ஒரு மாற்றம் கிடையாது. இரிட்டேட் ஆவாங்க, ப்ரெஷர் பண்ணுவாங்க. எவ்வளோ ப்ரெஷர் வருதுன்னு எங்களுக்கு தான் தெரியும். எவ்வளோ ப்ரெஷர் வந்துகிட்டே தான் இருக்குது. ஸோ நம்ம அதை எப்படியெல்லாம் மேனேஜ் பண்ண போகிறோம். ஏன்னா டுமாரோ இட்ஸ் அ ஃபீல்ட் வேர் most of the youngsters who are sitting here don't think that you will be only looking after practice. It's totally going to change. The entire scenario may change. So some of you should take up other fields like administrative fields, IAS, IPS, Group 2, Group 1. இதெல்லாம் நீங்கள் யோசிங்க. Don't think only about practice. And so definitely this will be the opportunity where you can learn so many things. And I also want to appreciate the various speakers, the list speakers for today's program, for taking their valuable time, especially Dr. Ramanathan sir, with whom I am going to share a session next. Then Arunathan sir for your time, and Jayasri madam for her hard work. I am appreciating her not only for this talk but the way she is handling the difficult cases in the Department of Obstetric Gynecology along with the Mirnalini madam. I am very happy that team of OGCians are doing a phenomenal work in the institute, and really I want to appreciate you. Yesterday also we got the video of a polytrauma patient. அது வந்து RTA ஒரு 23-year-old lady, when she was traveling in bike along with her husband, she met to the fatal accident, near fatal status, collapsed, hemoperitoneum, rupture uterus, rupture bladder, pelvic fracture, எல்லா ப்ராப்ளத்தோட ஷாக்கில் வந்து இறங்குனாங்க. நம்ம ஹாஸ்பிட்டலில் அப்படி ஒரு கேஸை மேனேஜ் பண்ண முடியுமா? முடியும்னு நடத்தி காமிச்சிருக்காங்க. ஸோ எல்லோரும் அதுக்கு ஒரு பாராட்டு தெரியும். என்டையர் டீம் ஆஃப் டாக்டர்ஸ், சர்ஜன்ஸ்லேருந்து ஆரம்பித்து அனஸ்தட்டிஸ், பிளட் பேங்க்கு, ஒஜிஷியன், வேறு யாரெல்லாம் இருந்தாங்க மேடம் அந்த டீமில்? ஆர்த்தோபெடிஷன் எல்லோரும் இருந்து அந்த லேடியை சேவ் பண்ணியிருக்காங்க. ஸோ ஹேட்ஸ் ஆஃப் டு த இன்ஸ்டிடியூஷன், all the dedicated professors and team of staff nurses, technicians worked behind that and saved the lady. அந்த மாதிரி ஒரு மிக சிறந்த ஒரு டிபார்ட்மெண்ட் அது. Then Professor Nandisha sir for your valuable time to be with us, and all the postgraduates and undergraduate students for their contribution, especially in posters and so many other things, and all the judges and the organizing committee. I'm really happy that this has been a series of events for the past 1 week. I could see that our anatomy department, how they organized the Rangoli in histology, how they have done it, and again community medicine, how they have conducted the TB Day, World TB Day, the World Health Day, and then yesterday the alumni meet, day before yesterday alumni meet, and then the CME, wonderful CME. I don't know how many people attended the CME on community medicine, where we had excellent talk from one of my own junior colleague, Dr. Kumarasamy sir, who is ultimate authority in HIV. அதெல்லாம் நீங்கள் கேட்டிருக்கணும். It would have been truly inspiring to the participants. அவ்வளோ தூரம் ட்ரையல்ஸ், அவ்வளோ தூரம் ட்ரக் ட்ரையல்ஸ் பண்ணி தமிழ்நாட்டிலேருந்து ஒருத்தர் உலக அளவில் ஹெச்ஐவியில் ஏஆர்டியில் இருக்கிறான்னு சொன்னால் அது உண்மையிலே நம்ம அனைவருக்கும் பெருமை. அவருடைய பேச்சை நீங்கள் கேட்டிருக்கணும். அது வந்து அவர் வந்திருந்தார். ஸோ கம்யூனிட்டி மெடிசன் டிபார்ட்மெண்ட், அண்ட் தென் ப்ரொஃபஸர் ராமநாதன் சார் was conducted the autism day, thalassemia, hemophilia day. ஸோ இந்த மாதிரி பல்வேறு நிகழ்ச்சிகளை வந்து செய்யும்போது அப்போ தான் நம்ம உண்மையிலே நம்மளுடைய மருத்துவக் கல்லூரியினுடைய நீங்கள்லாம் போஸ்ட் பண்ணும்போது அதை அப்படியே எடுத்து எங்கே போஸ்ட் பண்ணுவேன்? டீன்ஸ் குரூப்பு, ஹெல்த் செக்ரட்டரி. டீன்ஸ் குரூப்பில் 33 காலேஜுடைய டீன்ஸ் இருக்கிறாங்க, ஹெல்த் செக்ரட்டரி, ஐஏஎஸ் ஆஃபீஸர்ஸ் இருக்காங்க. அவங்களாம் பார்க்குறாங்க. கடலூர் மெடிக்கல் காலேஜ் இந்த ப்ரோக்ராம் பண்ணாங்க, கடலூர் மெடிக்கல் காலேஜ் பயோகெமிஸ்ட்ரி இப்படி பண்ணுறாங்க, கம்யூனிட்டி மெடிசன் இப்படி பண்ணியிருக்காங்க. இப்படி போடும்போது யுவர் இமேஜ் இஸ் பூஸ்டட் அப். நவ் இட்ஸ் அ டைம் ஆஃப் projecting ourselves. Tomorrow when we go for asking the health side எங்களுக்கு இது வேணும் அது வேணும் சொல்லும்போது they will remember that. கடலூர் மெடிக்கல் நல்லா பண்ணிகிட்ருக்கீங்க அப்படிங்கிற அந்த பேர் வரும். ஸோ அது நிச்சயமாக உங்கள் அனைவருக்கும் உங்கள் மாணவர்கள் எல்லாருக்குமே அது என்னுடைய ரிக்வெஸ்ட்டு. அண்டர் கிராஜுவேட் போஸ்ட் கிராஜுவேட்லாம் நல்லா ஹார்ட் ஒர்க் பண்ணுங்கள். டோன்ட் திங்க் தட் யூ ஆர் நாட் கோயிங் டு லேர்ன் எனி திங். யூஆர் டெஃபினெட்லி தட் இஸ் கோயிங் டு கிவ் யூ ப்ரைஸ். புரியுதுங்களா? நீங்கள் என்ன ஹார்ட் ஒர்க் பண்ணுறீங்களோ அதனுடைய பரிசு. என்னுடைய ஓன் ஃப்ரெண்டு ஹூ இஸ் ரிட்டையரிங் திஸ் மந்த், டாக்டர் ஜஸ்வந்த், இன்றைக்கி வந்து அவர் ஒன் ஆஃப் த பெஸ்ட் டாக்டர்னு வந்து இன்றைக்கி ரிட்டையர்மெண்ட்டில் தமிழ் சேனலில் உள்ள புதிய தலைமுறையில் போட்டிருக்காங்க. இஸ் ஃப்ரம் மார்த்தாண்டம், வெரி ஸ்மால் வில்லேஜ். அந்த இடத்துலேருந்து அவர் வந்து எம்எம்சியில் வந்து என் கூட எம்பிபிஎஸ் படித்து எம்எஸ் படித்து எம்சிஏ பிளாஸ்டிக். அவருடைய ஒரே ஃபைண்டிங் என்ன தெரியுமா? ஸ்டான்லி மெடிக்கல் கேஸ்ட்ரோன்டாலஜி ப்ரொஃபஸர். அவர் 100+ லிவர் டிரான்ஸ்பிளான்ட் சர்ஜரி பண்ணிவிட்டு ஃபைனலாக ஒரு அறிக்கை தமிழக அரசு கொடுத்தார். என்ன அறிக்கை தெரியுமா யாருக்காவது? மிக பிரமாதமான ஒரு அறிக்கை. நம்மளுடைய பாரம்பரிய உணவு என்ன உணவு? பழைய சோறை சாப்பிடணும்னு அறிக்கை கொடுத்துருக்காரு. ஆஃப்டர் 100+ liver transplant successful surgeries, he has given a report to the Tamil Nadu government that the பழைய சோறு prebiotic probiotic is going to protect you from very many diseases. இன்றைக்கி இருக்கிற எல்லா டிசீஸஸுக்கும் மெயின் காரணமே இந்த குடல் இறப்பை தான். ஸோ அதுக்கு பெஸ்ட்டு ட்ரீட்மெண்ட் என்ன சொல்லிட்டாரு? பழைய சோறுன்ட்டார். ஸோ அப்படிப்பட்ட ஒரு நல்ல ஒரு மருத்துவர் நண்பரையும் நான் இந்த மாதத்தில் அவரும் ரிட்டையர்மெண்ட்டு, நானும் ரிட்டையர்மெண்ட்டு. பட் என்னை பற்றி ஒன்றும் புதிய தலைமுறையில் போடலை, அதை பற்றி நான் வருத்தமும் படலை. ஆனால் அவரை பற்றி போட்டிருக்கான்னு சொன்னால் அந்த அளவுக்கு ஒரு எளிமையான வாழ்க்கையை வாழ்ந்து வெரி சிம்பிள் பர்சன். அவர் டீனெல்லாம் ஆகலை, வேணான்ட்டார். வெரி சிம்பிள் பர்சன் டாக்டர் ஜஸ்வந்த். இன்றைக்கி வந்து அவர் ஒரு மிக சிறந்த ஒரு மனிதராக இன்றைக்கு வந்து இந்தியாவே இப்போ உற்று நோக்குகிற ஆராய்ச்சியை செய்து அவர் வந்து வெளியிட்டிருக்கிறான்னு சொன்னால் அது வந்து உண்மையிலே பாராட்டத்தக்கது. அது வந்து எல்லா மருத்துவர்களுக்கும் இது ஒரு உங்கள் ஸ்டூடெண்ட்ஸுக்கு தான் சொல்கிறேன். ஸோ யூ ஷுட் டூ ரிசர்ச். ரிசர்ச் இஸ் ஒன் திங் விச் யூ ஆர் கோயிங் டு டேக் யூ டு ஹையர் லெவல். என்னுடைய ஃப்ரெண்டு நான் டாக்டர் குமாரசாமி சொன்னேன் இல்லையா, அவர் வந்து சொன்ன ஒரே வார்த்தை தான், மெனி ஆஃப் த ஸ்டூடெண்ட்ஸ் ஃப்ரம் மெட்ராஸ் மெடிக்கல் காலேஜ் அண்ட் அதர் இன்ஸ்டிடியூட்ஸ் ஆர் கோயிங் தேர் வாலண்டரி ஹெல்த் சர்வீசஸ். அந்த விஹெச்எஸ் ஹாஸ்பிட்டலுக்கு போயிட்டு தே ஆர் டூயிங் ரிசர்ச். ஸோ ஐ ரிக்வெஸ்ட் ஆல் த போஸ்ட் கிராஜுவேட்ஸ், ஆல் த ஃபார்மகாலஜி, பயோகெமிஸ்ட்ரி கிளினிஷியன்ஸ் ஹியர், இந்த பிஜிஸ் வந்து தயவு செய்து விஹெச்எஸ் அது என்னன்றதை பாருங்கள். தேர் ஹேவிங் எ சென்டர் ஃபார் டிசீஸ் கண்ட்ரோல் அண்ட் இன்ஃபெக்ஷன் டிசீஸ் சென்டர் வேர் தேர் டூயிங் லாட் ஆஃப் ரிசர்ச். மேடம் 400 ஆர்டிகல்ஸ் எஸ் பப்ளிஷ்ட். 400 ஆர்டிகல்ஸ் எல்லாமே ஸ்டாண்டர்ட் டெக்ஸ்ட் புக் ஹாரிசன்ஸ் அங்கெல்லாம் வந்துருச்சு. ஸோ அதெல்லாம் வந்து எப்படி பண்ணணுங்கிறத தயவு செய்து பாருங்கள். ஸோ திஸ் ஷுட் பேவ் அ வே ஃபார் யுவர் லேர்னிங். டுடே திஸ் பயோகெமிஸ்ட்ரி அது இல்லைன்னா இன்றைக்கி மருத்துவத்துறையே இல்லைன்னு சொல்லலாம். எல்லோரும் போனால் உடனே டாக்டர் என்ன சொல்ல, டெஸ்ட்டை பண்ணிட்டு வாங்க அப்படிங்கிறாங்க. எல்லாருமே கிளினிக்கில் வச்சு நம்மளால் ஒன்றுமே பண்ண முடியாது. டெஸ்ட்டு, அந்த டெஸ்ட்டுன்னா என்னது? ப்ளட் டெஸ்ட்டு, யூரின் டெஸ்ட்டு, இந்த மாதிரி தான் வருது. ப்ளட்டில் ஆயிரக்கணக்கான டெஸ்ட் இருக்குது இன்றைக்கி. எல்லா டெஸ்ட்டையும் பண்ணுறது யாருன்னு பார்த்தா பயோகெமிஸ்ட்ரி டிபார்ட்மெண்ட். whether it is tumor marker, whether it is a metabolic disease, whether it is a hormonal assay, whatever test எல்லாம் பண்ணுறது அவங்க தான். ஸோ இதை வச்சு தான் ட்ரீட்மெண்ட்டே நடக்குது. ஸோ எவ்வளோ சென்சிட்டிவ் ஏரியா எப்படி இருக்கிறோம், அந்த டிபார்ட்மெண்ட்டை உண்மையிலே நடத்தி சிறந்த முறையில் நடத்துகின்ற உங்கள் அனைவருக்கும் என்னுடைய பாராட்டுக்கள். இந்த நிகழ்ச்சி அதற்கு முத்தாய்ப்பு அமைந்திருக்கிறது. இந்த கடலூர் அரசு மருத்துவக் கல்லூரியில் இது ஒரு நிகழ்வாக நடத்தி இன்றைக்கு 300க்கும் மேற்பட்ட பங்கேற்பாளர்கள் இந்த நிகழ்ச்சியில் கலந்துருக்கணும்னு சொன்னால் உண்மையிலேயே நம்ம அனைவரும் பெருமைப்படக்கூடிய ஒரு நாள் என்று உண்மை அனைவரையும் பாராட்டி மீண்டும் வாழ்த்து கூறி விடைபெறுகிறேன். நன்றி, வணக்கம்.
Thank you, sir, for those memorable and inspiring words. We are truly honored to have you with us. Now I would like to invite Dr. Gayatri Ma'am, Associate Professor, Department of Biochemistry, to deliver the oath of thanks.
Respected Dean Sir, Chairperson, distinguished speakers, faculty members and delegates, good morning, good afternoon to all. On behalf of the Department of Biochemistry, I hereby to deliver the vote of thanks. First of all, I thank our beloved Dean, Sir, for giving support and guidance in conducting this CME. Sir, we are very happy and glad to conduct this CME on your superannuation day. It's very pleasure and happy to conduct this CME, sir. And then Sir gave support to not only in academic activities and also in hospital, not only in hospital side, but in concern about each and faculty members of both college and the hospital side. Sir's work in, especially we are very happy and thankful to Sir, because for so many days and months, they are all without the salary. Many of our faculties are suffered. Sir cleared that such a nice salary issues. Very thankful to you, sir. We are very happy with this, sir. With the salary issues, sir. Thank you so much, sir. Thank you, sir. And also I thank Dr. Ashok Bhaskar, sir, in helping this issue, a very big issue of salary, because of so many months. Each and every faculties and PGs are suffering, sir. With pleasure, we won't forget you, sir. Then I thank MS sir, Dr. Juriya Sundaresan sir, for his support and guidance. I thank our VP madam, Dr. Shashikala ma'am, with support and guidance. Ma'am is very friendly and easy approachable in all his activities, sir. Is very helpful in all the academic activities, sir. And I thank Dr. Balaji Swaminathan sir, hospital side administrative sir. Sir is a very what to say, sir is a very jovial person, and we can also ask anything about sir. It's a very nice to share with us, sir. Thank you, sir. Thank you so much for coming this CME, sir. And then I thank TNMSC observer, Dr. Anwal sir, and he is a HOD surgery department. And our speakers, Dr. Arulnathan sir, and Dr. Ramanathan sir, Dr. Jayashree ma'am, and Dr. Nandishan sir. And our chairpersons, Dr. Dean sir is one of our chairperson. The next session is going to come. And Dr. Sundaresan sir, and Dr. Sudha ma'am, and Dr. Tamilmani ma'am. These are all the chairpersons to our CME program. And I thank our e-postal judges, Dr. Geeta ma'am, who is a professor and HOD of Biochemistry Department at Kalakurchi Medical College, and Dr. Venila ma'am, he is a senior assistant professor of Tanjavur Medical College, he is a general medicine, and Dr. Dharani ma'am, department professor and HOD of anatomy. I thank you ma'am for your wonderful acting as a judge in selecting this posters and all. Thank you ma'am, thank you very much. And I thank Dr. Soundra Pandian sir, the pharmacology department assistant professor. He helped in technical assistance, and also he is helped in registration. And I thank physiology department technical assistant for the back contribution, and not but the least our sponsors, BioEndora company for registration kit, food and snacks by the Meenachi Catering, and banner by the Leo Madi, and AVH and hall arrangement Mr. Kannan and Mr. Naveen, and AVH especially Mr. Prabhaharan. Very thankful to you. It's a very wonderful and very nice going CME. And I thank one and all. I thank our HOD for organizing this CME, and our department faculties, teaching staffs, non-teaching staffs, and our pillar of our department, our PGs, postgraduates. Very thankful to you all. Because of them, this CME, this successful CME will not happen. Sir.
மிகப்பெரிய நன்றியை வந்து எல்லாருக்குமே சொல்லிகிட்டே இருக்காங்க. ஒரு லிஸ்ட்டு பயங்கரமாக போயிட்டுருக்கு. ஆனால் நாங்கள் மிகப்பெரிய அதுக்கு மேலே ஒரு நன்றி சொல்லணும் டிபார்ட்மெண்ட்டுக்கு. என்னென்னா வந்து சார் வந்து ஒரு ஐடியா கொடுத்தாங்க. ஓபி சாம்பிள்ஸ்லாம் வந்து கண்ணாமனா ஹேப்பஸாடாக வந்துட்டு லேட்டாக கொடுத்து லேட்டாக போயிட்டனால அந்த சாரோட ஆலோசனைப்படி ஒரே சென்ட்ரலைஸ்டு சென்டர் வந்து கலெக்ஷன் சென்டர். இம்மீடியட்டாக நாங்கள் மேடம் தான் டிஸ்டர்ப் பண்ணோம். எம்எல்டி ஸ்டூடெண்ட்ஸ் போடுங்கன்னு உடனே ஆணை பண்ணி இன்றைக்கி வந்து சக்ஸஸ்ஃபுல்லாக ஓடிட்டுருக்கு. ஏன்னா எங்கேயுமே அலைய வேணாம், பேஷண்ட்ஸ் அலைய வேணாம். சாம்பிளை ஒரே இடத்துல மெடிசன் ஓபிக்கிட்ட கொடுத்து அவங்க வந்து பிளட் பேங்க் இன்வெஸ்டிகேஷன் சென்டர் அனுப்பிச்சு இன்டிகிரேட் லேபுக்கு அனுப்பிச்சு அதுக்கப்புறம் அங்கே அதுக்கு முழு ஒத்துழைப்பு அனைத்து ஊழியர்களுக்கும் இன்டிகிரேட்டட் லேபுக்காக கண்டிப்பாக ஒரு மிக்க கரகோஷனர் பயங்கரம். ஒரு நாளைக்கு நம்ம காலேஜ் மட்டும் பண்ணுறதில்ல, வெளி எல்லா பிஹெச் சென்டர்லையும் கிட்டத்தட்ட ரெகுலராக வந்து கிட்டத்தட்ட 3000 to 5000 சாம்பிள்ஸ் டெய்லி அவங்க பண்ணுறாங்க. கடுமையான உழைப்பு எல்லாமே. அவர்களுக்கு மிக்க ஒரு கரகோஷம் கொடுத்தா ரொம்ப நன்றி. ஆனால் மேடத்துக்கும் ஒரு கரகோஷம். அதுக்கு மேலே வந்து சார் இந்த ஐடியா பண்ண டேரக்டருக்கு, நம்மள ஆக்டர் டேரக்டருக்கு வீணா ஒரு கைத்தட்டு.
தேங்க்யூ சார், தேங்க்யூ சார்,
தேங்க்யூ
தேங்க்யூ சார். Then last sir, I am going to finish. It's a very quickly sir, for want of time I am sir. Then the last very big thanks to our UG students who made this artwork and all. Sir, this artwork is done by our UG students, ma'am. all this artwork. And the volunteers of the first year department, thank you all. Thank you once again, and thank you all for this coming this for the creating this CME a grand success. Thank you, sir. Thank you so much, sir.
Thank you, ma'am.
May I request everyone to kindly rise and stand for the national anthem.
हे भारत भाग्य विदाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभाशिष माहे गाहे तव जय गादा जनगण मंगलदायक जय हे भारत भाग्य विदाता जय हे जय हे जय हे जय 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 हे.
Thank you all. Please be seated. We will now proceed to a...
I kindly request all the dignitaries on the dais to occupy the front row.
By the time we are getting for the next scientific session, we have Dr. Satyachitra ma'am to... Anita Shri. Okay, we have Anita Shri ma'am to have fun game session. Stage is yours, ma'am.
Our next fun game for the event, we'll start with the exclamation before the fun. So we are here to kindle your endorphins with endocrine exclamations. So this is another exclamation of the thyroid gland and its uniqueness. It's the only gland that stores the hormone extracellularly within the lumen of the thyroid follicles called as the colloid. So whenever there's a need for the thyroid hormone, the cell will engulf the colloid by endocytosis and then release it to the bloodstream. It can be compared to a pond where the water is already stored in the pond. You see the image of a woman where the water is already stored in the form. Just like the thyroid hormone, inside the follicle, the yellow color follicle, colloid is here below compared to the water in the pond. Whenever you want water, we can go with the pot and get a pot of water and come out. Just like that, the thyroid hormone, whenever there's a demand, where it is already stored in the colloid, the cells will catch some of the hormone and then give it to the bloodstream for its action. So this is an exclamation of the endocrine system. We are really exclaimed, aren't we? Thank you, and let's go to the fun now. Game. So here's your game. You have to guess the movie and the actor whom you're going to hear in the audio. Please play the audio.
நான் எதுக்காக உன்னை வர சொன்னேன் தெரியுமா? தெரியும். ஏரியா பிரிக்கிறதுக்கு. ஹைதராபாத் உண்டு, செகண்டராபாத் எந்து. குண்டூர் உண்டு, நெல்லூர் எந்து. கடப்பா உண்டு, மடப்பா எந்து. காக்கிநாடா உண்டு, பாவாடநாடா எந்து.
Tell the movie name and actor.
படிக்காதவன் விவேக் சார்.
Yes, it's right answer. May request Dean sir to give. Sir is busy. MS sir. Prize கொடுக்கணும் சார் அவர். நீங்க போய் நில்லுங்க.
Thank you for the active participation as a break.
We shall now proceed to our next scientific session titled Adrenal Alarm. The topic for this session is redefining the therapeutic landscape of congenital adrenal hyperplasia. Congenital adrenal hyperplasia remains one of the most clinically significant and challenging endocrine disorders of childhood, and this session promises to offer fresh insights while redefining our therapeutic approach. I would like to invite Dr. Kalaivani ma'am, Assistant Professor of Department of Biochemistry, to kindly introduce our respected chairperson of the session.
Respected dignitaries, estimated faculties, dear colleagues, and my dear students. A very good afternoon to everyone present here. I just start this session with a Tirukural here. பயந்தூக்கா செய்த உதவி நயந்தூக்கின் நன்மை கடலினும் பெரிது. இதன் பொருள், இன்ன பயன் கிடைக்கும் என்று ஆராயாமல் அன்புடனும் கடமை உணர்வுடனும் ஆசிரியர் செய்த உதவி கடலை விட மிக பெரியது. இத்திருக்குறளை எனது பேராசிரியரான டீன் சாருக்கு இத்திருக்குறளை சமர்ப்பிக்கிறேன். So, it's both an honor and a deeply emotional moment to introduce a remarkable personality who has not just served but shaped generations, Dr. K.U. Suresh Balan, our estimated Dean. Sir is a proud alumnus of Madras Medical College, who he pursued MBBS in 1989, followed by Diploma in Child Health, Master Degree and PhD in Community Medicine, along with Postgraduate Diploma in Hospital Administration. It shows reflecting his unwearying commitment to academic excellence. With an illustrious career spanning 29 years, Sir has worn many hats with grace: academician, researcher, administrator, and a mentor. He has contributed as a resource person in 19 programs, engaged in multiple research projects, and organized numerous conferences, leaving an indelible academic footprint. His leadership journey includes holding 13 key administrative positions, and his professional excellence is recognized through prestigious honors like the IMA Asan Award for Best Teacher, Best Doctor Award, and the Balagopal Raju Award at Pedican. But beyond the achievements, Sir's true legacy lies in the countless students he has inspired and the values he has instilled. Today is not just a farewell, it is a celebration of a legacy, not an end but the beginning of a lasting inspiration. Yes, ladies and gentlemen, it's my privilege to invite and introduce Dr. K.U. Suresh Balan, Dean, a leader for excellency. Over to you, sir.
Thank you, ma'am, for the warm introduction. I now request our respected Dean, sir, to introduce the speaker of the session.
Very good morning to all. So I'm very happy to introduce one of my colleagues and an IAPN, Dr. R. Ramanathan, with whom I know since 2006. When my HOD's daughter delivered her first baby, that time sir asked me to come for the resuscitation. I asked Professor Ramanathan sir to be there because I felt that he is more experienced in that neonatal resuscitation than me. So sir was there, we both were there for the resuscitation, and luckily she had no other complications. So such a nice person and a smiling person. He is the head of the Department of Pediatrics at the Government Kadalur Medical College and Hospital, CHIDAMBARAM. He completed his MBBS and his DPNB in Pediatrics from Raja Muthaya Medical College and his DCH from Ramachandra Medical College and Hospital. With over 25 years of excellence in teaching, mentorship and pediatric critical care, and significant contributions in strengthening NICU PICU services, he is a respected academician and clinician. And we are honored to have him with us today. And sir is very active in the Indian Academy of Pediatrics, Tamil Nadu State Branch, and he has attended many of the conferences, and we have met in a couple of occasions as chairpersons, and we have also witnessed the hard work which he has been doing here as a leader of the team, the pediatric intensive critical care team, as well as the neonatal intensive critical care team, where he has saved so many lives and many children are coming at the last moment, and he is able to do a great service with the limited resource setting. So I want to really appreciate you, sir, for the very hard work you have been doing. And now he will be talking about congenital adrenal hyperplasia, which is one of the very important endocrine problem in newborn period.
Yes.
Okay, so over to you.
Thank you, sir, for the warm welcome. It's my privilege to invite Dr. Ramanathan, sir, to deliver his talk.
Good afternoon, ladies and gentlemen, boys and girls. It's a pleasure for me to be standing here in front of our Dean, who is the chairperson for this topic. So in the next half an hour, I will be talking to you about this therapeutic landscape of congenital adrenal hyperplasia. I'll make sure that I'll keep it very short and brief and try to give only the important points because it is a very vast topic. So the learning objectives at the end of the session, I would like all of you to be to understand the pathophysiology of congenital adrenal hyperplasia, to identify what are the various types of congenital adrenal hyperplasia, how do you recognize each of these types clinically, and how do you interpret these diagnostic investigations that are done, and to know the acute and long-term complications of this particular condition. So at the end of the session, if you are aware of these things, our job is done well. Just to give you a brief idea of how this adrenal gland is there, as all of you know, it's a very small gland which is located above the kidney. So நம்ம தமிழில் சொல்கிற மாதிரி இந்த சின்ன பையன் என்ன ஆட்டம் போடுறான் பாருன்ற மாதிரி இவ்வளோ சின்ன ஒரு பொருள் வந்து பாடியில் it has got so many functions that it takes care of so many things in our body. So we have to give importance to this particular gland, and this adrenal gland is, you can see there, it is further subdivided as zona glomerulosa, fasciculata, reticularis, and the adrenal medulla. This glomerulosa, it produces the mineralocorticoids. This fasciculata produces the cortisol. Then this reticulosa produces the adrenal androgens. Then what is inside is the adrenal medulla, which presents the adrenaline and noradrenaline. So all these hormones, which are very, very essential for our day-to-day functioning, is all being produced by this adrenal gland, which is above the kidney. So when something wrong happens in the adrenal gland, the feedback goes to the pituitary or the hypothalamus, and it says, okay, you have to grow some more. So instead of the hormone being produced, the feedback says the gland alone is going to be enlarged. That is why the name, which is called as congenital adrenal hyperplasia. There is hyperplasia of the adrenal gland, but unfortunately the hormones are not present in the body. So only the substrates and the other alternative pathways are more. So here the most common, how do we define this congenital adrenal hyperplasia? It is an autosomal recessive disorder. As for many students are here, so autosomal recessive means there is 25% chance of transmission. So if there are 4 children who are born in the family, one child has got high possibility of acquiring this deficiency, disease. And it is a deficiency of enzymes of steroid synthesis. So all of you should be aware of this steroidogenesis, and I think biochemistry department would have taught you very well about how this steroidogenesis happens and how it starts from the cholesterol and ends into the various end products. So because of the deficiency, there is a wide spectrum of disease. Some children will come very serious, some children will come without any symptoms. You have to go and examine them and find out what is wrong with them. So if they give you a clue in the neonatal period, then you can pick them up earlier. But unfortunately, sometimes they don't have a clue. So later in life, you have to measure all the other values and have a proper examination of the sexual maturity rating. So SMR will give you an idea of all these unusual hormonal problems which is happening in the body. So it presents in the newborn period as a salt wasting type and sometimes as a non-classic congenital adrenal hyperplasia in adulthood. So this is the various types. First we said what is congenital hyperplasia. Now I am trying to tell you what is the various types of CH. The most common, 90% or 80% of children will have 21 hydroxylase deficiency. The second will be followed by 11 beta hydroxylase, and the third one will be 17 alpha hydroxylase. These 3 beta hydroxylase and the POR deficiencies are very, very rare. So sometimes we always say think of the common things first. So always when it's congenital hyperplasia, you think it is most probably a 21 hydroxylase deficiency because you do not want to miss the worst. If you miss the milder forms, it's not a problem, but please don't miss the worst forms. So think of the common things first. So this is the various types. Then just a small slide about steroidogenesis. I know it's a very dry slide. You'll be a bit bored when you go through all these things. But unfortunately, only when you understand this particular slide, you will be able to follow the rest of the slides. So it starts with cholesterol, pregnenolone, 17-hydroxypregnenolone, and then progesterone, and then comes down to aldosterone, cortisol, and estradiol. As I've already told you, this is by zona glomerulosa. That is by zona fasciculata. The androgen is by zona reticularis. So these 3 areas are taken up differently. So when something wrong happens, either the end product is not formed or the substrate which is higher goes to the alternate pathway and produces the other type of hormones. So the end product is not formed, or it goes to the alternate pathway. So two things can happen. So they will have deficiency of a few hormones, and they will have excess of certain hormones. That is how they present. So you will have a mix and match of all these conditions depending on the various enzymes which are lost. I have given numbers for these various enzymes of 1, 2, 3 and 6. As we have already told, the commonest type is, what is the type which I told you? 21 hydroxylase. So that is number 3. So it helps in the conversion of 17 hydroxyprogesterone to 11 deoxycortisol. That is why we use this 17 hydroxyprogesterone as a screening test. Whenever you have disorders of sex development, previously when we were undergraduates, we used to call them as ambiguous genitalia. No more it is called as ambiguous genitalia or intersex. We have to use the word DSD, or disorders of sex development. So whenever you have a suspicion, we always do a 17 hydroxyprogesterone, because what enzyme is absent there? 21 hydroxylase. So the level of 17 hydroxyprogesterone goes higher. So we don't want to miss this severe salt wasting variety. So we do a 17 hydroxyprogesterone in all the newborns, so that you will pick up the 21 hydroxylase deficiency. You can see here 21 hydroxylase is stopping the conversion of progesterone to deoxycorticosterone and the 17 hydroxyprogesterone to 11 deoxycorticosterol. So what two hormones are not formed here? Aldosterone and cortisol, but it goes to the alternate pathway and forms what? Testosterone. So here you will have androgen excess. So the child will have a features of ambiguous disorders of sexual development and androgen excess, and they will have deficiency of mineralocorticoids and glucocorticoids. So because of deficiency of cortisol, they will have hypotension, they will have shock, they may have hypoglycemia. And because of mineralocorticoids, aldosterone is very important for what? Absorption of sodium and excretion of potassium. So sodium is not absorbed, potassium is not excreted, so you will have hyponatremia and hyperkalemia. So whenever the external genitalia in the newborn period is abnormal and you have an electrolyte abnormality with shock, this is the commonest triad of congenital adrenal hyperplasia. Because in the newborn, mostly what happens, we think of sepsis. Most of the times my PGs will say it is probably a sepsis. But if you do not have a look at the external genitalia, you will miss a salt wasting type of congenital adrenal hyperplasia. That is why our professors, when we were students, used to teach us of meticulous examination. We give importance to examining each and every part of the child. But nowadays it is all going to AI, so we are losing the art of this human touch and examining the patients properly. So 21 hydroxylase will have absence of aldosterone and cortisol and excess of testosterone. So this is a crowded slide, but just remember that salt wasting type is 21 hydroxylase. The other common type of salt wasting is a classic form of CHS, is a simple virilizing disease. That means they will have some amount of mineralocorticoids, but they will have some minimal amount of androgen excess. The other type is non-classical type. So classical and non-classical. Classical is further subdivided into salt wasting type and simple virilizing type. Non-classical does not have any features, so they become asymptomatic sometimes. You will not have to treat them sometimes at all. So these are all the various types of 21 hydroxylase deficiency, classic and non-classic. Classic is divided into salt wasting and simple virilizing form. So progesterone gets converted into aldosterone. Here 17 hydroxyprogesterone gets converted into cortisol. In this deficiency, you have low aldosterone, low cortisol and androgen excess. Because of low cortisol, you have all the features of a salt wasting, low cortisol of shock and hypoglycemia. Because of low mineralocorticoids, you have salt wasting. That means you are losing lot of sodium. Wherever sodium goes, water will go. No? Like boyfriends and girlfriends, wherever sodium goes, water will follow that. So whenever sodium lost, you lose water also in the body and you will have severe dehydration. So this is the common features that we will have. We'll have a newborn baby at 3 or 4 days old baby who will have vomiting, who will have abnormal pigmentation of the external genitalia. They will have abnormal genital appearance, which is called as disorders of sex development. They will have failure to thrive later in life, and they will have shock. In the electrolyte, because it's a biochemistry CME, you are going to concentrate on the investigation part also. They will have hyponatremia because sodium is not absorbed. They will have hyperkalemia because potassium is not excreted. Cortisol is important for sugar metabolism, so you will have hypoglycemia. Because of shock and poor perfusion, all your organs and tissues will have anaerobic metabolism and you will develop metabolic acidosis. Because lot of fluid is lost from the body, you have a concentration of the blood. So these are all the points that you will have a salt wasting type of 21 hydroxylase deficiency. So this is just to tell you how the external genitalia will look like. No? See, this looks almost like a male child. The clitoris has enlarged and it looks like a penis. Both the labia has become almost fused to the center and it look like a scrotum. So always palpate for testis in these type of children. If you are having a palpable testis in the inguinal region also, then it is probably a male. If you do not have a testis, then this could be a female which is virilized. I told you in the first slide itself, what is excess? Androgen. Because of this androgen excess, a female baby gets the shape of a male organ. So that's why we tell our postgraduates, whenever you have cryptorchidism or undescended tested, rule out congenital adrenal hyperplasia straightforward. Or when you have hypospadiasis, you have to rule out congenital adrenal hyperplasia. So you can see here how it is virilized, and it almost looks like a penis there, where there is a small opening which is called as a urogenital sinus. In congenital adrenal hyperplasia, we will not have a common, we'll have a common pathway of the vagina and the urethra going through one pathway which is called urogenital sinus. So labia majora will be fused, clitoris will be enlarged and look like a penis, and you will have a urogenital sinus. These are all the common external genitalia findings that you see in the newborn baby. This is an exaggeration of the same thing. See, even the scrotum has a rugosity. It looks just like a normal male scrotum, and there is, the labia is fully fused, and you have a small swelling above. So whenever you see this type of picture, just do one simple investigation of 17-hydroxyprogesterone. Just tell the biochemistry department, they are so active that they'll give it within 2 hours for you, and immediately you can start the treatment immediately. Because this turnaround time is very important for us. Whenever you send an investigation, we want it to come back to us as fast as possible. Otherwise, we wait for 1 or 2 days, the child will go for shock, and we will not give hydrocortisone, which is the line of management. When you delay the administration of hydrocortisone, we may lose these children. We have lost 1 or 2 children by not suspecting these things. So we learn by mistakes. Unfortunately, our mistakes are very costly. This is the only machine that cannot be sent back to the manufacturer. So our profession, you have to be very, very cautious, examine them properly, take care of the examination findings, and act fast. You cannot be slow. Immediately you have to investigate. Immediately you have to get the report. Then start the treatment. So this is an older child who was missed at newborn period, and see how this is a female child, but has developed all the characters of a male. It is more masculine, the hair structure is like that, breast is not developed properly. So you have children who are missed for CH and are reared up as male also. So what is the problem of these patients? The mother and father wants to know, how do we rear them? How do we rear them as a boy? Do we rear them as a girl? What is the gender thinking among the patient? So these are all the problems that we face in the clinical scenarios. Then this is the other form which I told you. First form is the salt wasting form. The second form is the simple virilizing form, where you will not, it will have, they will have some amount of mineralocorticoids. Aldosterone will be produced, so you will not have salt wasting. Whenever aldosterone is produced, salt wasting will not be there. Whenever cortisol, but most of the conditions, 99% of this congenital hyperplasia will have cortisol deficiency. So it is a problem of cortisol defect, but aldosterone may or may not be there. So you will only have some amount of virilization in the form of precocious puberty in boys, and sometimes the bone age will be advanced. Whenever your androgens are produced in excess, suddenly the child will become tall, and by adolescence it will stop growing. Bone age, somatic growth, skeletal age, everything will be rampant, but it will stop at a particular stage. So if somebody is growing very fast and the bone age is very advanced, think of any congenital adrenal hyperplasia. This is just to tell you an older child. See, you can see a female child who has got all these problems of congenital adrenal hyperplasia, and this is a 6-year-old child, but her height age was 8 and the bone age was 13 years. So endocrine problems, any endocrine problem, hypothyroidism, short stature, all these conditions, postgraduates and undergraduates should know how to estimate bone age. Without estimating bone age, you cannot move a step further in your diagnosis, because all these pathological conditions will have either delayed bone age or advanced bone age. So you can see here how this child, her brother who is 5-year-old was also considered abnormal. He was not considered abnormal by the parents, but look at his height age, it was 8 years and the bone age was 12.5 years. That is when you get a clue. So you have to get the bone age, and the SM or Tanner staging should be done in all children who are above 8 or 9 years. So that the third variety of congenital adrenal hyperplasia is 21-hydroxylase. What we are saying is the non-classic type. That means they will not have much clinical features. They may have some amount of minimal androgen excess, but both aldosterone and cortisol are produced normally in their bodies, so they will not come to you at all. It will be detected only by the probably an examination in the school or somewhere by some other clinician. So they will not be having any serious symptoms. So who is serious? 21-hydroxylase. What do they have? They lost both aldosterone and cortisol is less. Where do they go? Go to the androgens. See, this is hirsutism, where older children or older adults will have these girl. This is a female who has developed a lot of hair in the cheeks. So whenever they have these features, please think of any endocrine issues. Don't tell them it will become better by day. No, we have this habit of saying any complaint the patient comes, poga sariyadum. Whenever you are in doubt, investigate them thoroughly and convince them that it is normal or abnormal. How do you diagnose? What happens to the sugar? Cortisol less, so you have hypoglycemia. What happens to electrolytes? Hyponatremia and hyperkalemia. Then your ABG will have acidosis. Cortisol will be low or high? Low. Cortisol is low. So feedback, who is high? ACTH will be high. 17-hydroxyprogesterone, low or high? High. Then you do an ultrasound to find out what is the internal gonads. Parents want to know whether my child has ovary or my child has something uterus or what is it that my child has. So that is called as gonadotype. Then you want to do a genetic test of a karyotyping. So if you do karyotyping, it will take 6 weeks. Imagine a newborn baby, we are examining the newborn at birth, we come out, there are 50 people ready enna sex nu therinjikadhukku ange appadi oru periya kootam ready ah ninnirukom. You go and tell them enak konjam doubt ah irunga, konjam wait pannunga. Imagine your social situation that you are going to face there. You will have a terrible time there. You cannot do that in front of them. So somehow you have to try to convince and tell them that within a short span of time I will do a genetic test. Karyotyping will take 45 days. So go for fish. Fluorescent in situ hybridization will be, you will have the reports within 48 to 72 hours. So when you want to know the genetic chromosomal typing, you have to do a fish for rapid reports. So these are all the common investigations that we do in a case of congenital adrenal hyperplasia. Then prenatally also sometimes you can do a chorionic villus sampling. What is the earliest methodology of diagnosing antenatally is CVS by 12 weeks. Amniocentesis is done only by 20 weeks. So you cannot wait for 20 weeks because the fetus will be already formed. You will not have the decision of to terminate the pregnancy. So CVS is much earlier able to diagnose, and nowadays they are giving antenatal dexamethasone for the mother once the child is diagnosed with congenital adrenal hyperplasia in the antenatal period itself. So that is called fetal therapy. Whenever you are going to treat the mother for the benefit of the fetus, this is called as fetal therapy. Then this is one important thing that you all know. It's called dried blood spot. All newborn babies born are doing this test now in developed countries and in corporate hospitals. But in the government sector, we are also trying to push for this. We are doing TSH only now. We are doing screening for thyroid stimulating hormone. But they want us to do for 6 tests with a small drop of blood from the heel. So take a drop of blood from the heel of the newborn, put it on a filter paper. After 48 hours of life, send them for these 6 diseases. Out of these 6 diseases, one is our disease. What is that? 17-hydroxyprogesterone is screened for all newborns throughout the country. So we are also trying to push hard in our country to go for that particular test. So if 17-hydroxyprogesterone is higher, immediately we think of CH and start the patient on hydrocortisone, and we don't wait for them to go for salt wasting crisis, because that salt waiting comes only after 2 or 3 weeks. So we want to diagnose them before that or very early possible. So this is 17-hydroxyprogesterone at 48 hours. You have to do this test. Very rarely preterm babies, some postgraduates are here, premature babies will have high levels of 17-hydroxyprogesterone. So you should not be confused. So repeat a sample again if there is a high value. The other diseases which are screened are galactosemia, then biotinidase deficiency, G6PD. All these diseases are screened in the newborn period within 48 hours. So how do you do problem? Whatever is less you give, whatever is more you want to reduce. So what is less? Cortisol and aldosterone. So give hydrocortisone, give fludrocortisone. All these patients will be on lifelong hydrocortisone and fludrocortisone. Because the adrenal is not producing them, it will not produce at a later date. We will say 2 years la thiruppi vandruma appadina appa amma keppanga, 5 years la vandruma. No, this will be there required throughout your life. You have to supplement hydrocortisone and fludrocortisone. Then surgical management. No, if there is a big clitoris, it's a big social problem for the patient. So you have to reduce the size of the clitoris, create a vagina, vaginoplasty, some reconstructive surgeries, so that you want to help the child to be reared as a female. This is a female with virilization, but unfortunately it has male gonads. It looks like a male genitalia. So you do some constructive surgeries and make the patient confident that you look like a female. And antenatal screening, I already told you, you can do a chorionic villus sampling, and if it is positive, start them on dexamethasone. Glucocorticoids, for some of you to know, the dose is 15 to 20 mg per meter square of hydrocortisone daily. Every day you have to give glucocorticoids. So when you give glucocorticoids, you have to be careful that they may have overweight. Weight may become more, bones may become abnormal. All the effects of corticosteroids has to be followed up. So maintain this level properly and check the doses of overload. So how is their puberty, how is their skeletal maturation, all these things should be followed up whenever children are on chronic steroid therapy. We prefer hydrocortisone more than prednisolone because of its short half-life. So it does not stay in the body for a long time, and the side effects are lesser when compared to prednisolone. So supplement hydrocortisone throughout the life. Mineralocorticone, what tablet I told you? Fludrocortisone. What is less? Sodium is less or more? Less. So you have to give sodium tablets also. Nowadays sodium chloride is available as tablets. What we take is salt in a daily diet, but it is available as oral tablets. So supplement them as oral tablets along with mineralocorticoids in the form of fludrocortisone. Simple virilizing disease, very low doses of hydrocortisone or fludrocortisone will help. When you give too much of mineralocorticoids, fludrocortisone, it increases the blood pressure. So you have to monitor the blood pressure when you are giving fludrocortisone, because aldosterone will try to increase your blood pressure. Then the next thing which I told you is 11 beta hydroxylase. This is 11 beta hydroxylase, which is problem is F. So what is more? Deoxycorticosterone and deoxycorticosol. So what two are not formed? Same type, aldosterone and cortisol. What is more? Androgens. But unfortunately here this 11 deoxycorticosterone acts like a aldosterone. So here you will not have mineralocorticoids deficiency. So what is not there? Salt wasting will not be there. So you will have hypertension. One variety of CAH which has hypertension is 11 beta hydroxylase. The word that we use to tell our postgraduates is when the number starts with 1, they will have hypertension. When the number ends with 1, they will have androgen excess. So 21, it will have what? Androgen excess. 11 beta hydroxylase will have hypertension. 17 alpha hydroxylase will have hypertension. So when the number ends with 1, it has androgen excess. When the number starts with 1, it has hypertension. Because you have to know which CAH types will have hypertension. So again the same features, because I told you they will have hypertension with some amount of ambiguous genitalia because of androgen oversynthesis. Then the other enzyme which I told you 17 alpha hydroxylase. So it stops this part itself. So what alone is produced here? Only fludrocortisone or aldosterone. What is not produced? Cortisol and testosterone. So both these things are not produced. So what will they have? Salt wasting or not? Cortisol is not there. So salt wasting will be there because there is no production of cortisol and mineralocorticoids. Salt wasting will not be there. So they will only have what? Cortisol deficiency, and they will have lack of androgens. So here you will have less androgen. So hypoglycemia and some amount of hypogonadism. Your gonads will not be formed properly. So that we call it as sexual infantilism. That means a female child or 12 or 13-year-old will have a external genitalia like that of a 2 or 3-year-old. So it is very, very infantile. That is called sexual infantilism because androgens are less, cortisol is less, but aldosterone is normal. So you will not have salt wasting in this particular type. So the same thing I'm just trying to put in a slide here. It's an overcrowded slide. Then the last type is 3 beta hydroxy steroids. The word itself says 3. So it blocks what? All the 3. Nothing is formed. No aldosterone, no cortisol, no testosterone. So they will have salt wasting. They will have hypoglycemia, cortisol problems. They will also have androgen less effects of androgen. So with these particular types of deficiencies, you have to think of the clinical features. This is again the same thing which I am trying to expand. So this is for maybe for PGs or UGs may be helpful. Some of the various deficiency enzymes, what will happen, what is the product, how is the androgen, how is the mineralocorticoid, and what is the percentage. So more than 90% is what? 21 hydroxylase. 5% is 11 beta hydroxylase. Very rarely other types are there. So only if you know about the first 2 types, most of the conditions you can be able to treat them properly. So gender of rearing, no, we have a problem sometimes. They will say, I want to go to the girls' hostel, I want to come to the boys' hostel, I would like to be a boy. I have many children who comb like a boy, who wear shirts and pants. They like to be reared like that. So give respect to their decision. Always respect what the particular child or the patient wants. 6 or 7 years, you cannot force something into them. Their mind is behaving like that. You don't tell them, no, you have to dress like this, you have to dress it. Because give them respect of what gender they want to become, gender of rearing, and probably what is be helpful for them. You can guide them saying, okay, this is a female child. So if you do a vaginoplasty and resist the clitoris, you can bring up like a female child itself. So think of XX disorders of sexual usually reared as females. XY disorders of sexual development usually reared as male. Very rarely androgen insensitivity syndrome, female gender is preferred because there is no sensitivity of androgen. You cannot rear them as a male, so you have to rear them as a female. But all other conditions, according to their chromosomes and karyotyping, you rear them as a male or a female. This is the very crowded and a toxic slide. So like now we are in touch with Gen Z kids, so we are using these words, sir. So don't worry about this. Just go through all these points. I will share the slides to others. So the enzyme which starts with 1 will have what? Hypertension. Ends with 1, androgen excess. Then 3 things are essential whenever you have a child with disorders of sex development. What is the first one? Genotype. How do you do that? Chromosomal analysis. Gonotype. How do you do that? It is inside. So can you touch and see? Ultrasound. Phenotype, which is seen outside. So all these 3 things are very, very essential when you have a disorders of sex development. Check their gonads, check their chromosomes, check their phenotype. Examine pannunga, ulla scan edunga, take a chromosomal analysis. When you do all these things, you know that if there is a mismatch between genotype and phenotype, that is the hallmark of disorders of sex development. It's not only a medical emergency, as I told you, when you are standing outside the delivery room, it is a social emergency, no medical, surgical sort of emergencies. This is a social emergency where the parents and the attendants and the relatives wants to know exactly what is happening to the child, whether it's a male or a female child. So your mind voice now, I can understand. So I tried to confuse you maximum, but unfortunately this is my biochemistry. I'd like to thank Tamil madam for giving this opportunity and to discuss about this. And just take home message, what is the commonest type? 21 alpha hydroxylase. Will it have salt twisting? Few forms will have salt twisting. Hypertension, which types? 17 alpha hydroxylase and 11 beta hydroxylase. Virilization, 21 alpha hydroxylase. Treatment, glucocorticoid, mineralocorticoids, if necessary sodium supplementation. Androgen excess, you don't have to do anything. Just if you supplement corticosteroids, the androgen will be suppressed. No need to give anti-androgen drugs in these patients. Just give them corticosteroid, they will become better. So what I am today, I thank my alma mater. This is the institution which had brought me to this stage. I was sitting there as a student. Now I am sitting on this side. So I thank my medical college, and I am proud to be a student of Raja Mutya Medical College. Thank you.
Thank you, sir, for that enlightening and informative session. Your valuable insights on the management of congenital adrenal hyperplasia have truly enriched our understandings. I request our respected Dean sir to share his thoughts on this session.
Yeah, it was நானும் அப்படியே ஒரு ஸ்டூடெண்ட் மாதிரியே மாறிட்டேன். So excellent presentation on a very difficult subject, I would say. You know, it is more of hormones, more of various clinical presentations, confusing the neonatologist or the pediatrician, the social problem as well. So you have nicely explained, beautifully explained to the level of an undergraduate student by tables and using the various slides in a beautiful way. This, I think it's by artificial intelligence. Yes, yeah. So wonderful. So super. And I think everybody would have learned a lot of things.
Thank you, sir.
So only one question to the audience. Sir was telling, what is the prevalence of congenital adrenal hyperplasia? Community medicine nalla naanga andha vaartha dhaan kepom. Prevalence, classical form. What is the prevalence? Evlo perukku varum? Is it very common? So it's around 15,000, 1 in 15,000 to 1 in 16,000. That's the prevalence of the congenital adrenal hyperplasia. So sir was telling males, females, both sexes are vulnerable. Are both sexes vulnerable, or only the girl children are vulnerable? Both sexes. But easily presented and easily making a diagnosis only by the girls. Okay, that is one of the thing. And otherwise sir beautifully explained what is the test to be done, what is the dried blood spot, are we doing routinely for all our newborns, what are the tests being done, and which is the one of the race having this congenital adrenal hyperplasia is a problem. One race is having this problem, Jewish race. One of the Jewish race, they are having this problem of congenital adrenal hyperplasia. So once again I want to appreciate my friend Dr. Ramanathan for the nice presentation. Thank you.
Thank you, sir. I request our HOD ma'am to share a few words.
Sir, first I would like to thank our beloved Dean for chairing this session amidst his busy schedule. Next, I would like to thank our speaker, Dr. Ramanathan sir, for his enlightening session. It was really wonderful, sir. Such a complex topic made into very easy concepts. Thank you, sir, with mnemonics.
Thank you, ma'am. The session is now open for the queries. Any queries from audience side? So if there is no further queries, I now hand over the mic to Dr. Satyachitra ma'am for fun game.
Here is the next fun session. Before that, the exclamatory point. There is no Cushing features in pregnancy despite high cortisol. This is because in pregnancy there is increased estrogen which increases the hepatic cortisol binding globulin. Also there will be upregulation of hypothalamus pituitary adrenal axis. All these will increase the total cortisol of 2 to 3 folds. This increased total cortisol is essential for fetal development and labor progression. But there is only total cortisol is increased. The free cortisol, which is functional form, is normal. That is why there is no symptom of hypercortisolism. This is an exclamatory feature. Moving on to the fun part, the same rules. Those who know the answer can stand up and say BioEndora. Yes, here is the music. You have to find out the movie and also you should say the actor name. Say BioEndora. Stand up and students. Yes, answer please.
Maunaragam. Lead actor Karthi and Mohan.
The answer is right. May I request Dr. Nandisha sir to give the prize to Dr. Santosh.
Thank you, ma'am, for that. Thank you, sir.
On to our next and last scientific session titled Signal Saboteurs. The topic for this session is biochemical and clinical implications of endocrine disruptors. Endocrine disruptors are ubiquitous environmental chemicals that silently interfere with normal hormonal signaling. This session promises to explore their biochemical basis and far-reaching clinical significance in modern healthcare. I now invite Dr. Anita Shri Ma'am to kindly present the chairperson's profile to the gathering.
Students, sit down, please. Sit, go and sit. Take your seats, Pa. Another 15 minutes you can leave. Take your seats. Good morning, everyone. It's a distinct honor and privilege to introduce our chairperson for this session, our own HOD ma'am, Dr. Tamilmani ma'am. She's a distinguished academician and leader in the field of biochemistry and serving as a professor and head of the department. And she has nearly 13 years of teaching experience. Her journey began with her undergraduation at KAPV Medical College, Trichy, and then followed by post-graduation in the prestigious Stanley Medical College, Chennai. Beyond the classroom, Madam has held several significant leadership roles, including serving as a former chairman of the institution's Scientific Research Committee for DNB and the former secretary for Kadlur IMA. A deeply committed educator, she has undergone advanced medical education training at JIPMA and CMC Vellore. Her expertise is widely recognized, and she has served as resource faculty for medical education units. Her scholarly contributions are reflected in numerous publications in both national and international journals. With a special interest in innovative teaching methodologies and genetics, she brings with her a wealth of knowledge and experience. We are privileged to have her with us today to chair the session. Please join me in extending a warm welcome to Madam to be chair of the session. Thank you, ma'am. Please introduce our speaker also, ma'am.
Thank you, Dr. Anita Shri. So, please. I take privilege in introducing our next speaker, Dr. Nandisha, Professor of Biochemistry, Jipmar Puducherry, who has come all the way to enlighten you here. With over 20 years of teaching and research experience, he has made remarkable contributions to academics and biomedical research as well. Holding MBBS, DNB, MD degrees, he has impressive research profile with numerous publications, book chapter contributions, prestigious awards, major funded research projects for his credit. A respected academician and researcher, actively involved in professional scientific societies in biochemistry and flow cytometry. We are very proud and happy to have him here. More than that, he's a very humble person, easily approachable, friendly person. Thank you so much for coming, sir.
Thank you.
Over to you, sir.
So first of all, I will thank Madam for inviting me for this talk. I think I am co-examiner with Madam in many colleges. So I think it's my privilege to give a talk in front of the Madam. Okay. So today I know it's lunch time. Everyone is waiting for lunch. So I won't take too much time. I will try to finish at the earliest. So my topic is endocrine disruptors. Disruptors means nothing but chemicals. So biochemical implications means what are the mechanisms that these disruptors will affect the metabolism of hormone, maybe it's synthesis, secretion, or metabolism. Okay, and clinical implications. What are the disorders associated with these endocrine disruptors? So my objectives are what are the different types of endocrine disruptors, what are their sources, then I will discuss about their mechanism of action and disorders associated with them, and one or two slides about methods of estimation. So I think all of us are exposed to various types of chemicals, various types of pollutants. Okay, some of these pollutants usually they affect the endocrine signaling system. Okay, they will affect the synthesis or signaling or function. So these chemicals are collectively known as endocrine disrupting chemicals or endocrine disruptors. So these are the chemicals which affect the function of endocrine system or which can cause us adverse health effects. So these disruptors, they can affect synthesis of hormones, they can affect the transport of hormones, the secretion of hormones, or binding of hormones with the receptor, thereby affecting the function. Also the metabolism of hormones. Why it is a global health concern? Because endocrine disruptors have been reported to associated with increased prevalence of infertility rates, metabolic disorders, some hormone dependent cancers like prostate cancer, ovarian cancer, and breast cancer. Also some neurodevelopmental abnormalities, mainly ADHD and autism disorders. So I think some studies have shown that in European countries, I think they are spending billions of euros to tackle these issues. What is the scenario in India? So as all of us are aware that we are exposed to high dose of these EDCs because we are adapted to these pesticides, we are adapted to these using these plastic containers. Also because of industrial waste contamination, we are exposed to these EDCs. So what is the health impact of these EDCs? I think high risk groups are reportedly in pregnant women and in children. And it has been reported that around 108 million Indians are affected with metabolic disorders because of these EDCs. Also, 1 in 8 children in the age group of 2 to 9 years, they are more prone to get this neurodevelopmental disorders because of EDCs. If you ask me what are the number of potential EDCs, I think we don't have any answers. So according to the reports, more than 4,000 chemicals are reported as EDCs. Some of them are industrial chemicals, they may be agricultural chemicals, pharmaceuticals, plastic additives, also heavy metals. Yeah, it's coming. So if you look at the sources of these EDCs, I think we have heavy metals like cadmium, mercury, lead, arsenic and others. Some pharmacological compounds like diethyl stelbestrol, pesticides like methoxychlor, chloropyrifos, other things. Some industrial chemicals like PCB, PBB and dioxins. Also some personal care products which you are using routinely. They are rich in parabens, phthalates, these fragrances and glycol ethers. Coming to the industrial chemicals which act as endocrine disruptors are polychlorinated biphenyls, dioxins and polybrominated diphenyl ethers. So these are organic pollutants that accumulate in our food chain either through food intake or through water intake. So these can cause adverse metabolic and reproductive effects. Agricultural chemicals which act as disruptors are mainly the DDT, endosulfan. I think endosulfan, if you remember a few years back, there was an issue in Kerala. So a lot of health issues were affected, reported, and endosulfan was banned. Okay, atrazine. So how these compounds act, mainly they interfere with binding of steroid hormone with the receptors. So they can affect the function of steroid hormones, also the function of reproductive hormones. So plasticizers, where we are used to using the plastic containers which are rich in bisphenol A, phthalates and alkyl phenols. So if you are using plastic containers either for food or water, usually you will get into our body and it can lead to various problems. So some of the drugs which are reported to be endocrine disruptors are, one is ketoconazole, which is used for the treatment of fungal infection. Then we have mitotane, which is used in the treatment of cancer. And we have etomidate, which is used in general anesthesia. So these can interfere with steroid hormone synthesis. Apart from that, we have phytoestrogens, which are naturally, which mimic estrogen and bind to estrogen receptor, and it can affect the function of estrogen. Some of them are gencitin, used in soybean, didazine, present in soybean and other legumes. Also resveratrol, we usually found in red grapes. So these are some of the adverse effects of EDCs. So some of these EDCs like BPA and organophosphorus and phthalates can affect brain development and brain function, resulting in autism, hypothyroidism or neurological disorders. So BPA, OP can also affect the cardiac muscle development and differentiation, leading to hypertension. So BPA and OP are associated with metabolic disorders. It can increase insulin resistance, obesity. It can affect the mobilization of calcium absorption and fat metabolism. Also it can affect gut microbiota. Some EDCs affect reproductive system, leading to gynecomastia, ovarian failure, and it disrupt the fertility. And BPA and OP are mainly associated with hormone dependent cancers, okay, like breast cancer, ovarian cancer, endometrium, prostate and testis cancer. So what are the common chemical routes of exposure? I think there are different routes of exposure for these EDCs. One is inhalation, one is ingestion, one is absorption through skin or eyes, and also through injection if you are using needles. So among these, the most common route is inhalation. So apart from that, it can transfer from mother to fetus, okay, through placental barrier, and these effects are known as transgenerational effects, leading to fetal anomalies. So EDCs are detected in breast milk, in umbilical cord blood, also in amniotic fluid, indicating that fetus are more prone to develop complications rather than adults. Since these EDCs are lipophilic compounds, they tend to accumulate in our tissues like adipose tissue, liver and breast milk, so that even if you are move out of that particular source or if you are away from this thing, still I think we are more prone to develop complications because of already accumulated EDCs in our body. So these are some of the disorders which we are going to discuss: reproductive disorders, developmental, neurological disorders, metabolic, and some immune disorders. So see, these are the common female reproductive disorders like infertility, PCOS, preeclampsia. Then we have abortion, preeclampsia. So common fetal anomalies are IUGR, congenital malformation like congenital heart disease and male urogenital anomalies. Also low birth weight is one of the complication. So male reproductive disorders, mainly EDCs, they are going to reduce the sperm count and alter the sperm morphology, resulting in impaired fertility. So it can lead to testicular agenesis syndrome characterized by cryptorchidism, hypospadiasis, that is abnormal urethral opening, reduced fertility, and testicular cancer. So neurodevelopment is since these EDCs affect brain development and brain function, so they can be associated with ADHD, attention deficit hyperactivity disorder, cognitive impairment, and autism spectrum disorders. So then we will move on to the mechanisms through which these EDCs can cause disturb the endocrine metabolism. So it can affect the hormone receptor interaction, it can affect the hormone synthesis, then it can affect the steroidogenesis. Then there are some epigenetic mechanisms through which it can affect, or some non-genomic mechanisms which we are going to discuss in the next few slides. And these are some of the endocrine glands which are more prone to develop complications or affected: pituitary gland, thyroid, adrenal, pancreas, and gonads. So we'll start with the pituitary gland. So EDCs usually affect the secretion of hormones secreted by pituitary gland like ACTH, growth hormone, and prolactin. So these EDCs can affect multiple pituitary axes like HPA axis, HPG axis, resulting in alteration in the hormones. Also they can stimulate pituitary cell proliferation, leading to abnormal secretion of hormones. So two mechanisms which are described are: one is aryl hydrocarbon receptor activation, and second is through oxidative stress pathway. So if you look at this aryl hydrocarbon receptor pathway, so these endocrine disruptors usually combine with AHR receptor which are present in the cell, and they form a complex. Once they form a complex, I think they will undergo two pathways, either genomic pathway or non-genomic pathway. So these complex can enter nucleus, they form a heterodimer with ARNT, that is AHR nuclear translocator. So these complexes bind with the promoter region in the DNA, that is XRE, xenobiotic response element, leading to expression of either cytokines or CYP1A1. So this CYP1A1 is responsible for degradation of these ligands, that is disruptors, whereas these cytokines can regulate our immune response. Okay. So non-genomic pathways, so interaction of these ligand AHR complex with other transcription factors like NF-kappa B, catenin, WNT, and other things. Also it modulates the calcium transport, which can regulate our immune response. So so these are the EDCs that are activating this AHR pathway: dioxins, PCB, and polycyclic aromatic hydrocarbons. So apart from this genomic and non-genomic pathway, so these signaling can also suppress estrogen signaling, and it can alter the reproductive functioning. So oxidative stress pathway is activated mainly by the EDCs like phthalates, BPA, and pesticides. So these EDCs tend to accumulate in the mitochondria, causing mitochondrial dysfunction. So once mitochondria is not functioning, then it lead to electron transport chain disruption. So electron transport chain ATP is not synthesized. So there is generation of reactive oxygen species. This can lead to reduction in antioxidant impairment. So ROS can also activate inflammatory signaling pathway like NF-kappa B, leading to generation of pro-inflammatory cytokines, leading to increase in inflammation. Also it can increase the lipid peroxidation, and it can cause DNA damage. So all these can contribute to various complications and various health issues. So thyroid system, as all of us are aware that thyroid hormones are known to regulate growth, brain development, and metabolic rate. So these EDCs can interfere with synthesis of thyroid hormones or signaling of thyroid hormones. So some of these examples are anti-thyroid drugs which are commonly used for hypothyroidism like perchlorate, thiocyanate, and nitrate. Some of the mechanisms are, first it can inhibit sodium iodide symporter. I think if you remember, this is the first step in synthesis of thyroid hormones, where iodine is uptake into the thyroid cells through this symporter. So that will be affected, which reduces thyroid hormone production. Second, these EDCs can compete with thyroid hormones for binding with their binding proteins like transthyretin or thyroglobulin. So this also can alter the circulating hormone levels. And finally, BPM act as thyroid receptor antagonist. So thereby it prevents thyroid hormones binding with its receptor. So all these effects can lead to reduction in T4 or T3 levels. It can alter the thyroid signaling, or it can leading to developmental abnormalities. So next is adrenal gland. So adrenal gland, as all of you are aware, it's rich in blood supply and lipid content is more. Okay, and leading to steroid synthesis. And these are the drugs which can affect this steroidogenesis: ketoconazole, etomidate, and mitotone. So EDCs can interfere with synthesis of steroid hormones, like it affect the key enzymes like CYP11A1, CYP17A1, then aromatase, 11-beta hydroxylase, and 3-beta hydroxysteroid dehydrogenase. So as already sir told, these are the enzymes involved in synthesis of thyroid hormones. Okay, this can lead to altered production of cortisol, aldosterone, androgens, estrogen, and other things. So apart from that, I think they can mimic steroid hormones and bind to their nuclear receptors like estrogen receptor, androgen receptors, thyroid hormone, retinoid X receptors, or progesterone receptors. So once it binds to the receptor, then it can have agonistic effect. So it will alter the transcription, it will alter the generation of proteins. Okay, so it will have agonist effect. There may be excess production of abnormal proteins which is not required, or it may have antagonist effect. So the proteins which are required may be reduced, okay, which are may not be in sufficient quantities, leading to either hyper or hypo condition. Next, I think little bit about xenoestrogens. So these are chemicals or compounds which mimic estrogen, which bind to estrogen receptor and prevent the functioning of estrogen. Some of the sources for xenoestrogens are sunscreen, bottled water, then some consumable we use for cleaning, birth control pills, so dyes used, artificial dyes used for as food additives, some cosmetics and perfumes. So these are the EDCs which behave as xenoestrogens like bisphenol A, alkyl phenols, and some DDT metabolites. So these compounds bind to estrogen receptors, both alpha and beta, and activate estrogen responsive element. So since I think it binds similar to estradiol, but the affinity is much lower, so it can have some agonistic effect. So endocrine disruptors can also activate membrane-bound estrogen receptors. One of the most common type is G protein coupled estrogen receptors, and EDCs which are responsible for this is BPA, non-enol phenol, and zearalenone. So this activation can trigger MAP kinase pathway. So you know that MAP kinase, I think it can further activate the downstream signaling pathway like JNK, ERK, leading to cellular proliferation, apoptosis, and other things. Then we have cyclic AMP signaling, mainly involved in metabolism. I think if you remember the glycogen metabolism, cyclic AMP signaling plays a role. So this can lead to intracellular calcium mobilization, causing various adverse effects. Apart from that, few epigenetic toxicity which are reported by EDCs are changes in acetylation, methylation, and ubiquitination. EDCs can also alter microRNA expression. For example, BPA strongly induces microRNA 146A. So this microRNA 146A is involved in the proliferation and differentiation of trophoblast, regulation of immune response, and also any alteration in this level can lead to gestational diabetes, antiphospholipid syndrome, and some inflammation. Okay, so phthalates can alter circulating extracellular vesicle microRNAs. So again, alteration in this level can lead to lung disease, can lead to heart disease, or can lead to cancers. Next, we'll move on to the obesogens. Okay, so these are again environmental chemicals that disrupt the metabolic process, promoting adipogenesis and weight gain. Some of the examples are parabens found in food preservatives, phthalates found in vinyl flooring, bipheноls found in dental sealants, then organotins found in disinfectants and others. So these can alter the fat cell development. They can reduce thermogenesis and impact appetite regulation, and they promote adipogenesis through activation of PPAR gamma, which is signaling this thing, and RXR receptors. So through these two pathways, it can promote adipogenesis. So coming to methods of estimation, we have various techniques available to measure these EDCs. We have GCMS to measure volatile pollutants like pesticides, PCB and dioxins. Then LCMS for non-volatile compounds like bisphenol A and phthalates. Then we have HPLC for separation and quantification of EDCs in biological samples. So these can tell you about the concentration. But apart from that, there are certain other assays which can detect the endocrine disrupting signals. Okay, for example, reporter gene assays which can detect the estrogenic and anti-estrogenic activity. Then we have receptor binding assay which can affect interaction of hormones with their receptors. Then cell-based assay which can assess the functional hormone response like steroidogenesis and cell proliferation. So these are some of the limitations which we are facing. So measurement variability. So we don't know, I think, whether what we have measured is exactly matching or this thing, because of short half-life of some chemicals. Also lack of standardized biomarkers. So whatever vendor is giving, we have to follow that one. So based on that, we have to diagnose. So research challenges are long latency period. So complex exposure mixture. I think since more than 4,000 chemicals are there, so we don't know what chemical exactly we are estimating. So just like that, we have to estimate. Okay, what are the standards provided by vendors? We can estimate only those things. And low dose chronic exposure, level may be low, but still patient is having symptoms. So it indicates that he is exposed for a longer duration. That's why I think he is having those problems. So some of the regulatory measures, I think several agencies are there. One is WHO, one is EPA. EPA is Environmental Protection Agency from US. So European Food Safety Authority. So these provide some guidelines to use these pesticides and other things. Some of the prevention strategies, I think all of you are aware. So reduce plastic use, avoid pesticide exposure, and promoting environmental monitoring. So future research include improved detection methods, longitudinal epidemic studies. Just we have to check which one causes what disorder and other things, and safer chemical alternatives instead of pesticides and other things. So to conclude, endocrine disruptors represent a major emerging environmental health problems. So they act through complex mechanisms which we have already discussed. So understanding their effects is critical for disease prevention and public health policy. So thank you for it.
Thank you, sir, for that thought-provoking and scientifically enriching presentation. Your valuable insights have greatly enhanced our understanding of this important topic. Now we have our chairperson, Dr. Tamilmani ma'am, to share her insights on this session.
Thank you so much, sir. It was so enlightening. Started from the different external factors, sir. So many would have noticed recent cosmetic usage. அது எந்த அளவுக்கு ஸ்கின்லேயே அப்சார்ப் ஆகிட்டு இட் இஸ் அஃபெக்டிங் எண்டோக்ரைன் சிஸ்டம்ஸ் அண்ட் ஆல்சோ இன்வெஸ்டிகேஷனு நிறையா இன்சைட்ஸ் கொடுத்தீங்க. தேங்க்யூ ஸோ மச் சார். கொஞ்சம் இந்த பெஸ்டிசைட்ஸ் வி குடன்ட் அவாய்டு இந்த ஃபுட்டில், அந்த ஃபுட்டில் ஆஃப்டர் மைக் அதான் சார் எனி
shops which sell these organic vegetables and organic okay, so I think such shops should come up. I don't know, I think whatever thing we are getting in this palamudir and other thing, whether it's organic or pesticide, that we don't know.
Any
but
types of cleaning before using and the mari effectiveness
I don't know, madam. I think we don't have
okay,
much.
Sir. Thank you so much, sir. Thank you so much.
Sir, India, I think I am not aware, sir. Maybe I think some Indian guidelines they would have like endosulfan. I told now it was banned actually, but I think different guidelines. I think we don't have any particular agency. That, yeah. That's what, sir. That government has to take this thing. Yeah, that's one. I think the pesticides they are reducing, but I think still people are using, so that we can't avoid.
Thank you, mom, for your valuable words and guidance. We now welcome any questions from the audience side. Are there any queries?
The morning session we end here. We'll join again for the afternoon e-poster presentation by the final year MBBS students at 2:30. Students can go for lunch and come back for afternoon presentation by 2:30.
like, hey, what's up, hello.
Good afternoon, one and all. We welcome everybody after the metabolic munch we had. to resume the sessions on e-poster presentation by the well-versed students of final year MBBS who are ready to launch their presentations. Before we dive into their presentation, we are going to kindle you with the endorphins. Now our exclamation for the endocrine exclamation for afternoon is cabbage is packed with goitrogens. A few may be exclaimed, while some are already familiar with this exclamation, that we know cabbage is packed with goitrogens because it activates an enzyme called myrosinase. Cabbage itself contains this enzyme, and also the substrate for the enzyme, glucosinolates, present in the cabbage itself on just cutting the cabbage or on digestion of the cabbage. So even if a raw cabbage is consumed, we are prone for this intake of this goitrogen. So this is going to block our sodium iodide symporter, which was the same thing that was mentioned in the previous session by Dr. Nandisha sir about the endocrine disruptors that are mimicking the goitrogen in cabbage that can block this sodium iodide symporter so that it does not allow the iodine to enter the thyroid cells and the synthesis of thyroxine itself is decreased. So this is one exclamation. You be careful when you are consuming the cabbage in any form as a samosa or as a fried rice. So next have the game, please. Ready all of you to get up and tell BioEndora so that you can come here and win your prize for the game. Identify this spot. Come, BioEndora, second boy after this girl. Yeah, you. Yes, come. Please come. Come forward, come forward. Come forward. Yes, cheer him, cheer him. Please, in the mic. We have both online and on-site audience waiting for your answer.
State of Hormuz. State of Hormuz.
Yes, Strait of Hormuz, correct. Can you please add on to the significance of the Hormuz?
Iran-USA war.
Yes, so we are in demand for?
Yes.
Yes, well said. Please receive your gift from Judge ma'am. Your good name, pa? Eril Vendan. Thank you, Eril. So, we are all awake now. Let's go to our presentations by young students. We call upon. Yes.
Yes, ma'am. Students list. உங்ககிட்ட கொடுத்தல ஸ்டூடண்ட்ஸ் லிஸ்ட் வச்சிருக்கீங்களா சார்? இருக்கு அவங்க மேம் கேக்குறாங்க சார். மேம் ஃபர்ஸ்ட்
So, ma'am, we are very happy and grateful for her indeed. Madam is very busy at Tanjavur Medical College, Senior Assistant Professor, General Medicine. She used to be running ICU, anga inga solittu such a busy schedule la ungalukkaga vara othirukanga. Please give a big round of applause for her to share her insights. So ninga present பண்றதுல எப்படி improve பண்ணலாம், definitely her inputs will be very useful to you. So madam oda introduction வந்து madam சொல்வாங்க.
Good afternoon all. I will like to introduce Dr. Venila ma'am. Ma'am, she is a judge today for our e-poster. Ma'am working as an assistant professor in the Department of Medicine at Tanjavur Medical College. Ma'am did his MBBS at Chengalpattu Medical College, and ma'am did when the DVL from Madras Medical College and MD General Medicine at Tanjavur Medical College. At present, ma'am is working as a senior assistant professor in the Department of Medicine at Tanjavur Medical College, and ma'am has a experience of 19 years of experience in government service and is various academic activities and clinical practice. Madam is interested in teaching and patient care and has a special interest in cutaneous manifestations of various disorders, and I welcome you ma'am for this session, today's session. Let us welcome ma'am. Good afternoon ma'am.
Good afternoon all. Kadalur Medical College, how you call yourself? We will call Chemcoids in Chengalpet Medical College. What do you call yourself? Huh? Huh? Oh. GCMC&H. Hello, hi. It's a big honor, and I thank Dr. Tamilmani ma'am, who was a very, very enthusiastic person in Tanjore Medical College. We really miss her. She gave so many teaching experience in the biochemistry as such, and you are very lucky to have her. Give her a big hand. You are having a very lucky HOD. She will be here with you for years together, and it's a big honor for me and privilege. And I will try to expose you to the clinical scenario as such in endocrine as such with my knowledge as a clinician in Medical College of Tanjore for more than 10 years. Here we go. Thank you. We'll call the presenters. Thank you.
So I had arranged another judge from Kalakurchi Medical College, Dr. Geeta, professor and HOD biochemistry. She is unable to come due to administrative emergency. Okay, so I'll be taking over as the second judge. You can start, Pa.
Good afternoon, everyone. Now we will move on to e-poster competition. Now I call upon Saravana Selvan to present on diabetic ketoacidosis, a serious and life-threatening complication of diabetes.
Hello, check. I am Saravana Selvan from MBS final year, here to present a topic on present a topic on diabetic ketoacidosis. Diabetic ketoacidosis name le irukku. Diabetic ketoacidosis, diabetes na random blood sugar more than 200, in the case 200 to 600 அது மாதிரி இருக்கும். நெக்ஸ்ட் வந்து கீட்டோசிஸ் வந்துட்டு என்னன்னா கீட்டோன் பாடிஸ் வந்து இருக்கும். நெக்ஸ்ட் வந்துட்டு மூணாவது வந்து அசிடோசிஸ் அப்படின்னா பிஹெச் வந்துட்டு லெஸ் தென் 7, நார்மல் வந்து 7.35 to 7.45. இங்கே வந்துட்டு லெஸ் தென் 7.3 கீழே இருந்துச்சுன்னா வந்துட்டு அசிடோசிஸ் இருக்கும். அது இல்லாமல் வந்துட்டு HCO3 வந்துட்டு நார்மல் HCO3 வந்துட்டு 22 to 26 மில்லி ஈக்குவலன்ஸ் per லிட்டர். இங்கே வந்துட்டு லெஸ் தென் 15 to 18 அதுக்கும் கீழே இருக்கும். ஸோ இந்த 3 கண்டிஷன்ஸும் அது நம்ம 3 கண்டிஷன்ஸும் அது சாட்டிஸ்ஃபை ஆச்சுன்னா அது வந்து டயபெட்டிக் கீட்டோசிடோசிஸ். டயபெட்டிக் கீட்டோசிடோசிஸ்னா இட்ஸ் வந்து எமர்ஜென்சி சீரியஸ் காம்ப்ளிகேஷன் ஆஃப் த டயபெட்டிஸ். இது என்னென்னா ஃபஸ்ட் வந்து பேத்தோஃபிசியாலஜி என்னென்னா பேத்தோஃபிசியாலஜி என்னென்னா இது இன்சுலின் லெவல்ஸ் கம்மியாகும். இன்சுலின் லெவல்ஸ் கம்மியாச்சுன்னா பாடியில் இன்சுலின் இல்லைன்னா குளுக்கோஸ் வந்து க்ளூட் ரிசெப்டார்ஸ் வழியாக என்ட்ரு ஆகும் செல்ஸ். ஸோ க்ளூட் ரிசெப்டார்ஸ் வழியாக என்ட்ரு ஆக முடியலன்னா செல்ஸால் வந்து எனர்ஜி வந்துட்டு கன்சியூம் பண்ண முடியாது. ஸோ வந்துட்டு அதுக்கு பதிலாக குளுக்கோஸ் பதிலாக வேறு ஆல்டர்னேட்டிவாக அதாவது ஃபேட்டி ஆசிட்ஸ் வந்து ஆக்சிடைஸ் பண்ணும். ஃபேட்டி ஆசிட் ஆக்சிடைஸ் வாங்கினா ஃபேட் ஆக்சிடைஸ் ஆகிற ஃபேட்டி ஆசிட்ஸ் வரும். ஃபேட்டி ஆசிட்ஸில் வரதால கீட்டோன் பாடிஸ் வந்து வரும். கீட்டோன் பாடிஸ் வந்துட்டு ஆசிடிக் இன் நேச்சர். ஸோ ஆசிடிக் இன் நேச்சர் இது என்ன பண்ணால் இது வந்து செரிப்ரல் அந்த பிளட் பிரெயின் பேரியர் வந்துட்டு டேமேஜ் பண்ணும். பிளட் பிரெயின் பேரியர் டேமேஜ் ஆச்சுன்னா குளுக்கோஸ் வந்துட்டு உள்ள வாட்டர் வந்து என்ட்ரு ஆகும். ஃபஸ்ட்டு குளுக்கோஸ் என்ட்ரு ஆகும், குளுக்கோஸோட சேர்ந்து வாட்டரும் என்ட்ரு ஆகும். ஸோ இட் காசஸ் செரிப்ரல் எடிமா. செரிப்ரல் எடிமா வந்து மோஸ்ட் ரொம்ப சீரியஸான காம்ப்ளிகேஷன். செரிப்ரல் எடிமானால என்ன ஆகும்னா கோமாக்கு போகலாம், ஆல்டரேஷன் சோடியம் GCS ஸ்கோர் கம்மியாகும். நெக்ஸ்ட் வந்துட்டு இந்த அசிடிக் நேச்சர் வந்துட்டு என்னென்னா அசிடிக் நேச்சர் என்ன பண்ணுன்னா வந்துட்டு ரெஸ்பிரேட்டரி சென்டர் வந்துட்டு ஸ்டிமுலேட் பண்ணும். ரெஸ்பிரேட்டரி சென்டர் ஸ்டிமுலேட் பண்ணுறதால என்ன ஆகும்னா அவங்க வந்துட்டு அசிடோட்டிக் ஹைப்பர் வென்டிலேஷன் நிறையா ஹைப்பர் வென்டிலேட் பண்ணி நிறையா கார்பன் டை ஆக்சைடு வெளியே போயிடும். ஸோ வந்துட்டு PCO2 வந்துட்டு பாடியில் கம்மியாயிடும். நெக்ஸ்ட் வந்துட்டு வாமிட்டிங் சென்டர் வந்துட்டு ஸ்டிமுலேட் பண்ணும். கீட்டோன் பாடிஸ் வந்து வாமிட்டிங் சென்டர் ஸ்டிமுலேட் பண்ணுறதால என்ன ஆகும்னா வாமிட்டிங் ஆகும். வாமிட்டிங்கால என்னென்னா ஃப்ளூயிட்ஸ் ப்ளஸ் வந்துட்டு எலக்ட்ரோலைட்ஸ் வந்து லாஸ் ஆகும். நெக்ஸ்ட் வந்துட்டு என்னென்னா வந்து பாலியூரியா. ஏன்னா வந்து இது வந்து பிளட் சுகர் வந்து 200 மோர் தென் 200 இருக்குது. ஸோ தட் வந்துட்டு யூரினில் வந்துட்டு ஒரு த்ரெஷ்ஹோல்டு, அந்த த்ரெஷ்ஹோல்டு 140 to 199 வந்து த்ரெஷ்ஹோல்டு. அதுக்கு மேலே போச்சுன்னா யூரினில் வந்துட்டு குளுக்கோஸ் வந்துட்டு எக்ஸ்க்ரீட் ஆகும். ஸோ வந்துட்டு குளுக்கோஸ் சேர்ந்து யூரினில் குளுக்கோஸ் போகிறதுனால சேர்ந்து வாட்டரும் சேர்ந்து போகும். வாட்டர் சேர்ந்து போகிறதுல சோடியமும் சேர்ந்து போகும். ஸோ வந்து சோடியம் லாஸ் இருக்கும், பொட்டாசியம் லாஸ் இருக்கும், எல்லாமே இருக்கும். நெக்ஸ்ட் மோஸ்ட் காமன் காஸ் ஆஃப் டெத் வந்துட்டு செரிப்ரல் எடிமா. நெக்ஸ்ட் வந்துட்டு இது இந்த சைடு லாஸ் மேலே. நெக்ஸ்ட் இன்வெஸ்டிகேஷன்ஸ் பார்த்தீங்கன்னா வந்துட்டு சொன்ன மாதிரி பொட்டாசியம் லெவல்ஸ் லெஸ்ஸாக இருக்கும், ரேண்டம் ஆர்பிஎஸ் வந்து அதிகமாக இருக்கும், சோடியம் வந்துட்டு கம்மியாக இருக்குது. ஏன்னா வந்துட்டு நான் சொன்ன ரீசன் தான் அது, கேஎஃப்டி அதிகமாக இருக்கும். நெக்ஸ்ட் வந்துட்டு இதில் வந்துட்டு ஆனியான் கேப் வந்து அதிகம். ஏன்னா வந்துட்டு பாடியில் வந்துட்டு சோடியம் பொட்டாசியம் வந்துட்டு லாஸ் ஆகுது. சோடியம் பொட்டாசியம் லாஸ் ஆகிறதுனால என்ன ஆகுதுன்னா பாசிட்டிவ் அயன்ஸ் எல்லாம் வெளியே போயிடுது, ஆனால் நெகட்டிவ் அயன்ஸ் வந்து பாடிக்குள்ளே தான் இன்னும் இருக்குது. ஸோ தட் இந்த ஆனியான் கேப் வந்து அதிகமாக இருக்கும். ஸோ இதுதான் வந்து ஹேக்மான்வாங்க, ஹை ஆனியான் கேப் மெட்டபாலிக் அசிடோசிஸ். நார்மல் ஆனியான் கேப் வந்துட்டு 12, அது சோடியம் ப்ளஸ் பொட்டாசியம் மைனஸ் குளோரின் ப்ளஸ் HCO3. இதான் வந்து ஆனியான் கேப் ஃபார்முலா. நெக்ஸ்ட் பேஜ். நெக்ஸ்ட் இப்போ வந்துட்டு கிளினிக்கல் ஃபீச்சர்ஸ் நாசியா இருக்கும், வாமிட்டிங் சொன்ன மாதிரி இதாகும். நெக்ஸ்ட் வந்து எபிகாஸ்டிக் பெயின் வந்து மோஸ்ட் காமன் காஸ். ஏன்னா வந்துட்டு இது வந்துட்டு நிறைய பேர் மிஸ்டயக்னோஸ் பண்ணுவாங்க, அக்யூட் அப்பெண்டிசைட்டிஸாக மிஸ்டயக்னோஸ் பண்ண சான்ஸ் இருக்குது. ஸோ நெக்ஸ்ட் ஸ்டூப்பர், பாலியூரியா அதெல்லாம் சொன்னது தான். நெக்ஸ்ட் எக்ஸாமினேஷன் ஃபைண்டிங்ஸ் வந்துட்டு ஃப்ரூட்டி ஆர்டர் இருக்கும், த்ரெடி பல்ஸ் வந்து வீக்காக இருக்கும், டிக்ரீஸ்ட் பிபி இருக்கும், ஸ்மால்ஸ் பிரீத்திங், அதான் அசிடோட்டிக் ஹைப்பர் வென்டிலேஷன் இருக்கும். கீழே கிரேடிங்ஸ். நெக்ஸ்ட் கிரேடிங். இது வந்துட்டு என்னென்னா இப்போ வந்துட்டு நமக்கு வந்து இன்வெஸ்டிகேஷன் ஆஃப் சாய்ஸ் வந்து என்னென்னா பிளாஸ்மா, பீட்டா ஹைட்ராக்சி பியூட்டேட், மொத்தம் 3 கீட்டோன் பாடிஸ் இருக்குது. அசிடோசிடேட், அப்புறம் பீட்டா ஹைட்ராக்சி பியூட்டேட். இதில் மோஸ்ட் அசைக்கு வந்து பீட்டா ஹைட்ராக்சி பியூட்டேட் தான். அதில் வந்துட்டு மோஸ்ட் இன்வெஸ்டிகேஷன் ஆஃப் சாய்ஸ் வந்து என்னென்னா பிளாஸ்மா, பீட்டா ஹைட்ராக்சி பியூட்டேட் தான். ஸோ அந்த பிஹெச்சும் பிளாஸ்மா, பீட்டா ஹைட்ராக்சி பியூட்டேட் வச்சு நம்ம வந்து மைல்டு, மாடரேட், சிவியர் 3 பிரிப்போம் பிஹெச் வச்சு. மோர் தென் 8னா சிவியர் கண்டிஷன் தான் நம்ம வந்துட்டு ஐசியூவில் அட்மிட் பண்ணுவோம். சிவியர்னா என்னென்னா பிஹெச் வந்துட்டு less than 7 இருக்கும், பீட்டா ஹைட்ராக்சி பியூட்டேட் வந்துட்டு மோர் தென் 8 இருக்கும். நெக்ஸ்ட் வந்துட்டு கீட்டோஸ்டிக்ஸ்னா யூரினில் இருக்க யூரினில் வந்துட்டு கீட்டோன் பாடிஸ் வந்து இது பண்ண யூஸ் ஆகும். இதில் என்ன லிமிட்டேஷன்னா இது வந்து அசிட்டேட் மட்டும்தான் இது வந்து மெஷர் பண்ணும். ஆனால் அசிட்டோசிட் வந்து என்ன ஆகும், அசிட்டோசிட் வந்துட்டு அசிட்டோனா வந்துட்டு பிரேக் டவுன் ஆயிரும். ஸோ அதனால் நமக்கு வந்து அந்த கரெக்ட் வேல்யூ கிடைக்காது. ஸோ இது வந்து ஒரு லிமிட்டேஷன். நெக்ஸ்ட் வந்து இது வந்து என்னதான் அசிடோசிஸாக இருந்தாலுமே நம்ம வந்துட்டு மற்ற அசிடோசிஸ்க்கு வந்து நம்ம சோடா பைகார்பனேட் கொடுப்போம். ஆனால் இந்த கண்டிஷனில் இருக்க பேத்தோஃபிசியாலஜி என்னன்னா இன்சுலின் கரெக்ட் பண்ணால் மட்டும்தான் நமக்கு வந்து இதாகும். நெக்ஸ்ட் ஆன்டிஎமிட்டிக்ஸ் வந்துட்டு நோ ரோல் இன் ஆன்டிஎமிட்டிக்ஸ். நெக்ஸ்ட் ரெகுலர் இன்சுலின் வந்து இது கொடுப்பாங்க. ஏன்னா வந்துட்டு ரெகுலர் இன்சுலின் தான் வந்துட்டு ஐவியில் கொடுக்குற ஒரே இன்சுலின் வந்து ரெகுலர் இன்சுலின் மட்டும்தான், மற்ற எந்த இன்சுலினும் ஐவியில் கொடுக்க மாட்டாங்க. நெக்ஸ்ட் வந்துட்டு லாஸ்ட் பாயிண்ட் அப்புறம் எக்ஸ்பிளைன் பண்ணுறேன். நெக்ஸ்ட் வந்துட்டு இது வந்துட்டு மேனேஜ்மெண்ட். இப்போ வந்து ஒரு பேஷண்ட் வந்து வராங்கன்னா மொத்தம் 3 கண்டிஷனில் இருக்கும். ஒன்று மேபி தே கேன் பி இன் ஷாக், மேபி ஏன்னா வந்துட்டு டீஹைட்ரேஷன் ஆகிறதுனால என்ன ஆகுதுன்னா வாட்டர் லாஸ் ஆகுது, அப்புறமேட்டு வந்து எலக்ட்ரோலைட்ஸ் லாஸ் ஆகுது. ஸோ டீஹைட்ரேஷன். அதனால் பழைய ஓல்டு கைட்லைன்ஸ் படி பார்த்தீங்கன்னா ஃபஸ்ட்டு எடுத்தோடனே இன்சுலின் கொடுப்பாங்க. ஆனால் இப்போ நியூ கைட்லைன்ஸ் படி ISPAD 2025 கைட்லைன்ஸ் படி என்னென்னா ஃபஸ்ட்டு வந்துட்டு அந்த டீஹைட்ரேஷனோட காம்பனண்ட்டை ஃபஸ்ட்டு நம்ம ரிசால்வ் பண்ணிவிட்டு அப்புறமேட்டு நம்ம இன்சுலின் கொடுப்போம். ஏன்னா இப்போ வந்துட்டு ஃபஸ்ட்டு வந்துட்டு ஷாக்கில் என்ன ஆகுதுன்னா ஃபஸ்ட்டு ABC சர்க்குலேஷன் வந்துட்டு NS கொடுப்போம். NS கொடுத்துட்டு NS வந்து 20 யூனிட்ஸ் per kg கொடுத்துட்டு இது பண்ணுவோம். நெக்ஸ்ட் இது ஷாக்கில் இருந்தால் ஃபஸ்ட்டு ஏர்வே ப்ரீத்திங், அப்புறம் வந்து சர்க்குலேஷன் பார்ப்போம். நெக்ஸ்ட் வந்துட்டு மாடரேட் அட்லீஸ்ட் என்னன்னா மாடரேட் டீஹைட்ரேஷன். ஆனால் வந்துட்டு ஷாக்கில் இல்லை, பட் ஆனால் டீஹைட்ரேஷன் இருக்குது, அசிடோட்டிக் ப்ரீத்திங் இருக்குது, வாமிட்டிங் இருக்குது. இதில் என்ன பண்ணோம்னா இதே சேம் தான், NS நார்மல் சிலின் கொடுத்துட்டு அப்புறம் KCL வந்து 40 mmol per kg கொடுத்துட்டு அப்புறமேட்டு தான் நம்ம வந்து ஆஃப்டர் 1 hour தான் நம்ம இன்சுலினோட தெரப்பி ஸ்டார்ட் பண்ணுவோம். ஏன்னா இப்போ ஏன் இந்த பொட்டாசியம் கொடுக்குறோன்னா இப்போ வந்துட்டு இன்சுலின் நம்ம எடுத்தோடனே இன்சுலின் கொடுத்தா என்ன ஆகும்னா இன்சுலின் வந்துட்டு பொட்டாசியம் வந்துட்டு செல்ஸ்க்குள்ளே போக வைக்கும். ஸோ தட் நம்ம எடுத்தோடனே இன்சுலின் கொடுத்தோன்னா ஹைப்போகலிமியா காஸ் ஆகும். ஹைப்போகலிமியா வந்துட்டு என்னென்னா டார்சாய்டிஸ் டிஸ்பாயிண்டஸ் காஸ் பண்ணும், நிறையா இது காஸ் பண்ணும். ஸோ அதை நம்ம ப்ரிவெண்ட் பண்ணுறதுக்காக நம்ம ஃபஸ்ட்டு NS + பொட்டாசியம் கொடுத்துட்டு அப்புறமேட்டு ஆஃப்டர் 1 hour வந்துட்டு நம்ம இது பண்ணுவோம். நெக்ஸ்ட் வந்துட்டு மினிமலில் வந்துட்டு வெறும் சப்க்யூட்டேனியஸ் இன்சுலின் கொடுத்துட்டு இது பண்ணுவோம், நோ இம்ப்ரூவ்மெண்ட். இல்லைனா நம்ம வந்து இதாக மாற்றிடுவோம் நம்ம. நெக்ஸ்ட் லாஸ்ட் கீழே
30 seconds.
ஓகே. இப்போ வந்துட்டு ஒரு பேஷண்ட் வந்துட்டு நம்ம வந்துட்டு இப்போ வந்துட்டு எமர்ஜென்சி டிபார்ட்மெண்ட் வராங்க வந்துட்டு என்னென்ன இப்போ வந்து நமக்கு வந்து எமர்ஜென்சி டிபார்ட்மெண்ட் வராங்க, டயபெட்டிஸாக இருக்காங்க, ஆனால் அன்கான்ஷியஸாக இருக்காங்க. நம்ம எப்படி நம்ம டிஃபரன்ஷியேட் பண்ணோம்னா டிகேயில் பார்த்தீங்கன்னா அந்த அசிடிக் காம்பனன்ட் இருக்கும், கீட்டோன் காம்பனன்ட் இருக்கும், நெக்ஸ்ட் ரேண்டம் இது இருக்கும். லாக்டிக் அசிடோசிஸில் வந்துட்டு வெறும் லாக்டேட் அசிடிக்கும் இருக்கும், ஆனால் வந்து ப்ளஸ் வந்துட்டு இந்த ரேண்டம் சுகர் அதிகமாகவும் இருக்கும், ஆனால் கீட்டோனோட காம்பனன்ட் கம்மியாக இருக்கும். நிறைய பேர் இதுக்கு டயக்னாஸ் பண்ணிவிட்டு இதுக்கு லாக்டிக் அசிடோசிஸ் டயபெட்டிஸ்க்கு இது பண்ணிட்டு நம்ம மெட்ஃபார்மின் கொடுப்பாங்க. மெட்ஃபார்மின் கொடுத்தா என்னன்னா இன்னும் லாக்டிக் அசிட் இன்னும் அதிகப்படுத்தும் அது. ஸோ அதனால் வந்துட்டு இந்த லாக்டிக் அசிடோசிஸ் பேஷண்ட்டில் வந்துட்டு நம்ம மெட்ஃபார்மின் வந்து கான்ட்ராண்டிகேட்டட். நெக்ஸ்ட் ஹைப்பர் ஆஸ்மோலர் கோமாவில் வந்து என்னன்னா வெறும் குளுக்கோஸ் லெவல்ஸ் மட்டும் 600 to 1200 இருக்கும். இதுவே வந்து செரிப்ரல் எடிமா குளுக்கோஸ் அதிகமாக பிளட் பிரெயின் பேரியர் வந்துட்டு அஃபெக்ட் ஆகி இதுவே வந்துட்டு செரிப்ரல் எடிமா காஸ் பண்ணி இதுவே வந்துட்டு கோமா காஸ் ஆயிரும். நெக்ஸ்ட் தான் யூக்ளைசமிக் டிகே வந்துட்டு என்ன SGLT2 இனிபிட்டர்ஸ் இது சேம் டிகே தான். ஆனால் இந்த SGLT2 இனிபிட்டர்ஸ் கொடுக்குறதால என்ன ஆகும்னா நிறைய எக்ஸ்ட்ரா இருக்க குளுக்கோஸ் வந்துட்டு வெளியே வந்து எக்ஸ்க்ரீட் ஆகிடும். அதனால் இதில் வந்து அசிடிக்காக இருக்கும், கீட்டோன் இருக்கும். ஆனால் வந்துட்டு நார்மல் ரேண்டம் வந்து பார்த்தோன்னா நார்மலாக இருக்கும், பிளட் சுகர் வந்து நார்மலாக இருக்கும். நெக்ஸ்ட் வந்து என்ன இது வந்துட்டு ரீசன்ட் டயபெட்டிஸோட அப்டேட்னா இதில் வந்துட்டு இந்த இவர் வந்துட்டு ஒரு அசிஸ்டன்ட் ப்ரொஃபஸர் இன் ஹவுசன் யூனிவர்சிட்டி. இதில் என்ன டாக்டர் ரவி சிங்னு ஒருத்தர். அவர் வந்துட்டு என்ன அந்த MEF2D ஆல்ஃபா 2ன்ற ஒரு ப்ரோட்டீன் வந்து நம்ம மசிலில் இருக்குது. இந்த மசில் வந்து இந்த MEF2D ஆல்ஃபா 2 வந்து என்ன பண்ணோம்னா நம்ம இப்போ வந்து பிளட்டில் கீட்டோன் பாடிஸ் இருந்துச்சுன்னா அந்த கீட்டோன் பாடிஸை வந்துட்டு எடுத்து அது வந்து கன்சியூம் பண்ணிக்கும். ஸோ தட் பிளட்டில் இருக்க கீட்டோன் லெவல்ஸ் வந்து கம்மியாகும். இது வந்துட்டு நம்ம டிகே பேஷண்ட்ஸ்க்கு ரொம்ப யூஸ்ஃபுல்லாக இருக்கும். ஏன்னா டிகே பேஷண்ட்ஸில் வந்துட்டு நிறைய கீட்டோன் பாடிஸ் வந்து நிறைய பாடியில் நிறைய பிளட்டில் நிறையா இருக்கும். ஸோ இது வந்து கன்சியூம் ஆச்சுன்னா இது வந்து யூஸ்லெஸ் எனர்ஜி சோர்ஸ். அவங்க வந்து எனர்ஜி சோர்ஸாகவும் இருக்கும், நமக்கு இதாகும் இதுக்கும். இது வந்து ரிசர்ச் போயிட்டுருக்கு. நம்ம வந்து இந்த QR கோட் ஸ்கேன் பண்ணி இந்த டீட்டெயில் ரிப்போர்ட் கிடைக்கும். கீழே சார். நெக்ஸ்ட் வந்துட்டு இப்போ வந்து கண்டினியூஸ் குளுக்கோஸ் மானிட்டரிங் மாதிரி கண்டினியூஸ் கீட்டோன் மானிட்டரிங் வந்து இப்போ வந்து இந்த ஆப் மாதிரி எல்லாம் இப்போதைக்கு வந்திருக்கு. தேங்க்யூ மேம்.
தேங்க்யூ சரவணன் செல்வம். your content was good, too good, and this was very neat and clear also. One thing I would suggest is if that presentation was in your medium of language, that would be better. Am I hurting you? No, because our medium is still English, and we have to present in English anything. Our mother language is Tamil, and we need to talk to patients in Tamil only. That is no doubt in that. Anga poi English la pesningna romba thappa poidum. But during presentation, my suggestion will be better in English. Otherwise, everything was good. Thank you.
1 minute pa. Saravanan Selvam. Myself. Inge. Wait panna. See, my feedback is that you presented well with the help of what and all you used for this, preparing this. AI, number 1. Next. Mic la pesu.
I researched on many websites for the recent updates, ma'am.
Recent update websites. Okay. So adella use பண்ணதுனால உனக்கு என்ன இப்ப டிஸ்அட்வான்டேஜ் இதுல தெரிஞ்சிச்சு? எதா தெரிஞ்சதா? இல்லையா?
prompt நிறைய கொடுக்க வேண்டியிருக்கும். prompt நிறைய கொடுக்க.
prompt என்னன்னா? இது மாதிரி prompt நீ கொடுக்கறது அது சொல்லல நான். presentation while presenting. So madam first point out பண்ண மாதிரி comfortable உனக்கு தமிழ் இருந்தாலும் இங்கிலீஷ்ல தான் you will be a teacher also hereafter. நீ அடுத்த ஸ்டூடண்ட்ஸ்க்கு இங்கிலீஷ்ல டீச் பண்ணணும். உனக்கு வர எக்ஸாமினர்ஸ் வில் பி ஃப்ரம் எக்ஸ்டர்னல் ஸ்டேட்ஸ். ஸோ இங்கிலீஷில் தான் நீ பேசுகிறது பெட்டராக இருக்கும். இன்னொன்று ஏஐ ரிசோர்ஸ் எடுத்ததுனால கண்டென்ட் வாஸ் வாஸ்ட். பட் அவ்வளோ ஃபாஸ்ட்டாக ஆங்ஷியஸாக நீ முடிக்கணும்னு ஃபாஸ்ட்டாக பண்ண மாதிரி இருந்தது. டு த பாயிண்ட் என்னெல்லாம் சொல்லணுமோ அது மேலே ஃபோக்கஸ் பண்ணேன்னா இன்னும் கொஞ்சம் பெட்டராக இருக்கும். டைம் ஆல்சோ வி ஹவ் கிவன் ஆல்ரெடி. ஸோ அந்த டைம்குள்ளே மேக்ஸிமம் கீ பாயிண்ட்ஸ் இதில் என்ன சொல்லணுமோ அது சொல்லணும். இன்னொன்று ரைட் ஃப்ரம் த ஸ்டார்ட் யூ டோல்டு 250. ஆக்சுவலாக அலார்மிங் கான்சன்ட்ரேஷன்ஸ் டிகேஏனாலே ரொம்ப ஹையர் லெவல்ஸில் தான் இருக்கும். 250 இருக்க நார்மலாக ஒரு டயபெட்டிக்கு கூட 250 தான் இருக்கும். ஓகேவா? அது எல்லாமே நல்லா இருந்துச்சு. ரெஃபரன்சஸ் எல்லாருமே போடுறதுக்கு ட்ரை பண்ணுங்கள். ஏஐ ஹெல்ப் யூஸ் பண்ணுங்கள், வேணாம் சொல்லலை. பட் லிமிட் அதில் நிறைய இருக்கும். ரெலவன்ஸ் வந்து யூ வில் கெட் ஓன்லி ஃப்ரம் டெக்ஸ்ட் புக்ஸ் அண்ட் டீச்சர்ஸ். எதை அங்கே சொல்லணுங்கிறது என்னம்மா மைக்கில் பேசு. டெக்ஸ்ட் புக்லேருந்து எடுத்திருக்கியா? வெரி குட். ஓகே, வெரி குட். ஐ அப்ரிஷியேட் யூ. பிக்சர்ஸ் எல்லாம் கிளியராக இருந்துச்சு. மை பாயிண்ட் இஸ் தட் டு பி ஃபோக்கஸ்ட் ஆன் வாட் யூ வாண்ட் டு டெல். வெரி குட்மா, வெரி குட் அட்டெம்ப்ட். குட். நெக்ஸ்ட்டுப்பா.
தேங்க்யூ மேம். Darshini will present on Addison's disease, a condition caused by insufficient production of adrenal hormones.
Hello. A very good afternoon to one and all present here. I'm Tarshini Jayakumar here to talk on Addison's disease. So what is Addison's disease? It is chronic adrenocortical insufficiency caused due to the destruction of the adrenal gland or the dysfunction of the adrenal gland. This leads to deficiency of 3 hormones mainly, that is the cortisol levels, then the mineralocorticoids aldosterone and the adrenal androgens. What are the causes of Addison's disease? The most important cause in developed countries especially is autoimmune. I'll prefer to talk. I'll explain. So it includes autoimmune causes, that is autoimmune adrenalitis, then autoimmune polyglandular syndromes, which is written over here, then metastasis, then congenital adrenal hyperplasia in genetic causes, drugs like ketoconazole, etomidate, and so on. Moving on to the clinical features and pathogenesis, we can explain the clinical features based on the 3 hormone deficiencies itself. The decrease in the mineralocorticoid levels leads to poor salt and water retention, thereby causing hypovolemia, polyuria, then hyponatremia, hyperkalemia, and the patient may present with postural hypotension. The decrease in the cortisol levels leads to hypoglycemia symptoms and non-specific symptoms like palpitations, weight loss, and so on. This decrease in cortisol levels is also responsible for the loss of negative feedback on the ACTH, thereby causing increased ACTH levels, which leads to the most important manifestation of Addison's, that is hyperpigmentation, especially in friction areas like knuckles, cubital fossa, and so on, due to the increase in the melanocyte stimulating hormone and the POMC hormone. The decrease in the adrenal androgens leads to loss of libido in both males and females and poor development of the pubic hair and so on. Next, moving on to the workup. So how do we diagnose this? First of all, it's based on the clinical features like hyperpigmentation is a key clinical feature, then followed by screening. This is done by the early morning cortisol levels, which if less than 5 microgram per deciliter is definitive of Addison's disease, and if more than 15 microgram per deciliter helps rule out adrenocortical insufficiency. We confirm this, that is the investigation of choice is the ACTH stimulation test, also known as the co-syntropin test, wherein we give 250 micrograms of the artificial ACTH, that is co-syntropin, and we check for the rise in the levels of cortisol. If there is a rise in cortisol levels of at least 7 microgram per deciliter or total elevation of 18 microgram per deciliter, it helps rule out Addison's disease. A deficiency in doing so is indicative of Addison's, and we measure this at 30 minutes and 60-minute intervals. This differentiation of ACTH is because there are 3 types of Addison's. There's primary, secondary, and tertiary. Primary is due to the adrenal damage, and secondary is due to the loss of pituitary hormone ACTH, and tertiary level is the decrease in the cortical stimulating hormone. Then moving on to the management. Management overall can be classified into 2 major types, that is basically the medical management and then the lifestyle modifications. As I said, due to the hypoglycemia component, then the salt wasting part of it due to the mineralocorticoid deficiency, we can advise the patients to increase their salt intake and to have more frequent meals. Whereas the medical management includes hydrocortisone. Steroids is the main form of management, and in that hydrocortisone is the most important drug of choice. We give 15 to 25 milligram per day orally in divided doses, that is like 10 milligram in the morning, 5 milligram in the afternoon, and 5 milligram in the evening. In case of postural hypotension due to mineralocorticoid deficiency, the drug of choice preferred is actually fludrocortisone, which is 0.05 to 0.2 milligram per day. A note to remember is Addisonian crisis, which is the acute adrenocortical insufficiency aspect of it seen in a patient with Addison's disease, especially in terms of stress due to infections and during operations, wherein instead of giving oral hydrocortisone, we prefer to give IV hydrocortisone of 100 milligram stat and followed by 50 milligram of maintenance therapy. Thank you.
Darshini, that was a very good presentation from you. Can we go into the depth of Addison? Which is the most common scenario of Addisonian crisis? Common as such.
A patient undergoing operation having Addison's disease.
Okay, actually in clinical thing, withdrawal of steroids as such. Okay, so patient will be on chronic withdrawal, that is steroid intake. Can you tell me some examples? Chronic steroid intake?
in immunocompromised patients.
You think of some auto-inflammatory conditions. Joints, lungs.
Rheumatoid arthritis, sarcoidosis.
So all connective tissue disorders, even skin disorders and lung COPD, asthmatics, they will be on steroids. If they withdraw, they will go for a additional increase. So what do you do at that time?
We'll have to give an increased level of IV hydrocortisone.
So you want to make a diagnosis. No, this is primary or secondary. You want to take a serum cortisol the next day. That day lab is not available. What do you do? Instead of giving hydrocortisone, you can give dexamethasone. So dexamethasone will not interfere with your thing, because Addison is not a very common thing like your type 1 DKA. This is a rare thing. So you want to make a diagnosis, you have to take a cortisol level. For that sake, instead of giving hydrocortisone, you can give dexamethasone. Okay. Thank you, ma. Thank you.
Darshini, very good, very neat, short time la mudichita, good job. என்னன்னா இந்த 9 AM கார்டிசால்னு ஏன் ஸ்பெசிஃபிக்காக சொல்கிறோம், ஏதாவது ஐடியா இருக்கா?
There's a rise in the cortisol levels usually at that time, ma'am. So when we measure it at that time, like if there's already a
similarly வேற எதுக்காச்சும் அந்த டைம்டா இந்த டைமில் எடுக்கணும்னு சொல்வீங்களா? வேற டெஸ்ட்
like diabetes la fasting glucose and the money
that is one timed. அது வந்து எதனால டைம்?
There'll be a difference in the postprandial
relation to food. ஃபுட்னால நீங்க டைம் சொல்றீங்க, பட் இந்த ஹார்மோன்ஸ்ல ஏன் டைம் சொல்றோம்? மா தைராய்டுக்குலாம் என்னமா சொல்றோம்? the variation, the circadian rhythm, அது எப்போ கான்சன்ட்ரேஷன்ஸ் இருக்கோ அதை வச்சு நம்ம ரெஃபரன்ஸ் ரேஞ்ச் வந்து மேக் பண்ணியிருக்கோம். இட் டிஃபர்ஸ் இல்லையா, மார்னிங் ஆஃப்டர்நூன் நைட்டு. பிபி ஆல்சோ டிஃபர்ஸ் மார்னிங் ஆஃப்டர்நூன் நைட்டு பிகாஸ் ஆஃப் த ஹார்மோன்ஸ் ஒன்லி. ஓகே, நீட் டு பி கேர்ஃபுல் எப்போ எடுத்தாங்க என்ன பண்ணாங்கன்றத பர்டிகுலர். வெரி நைஸ் மா. ஓகே, குட் ஜாப். நெக்ஸ்ட்.
Thank you, ma'am. Now we will move on to Lisa Joyce will present on Graves' disease, an autoimmune condition that leads to overactive thyroid function.
Good afternoon all. I'm Lisa and I'm going to be presenting on Graves' disease. So what is this Graves' disease? Graves' disease is an autoimmune condition which is the most common cause of hypothyroidism, contributing to about 60 to 80 hyperthyroidism, contributing to about 60 to 80% of all the cases of hyperthyroidism. It is characterized by antibodies against the TSH receptors, which are both in thyroidal as well as extrathyroidal tissue. Females are more predominantly affected in the ratio of 10:1 due to the estrogen exposure. So coming to the pathogenesis, so first, genetic susceptibility, in which there are gene mutations in the HLA-DR3 with strong association, CTLA4 as well as PTPN22 gene. These susceptible individuals, when they are exposed to some sort of environmental trigger such as smoking or chronic stress or postpartum shift and infections such as Yersinia or EBV, these conditions, it causes the autosensitization of the T helper cells, intrathyroidal T helper cells.
Silence please, listen.
Affects the B cells. That in turn activates the B cells to produce the thyroid receptor antibody. This thyroid receptor antibody, it goes and acts on the TSH receptor which is present in the thyroid gland to cause increased CAMP levels that leads to increased T3 and T4, which in turn causes suppression, TSH suppression. And then it acts on the orbital fibroblast. There is two receptors. One is TSH and the other is the insulin derived growth factor 1 receptor. It acts on both and causes the glycosaminoglycan accumulation, thereby leading to orbitopathy. Acts on the dermal fibroblast to cause dermopathy. So coming to the clinical features, according to the pathogenesis, since the T3 and T4 levels are so high, there will be all forms of clinical features of hyperthyroidism, mainly and even thyrotoxicosis. Symptoms like anxiety, tremors, palpitations, and then there is diffuse enlargement of thyroid gland, that is goiter, with a palpable thrill or bruit. Then the most important extrathyroidal manifestation, that is Graves' orbitopathy. It can be seen in different signs, clinical signs like lid retraction, lid lag, that is the Von Goffrey sign, and the Mobius sign, the Darlimpi sign, and so and so. It affects almost 10 to 25% of people with Graves' disease. And then we have pretibial myxedema, which is the dermopathy that affects almost 5% of the people. And then in severe cases of Graves' disease, we have the diamond triad, which comprises exophthalmos, pretibial myxedema, as well as thyroid acropathy, meaning clubbing. Then coming to the complications, we have atrial fibrillation, thyrotoxicosis, osteoporosis, and thyroid storm. Diagnosis is done by 3 modalities. First one, it is biochemical test is the first line. TSH suppression by marked level less than 0.01 micro unit per liter. If TSH is increased, it necessarily rules out Graves. Then there is marked elevation of T3 and T4 levels. Immunological test done is for it is a definitive test. The thyroid receptor antibodies are elevated, and sometimes TPO, thyroid peroxidase antibodies, may also be present. When come to imaging, there is ultrasound of thyroid gland. It shows diffuse hypoechoic goiter along with a characteristic finding known as thyroid inferno. There is also radioiodine uptake and thyroid syncytiography, which shows diffuse uptake of the gland. Then there is a scoring system called the clinical activity scoring. It is based on a 7-point system that is used to grade the activity on Graves' orbitopathy. So this scoring is actually used for the treatment of Graves' orbitopathy, since the severity of the orbitopathy determines its treatment. And then coming to the treatment, antithyroid drugs are used as a first line drugs, mainly methimazole and carbimazole, but they cannot be used in pregnancy. So the first trimester of pregnancy, they use propyl thiouracil. The treatment duration lasts between 12 to 18 months. Then we have radioiodine therapy. It is only indicated for elderly or in case of recurrent relapse cases or in case of large thyroid goiters. Iodine 131 is given orally. It may worsen orbitopathy in smokers, therefore smoking cessation is very important, as well as you can give prophylactic corticosteroids according to the EU-GOGO guidelines. And then we have thyroidectomy as the specific treatment, as a definitive treatment. Total thyroidectomy or near total thyroidectomy is preferred to prevent recurrence, and those patients require lifelong supplement of oral levothyroxine. Then for symptomatic treatment, we use beta blockers, and also we use beta blockers as prophylaxis to prevent atrial fibrillation or thyroid storm. And then corticos, in case of Graves' orbitopathy, for the mild cases we use selenium lubricants. For moderate to severe cases, we use corticosteroids as well as decompressive surgeries, orbital surgeries, as well as we might also use rehabilitative surgeries. And then recent advances. So we have this, in diagnosis we have a recent advance called the high sensitivity TRAB. It is a 3rd generation assay. In this assay, instead of using porcine and bovine values, they use human monoclonal antibodies, so the sensitivity is increased. The importance is in neonatal thyrotoxicosis. In 3rd trimester of pregnancy, the high sensitivity and specificity is better used to find neonatal thyrotoxicosis. And then orbital imaging by T2 relaxometry is being practiced. Doppler ultrasound is being used. And then advance in treatment, we use teprotumab, which is the first FDA approved drug in 2022, which is an IGF-1 receptor antagonist. It is used for moderate to severe cases of orbitopathy, and biological therapies like rituximab are being tried to prevent, it is an anti-CD20, it prevents the B cells, thereby decreasing the production of antibodies, thyroid receptor antibodies. So, and then there, that's it. Thank you.
You want to prolong 30 seconds? No.
Ma'am, that is just the thyroid ultrasound and the remaining 2 diagrams whether of the thyroid ultrasound and the action of treptotumab, ma'am.
Okay. That is okay. That was a very comprehensive, very good presentation. You have concised everything in 2 slides as such. I want to ask you a very basic question. What is hyperthyroidism and thyrotoxicosis?
Ma'am, in thyrotoxicosis, the cardiovascular system is predominantly affected, ma'am, due to very high levels of T3 and T4.
Anybody from audience? What is difference between hyperthyroidism, thyrotoxicosis? Hyperthyroidism toxic features irukada. The name itself suggests hyperthyroidism. That is, that amount of extra thyroid hormone is from the thyroid as such. But thyrotoxicosis is not definitely from the thyroid, it can be from the other ectopic sites. What is that ectopic site?
Struma ovarium.
Struma ovary, very good. So that is what I expected from you. And one more thing is that in autoimmune thyroiditis and in Riedel's thyroiditis, there can be a transient elevation of thyroid hormones, not necessarily hypothyroidism as such. So that is termed as thyrotoxicosis. Otherwise, everything was good, ma'am. The latest advances you have covered very well. Very good. Thank you.
Thank you so much.
Lisa, what's your name? Lisa?
Joyce, ma'am. Lisa Joyce.
Okay, good job. Well presented. Confident present panna. Content was also good. Only one investigation to be done to diagnose a thyroid disease. Which do you choose?
In case of Graves' disease, ma'am.
Thyroid. Any thyroid disease, only one test you can do. You cannot write a profile. Only one.
Radioiodine uptake scan.
அப்படியா இன்வெஸ்டிகேஷனில் பிளட்டில் ஒன்றே ஒன்று தான் பண்ணணும். ப்ரையாரிட்டி எதுக்கு கொடுப்பேன்? நிறைய சொன்னல.
Free T3, T4, ma'am.
Hey audience, இன்னும் சத்தமாக எதிர்பார்க்குறேன்ப்பா. TSH will be the first line. ஓகேவா? அதுக்கப்புறம் தான் அது. சரி, ஃப்ரீ பவுண்டில் டோட்டலில் எது யூ ப்ரிஃபர்? ஃப்ரீ. யூ ஆர் ஷுர் அபவுட் இட். சரி, இன்றைக்கி உனக்கு ஒரு பிளட் டெஸ்ட் பண்ணியாச்சு. தைராய்டு ப்ரொஃபைல் பார்த்துட்டேன். அதோட திரும்பவும் பண்ணணுன்னா எது வரைக்கும் வெயிட் பண்ணும்? How long should you wait?
3 months, ma'am.
3 months? At least for ஒரு டாக்டராக நீ உட்காந்துருக்க, எப்போ அட்வைஸ் பண்ணுவ ட்ரீட்மெண்ட் கொடுத்துட்டு? அட்லீஸ்ட் ஆஃப்டர் 1.5 months. அப்போ தான் வந்து லெவல் ஸ்டெபிளைஸ் ஆகும். ஸோ அதுக்கு முன்னாடி பண்ணுறதுனால எந்த யூஸும் கிடையாது. ஓகே, வெரி குட். போ.
Thank you, ma'am.
நெக்ஸ்ட்டுமா.
Next, I call upon Akshini to present on thyroid disorders complicating pregnancy, a topic that highlighting how thyroid imbalance can affect both maternal health and fetal development.
Good afternoon, everyone. I am Akshini and I am here to present the topic thyroid disorders complicating pregnancy. So first what I have given is what is the thyroid gland according to the American Thyroid Association. Next, what I have explained is the physiological changes during pregnancy. This is very important because only if you know what is the physiology, then you will be able to know what is hypothyroidism and what is hyperthyroidism and what is the complications. So first, what happens in physiological changes during pregnancy? The size of thyroid gland increases by 10 to 40%. Why does it occur? Because there is an increase in the HCG hormone. The alpha subunit of this HCG hormone is similar to the alpha subunit of the TSH. So this stimulates and causes increased production of the thyroid hormone. So due to the negative feedback, the TSH level will be low. Next, what happens? This is the estrogen. What does it do? Due to increase in estrogen, the total thyroid binding globulin increases. Now you can see that even though the T4 increases, the thyroid binding globulin also increases. So it binds to it and the total T4 increases, whereas the free T4 levels will be slightly elevated. So in this graph I have depicted that the free T4 levels are slightly elevated and opposite to it TSH, it is slightly depressed. It is up to 12 weeks of pregnancy. Why it is up to 12 weeks of pregnancy? Because you can see the HCG surge. It is up to 12 weeks of pregnancy and after that it is decreasing, and similarly these two hormones. And you can see that the thyroid binding globulins also increases and total T4 increases, whereas the free T4 is slightly increased. Next, what happens is there is an increased renal iodine clearance. Due to this, there is increased hormone production. Then you can see that the placental iodothyroid dehydrogenase activity increases. Why does it increase? Because there is a maternal fetal thyroid hormone bridge in pregnancy. What does it do? It will allow the T4 to cross through the placenta and reach the fetus. You can see that up to 12 weeks, the fetus is completely dependent upon the maternal thyroid hormone for neurodevelopment, whereas after 12 weeks, it can produce the thyroid hormones. So because of this, this placenta will selectively allow the T4. So what does this hormone do is, it converts the T4 into T3. The T3 can only up to some amount it can cause the placenta, whereas the T4 can freely cross. By this activity, it helps the fetus by preventing thyrotoxicosis in the fetus. So this is what I have depicted in physiological. Next, let's go to hypothyroidism. In hypothyroidism, we have three things, which is subclinical, overt, and isolated hypothyroxemia. What is subclinical? TSH will be increased, but the free T4 will be normal. And in overt, the TSH is increased, but the free T4 is decreased. This is a rare condition. In this, normal TSH will be present, but the FT4 will be in the lowest percentile. Next, I have given the etiology. The most common cause of hypothyroidism is autoimmune thyroiditis. Some other causes will be new diagnosis. Newly in the pregnancy it can be diagnosed, or already the patient might have taken the treatment, but doses will be decreased or iodine deficiency. Clinical features already it has said, cold intolerance, bradycardia and everything. Maternal fetal risk will be abortion, stillbirth, prematurity, then preeclampsia, anemia and everything. In fetus, the main thing is impaired intellectual development. It will lead to congenital hypothyroidism in the child, and which is called as cretinism. Next, let's go to the diagnostic thresholds. Already in the physiology, I have explained you that the TSH will be slightly decreased. So in the first trimester, the TSH upper limit is 2.5 milli international units per liter. If it is slightly increased beyond it, we can say it is hypothyroidism. In later trimester, it is 3 to 3.5. Here, the TPO antibodies plays a very, very important role. Why? Because according to our guidelines, if the TSH level is more than 10 milli international units per ml, we have to start with levothyroxine. But even if it is above 2.5 and TPO antibodies are present, we have to start with levothyroxine. As you all know, if the woman is already hypothyroid, then we can increase the dose by 20 to 30%. Then monitoring should be done for every 4 to 6 weeks. And after delivery also, we have to monitor. Why? Because there is a condition called as postpartum thyroiditis. What is this postpartum thyroiditis? Why does it occur? Because you know that pregnancy is the immunosuppressed state. So the anti-TPO antibodies will also be suppressed. But after that, what does it occur? Immediately postpartum, it will increase. So due to this, first there will be hyperthyroid phase due to the release of the hormones, not due to the increased synthesis. So the management will also be beta blockers and not anti-thyroid drugs. Same way, the next phase will be hypothyroid phase, and next will be the recovery phase. So this is about hypothyroidism. Next, hyperthyroidism. So overview, it occurs in 2 per 1,000 pregnancies. And normally physiological changes, what occurs during pregnancy? There will be increased oxygen consumption, increased heat production, increased cardiac output. All these changes are normal, but it mimics mild thyrotoxicosis. Next will be etiology. Etiology is Graves' disease, and clinical features, heat intolerance, everything. Maternal and fetal risk is slightly similar to hypothyroidism. Only thing is that the thyroid receptor antibodies in Graves' disease, it will cross the fetus and it will give neonatal thyrotoxicosis. Next, diagnostic approach. In diagnostic approach, we can see that if the TSH is decreased, but the free T4 is normal, then physiological follow-up is enough. But the TSH is decreased and FT4 is increased, we have to check for the thyroid receptor antibodies. Why shall we check it? If it is present and there are symptoms of goiter, it is Graves' disease. But if it is present, but the thyroid receptor antibodies are not present and there are no symptoms of goiter, it is gestational thyrotoxicosis. It is very important to treat it. It is very important because this doesn't require any treatment, but this requires anti-thyroid drugs. So in anti-thyroid drugs I have measured first trimester, it is propyltyrosine, because methimazole will cause congenital malformations like choanal atresia and aplasia cutis, whereas propyltyrosine is shifted in the second and third trimester because it is hepatotoxic. Next comes the recent advances. This is the final part of my slide. In this I have talked about the American Thyroid Association and the changes between 2017 and 2025. In 2017 you can see that even if the woman pre-conceptionally she has TPO antibodies positive, we have to treat her, but here no treatment is required. Next, even hypothyroid phase, PTO is given, but now it is based upon the patient, and also the diagnosis have narrowed. Before, the risk factors like age, obesity, everything the diagnosis were done, but now it is narrowed down to symptoms and history and individualized care and screening controversies. You can see that in targeted screening only 30 to 40% cases are missing, but still now it is a controversial topic whether universal screening to be done or targeted screening. At last I have said about a European trend journal where I have said about in last 13 years there have been an increase in the diagnosis and treatment as well. Because of this it may lead to overdiagnosis. That's it. Thank you.
Akshini, show me the second slide. That was very good, ma. Very nice. You missed one important side effect of azoles, that is carbimazole or methimazole. Can you tell me?
Ma'am, choanal atresia aplasia cutis, ma'am.
Agranulocytosis, somebody was prompting. Good. So agranulocytosis is an important thing. Patient can present with fever and other infections. So ideally, you should get a consent from them to start them on carbimazole or methimazole. Carbimazole is not available in American countries, but here it is available because it's a cheaper drug. Okay. One more thing. Next. And which is common, hyperthyroidism or hypothyroidism in pregnancy? And you told something about screening. We are doing screening. You should know what is happening in Tamil Nadu as such. We are doing a screening for everyone in the first trimester itself to identify early hypothyroidism and prevent neurodevelopmental delay as such.
Yes,
which is common? Hyper or hypo? Nowadays, hyper is getting very common.
Yes, 2 in 1,000 pregnancies.
Because of gestational thyrotoxicosis. Very good. Otherwise, very good. Nice.
Thank you.
Akshini,
Yes, ma'am.
what's your meaning of your name?
Eyes of Goddess Parvati, ma'am.
Eyes of Goddess Parvati. Very good. Very nice. Well presented. Energetic. ரொம்ப எனர்ஜி அவுட்புட் பயங்கரமாக இருந்துச்சு மற்ற ப்ரெசண்டாஸ் விட. இதில் என்னன்னா ஈவன் பிஃபோர் ப்ரெக்னென்சி சம் ரீப்ரொடக்டிவ் ஏஜ் விமன் ஆங்ஷியஸ் டு கன்சீவ் அவங்களில் ஏதாவது சிக்னிஃபிகன்ஸ் இருக்கா தைராய்டுக்கு?
Ma'am, if they are having thyroid before 1 year, they should not have taken any radioactive iodine treatment as well as for scans, ma'am.
Very good.
They should postpone the pregnancy up to 1 year. Then if preconceptionally they are having, they have to reduce the hormone level to 2.5 milli international units.
Very good. நேரோ ரேஞ்சில் மெயின்டைன் பண்ணணும். இன்ஃபர்டிலிட்டிக்கு நிறைய தைராய்டு வந்து டிசீசஸ் வந்து ரீசனாக இருக்குது, அது ஒன்று. இன்னொன்று ரெஃபரன்ஸ் ரேஞ்ச் பொறுத்த வரைக்கும் if it is within the normal limits, is that fine, or we have to look deep into it for anybody who comes with a thyroid report? What else you have to see? Reference range la irukku, normal you can go, abdi paaknuma illa vera edachum paakanuma?
For signs and symptoms, ma'am.
I am asking about the report.
Normal TSH will be 0.5, easy to remember, will be 0.5 to 5.
Yes, ma'am.
Madam is asking if it is not within the range.
ரேஞ்சில் இருக்குது, பட் ஷுட் யூ நோட்டிஸ் சம்திங் எல்ஸ்? அங்கே ரெஃபரன்ஸ் ரேஞ்சில் தான் ஃபால் ஆகுது, வேறு ஏதாச்சும் நோட்டீஸ் பண்ணணுமா அங்கே? ஆனால் சம் கம்ப்ளைண்ட்ஸோடு வராங்க இல்லையா, அதுக்கு தானே நம்ம பண்ணுறோம். ஸோ அப்போ அந்த ரெஃபரன்ஸ் ரேஞ்ச் பார்க்கும்போது நம்ம என்ன பார்க்கணும்? த சேம் ஹோல்ஸ் குட் ஃபார் ஃபெரிட்டின் இன் அயன் ப்ரொஃபைல் ஆல்சோ. என்ன பார்க்கணும்? Always look for the whether the hormones fall to lower range or higher range. And the end within the normal range irukanu paakano. Not like that, okay, higher end la irka, lower end la irka. So that the patient is going in for that side and artham. Also the people who are undergoing treatment போயிட்டு வராங்க இல்லையா, அவங்கள அசஸ் பண்ணும்போதும் எந்த சைடு வந்து போயிட்டுருக்கு. ஸோ நெக்ஸ்ட்டு அவங்க ஈஸியாக அடுத்த இதில் போயிடுவாங்க, அப்நார்மலில் போயிடுவாங்க. இப்போ நார்மல் ரேஞ்சில் தான் இருப்பாங்க. சிமிலராக ஃபெரிட்டினும் பார்த்தீங்கன்னா லோயஸ்ட் லிமிட்டில் இருக்கும், 30ல் இருக்கும். தட் மீன்ஸ் தே ஆர் ப்ரோன் ஃபார் வேணாண்டா தேங்க்யூ. தட் மீன்ஸ் தே ஆர் கோயிங் டு பிகம் அனிமிக். இட்ஸ் ஃபெரிட்டின் தான் ஃபஸ்ட்டு லைன் ஸ்டோர். அந்த மாதிரி ஆல் ஆஃப் யூ ஷுட் லுக் ஃபார் not only whether it falls within the normal range, higher end la irka, lower end la irka. Good action.
Thank you.
Next.
Now Achyutan will present on abnormal uterine bleeding, an important gynecological condition affecting women's reproductive health.
Welcome, I am Achyutan from final year MBBS. I am going to talk on abnormal uterine bleeding. What is abnormal uterine bleeding? Any vaginal bleeding from non-pregnant women that deviates from normal menstruation in volume, frequency and duration is abnormal uterine bleeding. Then we should know about what are the normal menstrual cycle parameters. Length of the cycle should be between 24 to 38 days. Volume of blood loss should be between 20 to 80 ml. Number of days of bleeding should be between 4.5 to 8 days. If it deviates from this means, we will call it as abnormal uterine bleeding. We should know about the terminologies of AUB. Oligomenorrhea, that is infrequent cycles less than more than 38 days. Polymenorrhea, frequent cycles less than 21 days. This is based on the duration of cycle. Then Based on the duration of blood flow, we call it as menorrhagia and hypomenorrhea. Menorrhagia is more than 80 ml of bleeding, and less than 20 ml of bleeding is hypomenorrhea. Then metrorrhagia is a irregular bleeding in between the normal menstrual cycle, and amenorrhea is absence of menstruation for more than 3 months. The etiology is given by the acronym POM and COIN classification. POM stands for structural causes and COIN stands for non-structural causes. POM for polyp, adenomyosis, leiomyoma, malignancy and hyperplasia. COIN non-structural causes, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic and not otherwise classified. We'll talk a little bit about each one. POM, P for polyp, it's an endometrial outgrowth, and it's seen as in Doppler we'll see a feeder vessel sign in case of polyp. Adenomyosis, endometrium goes inside the myometrium, that is adenomyosis. We can see glands and stroma in myometrium, which is normally a muscle layer. In a normal patient it will not be there. And leiomyoma, also known as fibroid, it's a smooth muscle tumor from the myometrium. In case of perabdominal examination, we cannot be able to converse the hands. In case of fibroid, it will be a firm tumor and a midline tumor. M for malignancy and hyperplasia. What are all the malignancy we are talking about? We are talking about CA cervix, CA endometrium and CA ovary, and hyperplasia is a endometrial hyperplasia. CA cervix, most commonly in India, the woman will present as a post-menopausal bleeding, that's a CA cervix. CA ovary, the estrogen secreting tumors of the ovary, that is granulosa cell tumor and a theca cell tumor. CA endometrium is due to hyperestrogenic state. Hyperplasia, it's due to CA endometrial hyperplasia. The investigation of choice is endometrial biopsy. Then non-structural causes, coagulopathy due to systemic disorders of hemostasis, most commonly von Willebrand disease. Ovulatory dysfunction, we can divide this into anovulatory cycles and ovulatory cycles. Anovulatory means there will be no progesterone, so the endometrium will not be supported and the endometrium sheds frequently. What are all the causes for anovulatory cycle? The woman puberty, obese and perimenopausal women, androgen excess, hypothyroidism and hyperprolactinemia are the causes for anovulatory cycles. And ovulatory cycle, in case of decreased progesterone, there will be bleeding. And endometrial cause, it is due to imbalance in the ratio of prostaglandin, imbalance in PGE2 to PGF2 alpha. If there is imbalance, means there will be a bleeding. And iatrogenic due to IUCD insertion, not otherwise classified. PAED and endometritis comes under the not otherwise classified category. Okay, then evaluation, we will ask about these things. We will ask in the history. Why do we ask each thing? Age. Why age is important? In puberty there will be an anovulatory cycle due to immature HPO axis. If a reproductive woman comes with the complaint of abnormal uterine bleeding, means first we should rule out the complications of pregnancy, then we should rule out the infections of pelvis, then benign condition of the uterus like adenomyosis, leiomyoma and endometriosis, then only we should come for malignancy. The most common malignancy we suspect in a reproductive age women is CA cervix, then CA endometrium. If a perimenopausal woman comes, means we should first rule out the endometrial carcinoma. If a menopausal woman comes, means the most common causes of polyp in case of menopausal women. Then age of menarche. Age of menarche, since the puberty is associated with anovulatory cycles, parity, in nulliparous women there will be increased risk of fibroid and carcinoma endometrium. In multiparous women there will be increased risk of adenomyosis. Menstrual parameter, what are all the menstrual parameter we ask for? We ask about whether the cycles are regular or irregular, the length of the cycle, number of pads used, and whether it is associated with clots. Normally there will be an anti-fibrinolytic mechanism. If there is a overwhelming bleeding, means there will be associated with clots. Intermenstrual bleeding in case of polyp, postcoital bleeding in case of CA cervix, coagulopathies, and a recent abortion, because there may be a retained products of conception will be there, so we should ask about the history of recent abortion. And IUCD insertion is associated with bleeding for few months. Symptoms of hypothyroidism, because hypothyroidism causes hyperprolactinemia and it will cause anovulatory cycles. Then comes to the examination. General examination, we see about the vitals of the patient, because in case of acute bleeding there may be unstable vitals, we should intervene immediately. Then general examination, we look at the pallor to know about the severity of the disease. Then signs of PCOS like hirsutism, acanthosis nigricans and acne. Abdominal examination for spilling lump in case of fibroid. Perspeculum examination for growth in case of CA cervix. Bimanual pelvic examination to know about the size of the uterus, contour of the uterus, texture of the uterus. Then we come to the investigation, CBC and hemoglobin. Because the blood transfusion guidelines are based on the hemoglobin level. Then bleeding time, clotting time, and the APTT to know about the coagulation disorder, UPT to rule out the pregnancy, cervical cytology to rule out pre-malignant and malignant conditions of cervix, USG to for structural causes, PALM, polyp, adenomyosis, leiomyoma, and malignancy. In polyp, we'll see endometrial growth, and in adenomyosis, we'll see glands inside the uterus. Hysteroscopy to see inside the uterus for endometrial. In endometrial biopsy, it's an investigation of choice for endometrial carcinoma. This is the investigating algorithm. If a reproductive age woman comes in, first we should rule out pregnancy by UPT, then go for USG. If the endometrial thickness more than 12 millimeter, normal USG, but there is a persistent bleeding. High risk factors are present means we will go for endometrial biopsy. If any one of the three is present means we will go for endometrial biopsy in case of reproductive women. But if a perimenopausal woman comes means there is a high risk for carcinoma endometrium, so directly we should go for endometrial biopsy. If a postmenopausal woman comes means more than 4 millimeter endometrial thickness means we will go for endometrial biopsy. If less than 4 millimeter thickness means we will use tranexamic acid. If does not respond means we will go for fractional curettage and hysteroscopy. Next. Okay, then comes the management. The overview is first we should go for medical management first. If the patient does not respond means we will go for second line medical management. Then we use Mirena. Mirena is a progesterone containing IUCD. If the patient does not responding to medical management means we go for minimally invasive surgery, that is endometrial ablation. If the patient does not responding to any of this means we will go for hysterectomy. First, medical treatment. What are all the drugs we'll use in medical treatment is NSAID, mefenamic acid, tranexamic acid, OCP. To with the help of OCP, there will be a negative feedback mechanism, so there will be the endometrium is supported. Then progesterone. Progesterone also causes endometrial atrophy. We go for continuous progesterone supplement like 3 to 6 months is preferred over cyclical progesterone. Then second line drugs or GnRH analog. GnRH analog is used before surgery for thinning the endometrium. Okay. Then specific management. If we found any specific cause like polyp, adenomyosis, leiomyoma means we will go for specific management of the individual tumor. For non-structural causes, if the bleeding persists means we should go for blood transfusion. Then surgical management, endometrial ablation. Endometrial ablation means we will ablate both the basal and superficial layers of endometrium. Fertility is not possible after endometrial ablation. That is a disadvantage with this because the ovum implants in the endometrium. There are two generations of endometrial ablation, first generation and second generation. First generation is based on hysteroscopic and we should use GnRH analog before going for endometrial ablation. In second generation endometrial ablation, we don't need anything like magnetic resonance, such that methods. Uterine artery embolization in case of fibroids and varicose uterus. Hysterectomy, there are three types of hysterectomy: type 1, type 2, and type 3. And medical management, tranexamic acid, OCP, progesterone. Mirena is a progesterone containing IUCD. It contains 52 milligrams of levonorgestrel. It supports the endometrium and prevents it from shedding. Thank you.
Achudan.
Clap பண்ணுங்கப்பா.
அச்சுதனோட கிளாஸ் வந்து எனக்கு ஒரு அசிஸ்டன்ட் கிளாஸ் எடுத்த மாதிரி இருக்கு. I give you that thing. You have taken a class just like an assistant. That was very nice. You talked from your memory, not from the slide as such. And this was a different presentation. Yes, sir, Ilya. Compared to previous ones, which was stuffed with so much information, this was a different thing. I applaud for that, but very nice. I'll tell you one scenario. To break the monotony, I'll tell you one scenario. I have a patient in my ward, to everyone. She is a 50-year-old female. She has menorrhagia. Menorrhagia, but she is okay. Her HB is 9. But her family, both the kids, daughters, again having menorrhagia, on and off, they used to have blood transfusions and they are diagnosed one disease. This is one thing. And one more sister, siblings, they too have menorrhagia with bleed from the gums as such. Both are different set of thing. According to you think, this is abnormal uterine bleeding. This is some medical cause. How will you proceed?
First, We go for CBC and hemoglobin.
Yeah, CBC was 9 grams. Both of them, one is 9, 6. What are the important thing and the medical perspective? Not in the surgical. You told something more of gynec and surgical problems. I'm telling about medical, which is common in medical wards. If it is a menorrhagia and the gynecologist has sent to you, there is nothing to intervene in gynec wards as such. They are sent to medicine ward.
Systemic cause of hemostasis should be ruled out. Von Willebrand disease.
Okay. Anything else from the audience? Von Willebrand, he told anything? Von Willebrand is not that common. He told common. Von Willebrand, we have seen out of my 10 years of thing, I have seen only 2 cases of Von Willebrand. Anything commoner? Von Willebrand is coagular. Hemophilia in female. Hemophilia in female. Possible. Okay. Thrombocytopenia, ITP. Anything else? Any other coagulation disorders? Bleeding disorders? So you have to screen for bleeding disorders and coagulation disorders. Any bleeding disorders? What do you do for bleeding disorder for coagulation? He told coagulation workup for coagulopathies. Bleeding? Yeah, PT, APT, TT for coagulation. Here, platelet aggregometry. So that patient is a case of Glanzmann's thrombasthenia. So don't ever forget Bernard-Solier and Glanzmann's thrombasthenia are common than Von Willebrand disease. We have 10 to 15 cases of Glanzmann and few cases of Bernard-Solier. That also presents as AUB only. So for that cases, patient will be referred here, and platelet aggregometry is done only in Vellore CMC. So we refer all patients there and make a diagnosis. They need only transfusions on and off, and he told tranexamic acid. Every time when she is bleeding, give her tranexamic acid. And family screening is a must. You have to screen the family. Thank you, Pa. Very nice. Nice.
அச்சுதன் வெரி வெல் ப்ரெசென்டட். இப்படி தான் இருக்கணும் ஒரு கிளாஸ்னா, ஸ்லைட்ஸ்னால் இப்படி தான் இருக்கணும். இங்கே அங்கே மூவ் ஆகிறது, முன்னாடி பின்னாடி ஷுட் நாட் கீப் சேஞ்சிங். கான்ஃபிடென்ட்டாக ப்ரெசென்ட் பண்ணும். குட் ஜாப். இன்னும் டைம் எக்ஸீட் பண்ணேன், பட் இட் வாஸ் குட். நிமோனிக்ஸ்லாம் யூஸ் பண்ணியிருந்தேன், தட் வாஸ் யூஸ்ஃபுல். யூரினரி ப்ரெக்னென்சி டெஸ்ட்டை ஸ்ட்ரெஸ் பண்ணி சொன்னேன். அதுதான் இப்போது மோஸ்ட் இம்பார்ட்டண்ட். ரீப்ரொடக்டிவ் ஏஜ் குரூப் மட்டும் இல்லாமல் ரீசெண்டாக இட் வாஸ் டிஸ்கஸ்ட் இன் அ மீட்டிங் லைக் தட். Any age suspicion of pregnancy, first rule out urine pregnancy. Anything related to menstrual disturbances. Menopause oda period enna? Edukapram menopause? How long?
After 47 years.
Age okay. Evlo years, evlo months stop aichna menopause. Post menopausal bleeding you say illa. After what period? It will be defined in your book, no? Inducha. சரி, ஏதாவது ப்ரிவென்டபிள் காஸ் இருக்கா? இப்போ நீ சொன்னதில் எதுலையாச்சும் ப்ரிவென்ட் பண்ணலாம் அப்படிங்கன்னா எது? இதில் ஏதாச்சும் ப்ரிவென்டபிள் காஸ் இருக்கா? நீ பார்த்து கூட சொல்லேன். பாசிபிளா? அது வந்து ஸ்க்ரீனிங். ப்ரிவென்ஷனுக்கு என்ன இருக்குது? இப்போ ரீசெண்டாக வந்துட்டு இருக்குது ரொம்ப. ப்ரிவென்ஷன்னாலே என்னது? Vaccine for what carcinoma? Cervical carcinoma. எப்போ போடணும்?
Adolescent female.
Very good. Early adolescent periodலே போட்டுறணும். Okay, that is the preventable cause. மற்றதெல்லாம் அவ்வளோவா ப்ரிவென்ட் பண்ண முடியாது. குட் ஜாப், நல்லா ப்ரெசென்ட் பண்ணேன்.
Thank you.
இப்போ monotony breaker exclamation.
Next we will have the fun session.
Anyone from final year is a good singer? Wants to come forward to sing a song? Yes, இன்னொருத்தவங்க தான் பிடிச்சி கொடுக்கணும், அவங்களே வர மாட்டாங்க. மிமிக்ரி, மூன் ஆக்டிங், யாராச்சும் ஸ்கில் ஒருத்தர் கூட இல்லையா? ஷேம் ஆன் யூ. கம் ஃபாஸ்ட், கம். ஃப்ரெண்டை பிடிச்சி கொடுங்கப்பா. யாரும்மா வர சொல்லு. பாடுறீங்களா, ஆடுறீங்களா, ஏதாவது ஒன்று. 2 ஸ்டெப்பு கூட போடுங்க, டான்ஸ் ஸ்டெப்பு, பவழமல்லி ஸ்டெப் போடுறதுனால போடுங்க. ஃபாஸ்ட்டாக வா. மேடமுக்கு கேவ் ஐடியா. நான் லாஸ்ட்டாக பாட சொல்லலான்னு இருந்தேன், மேடம் இப்போவே பண்ண சொல்கிறாங்க. வாங்கப்பா வாலண்டியர்ஸு. பாட்டு பவழமல்லியா பாடுவாங்க. ஃபைனல் இயர்ஸ்லேருந்து கேட்டால் இவனை ஏன் கூப்பிட்றேன். ஃபைனல் இயர்ஸ், இவங்கெல்லாம் ஃபைனல் இயர் தானான்னு டவுட்டாக இருக்குது. கல்ச்சுரல்ஸ்லாம் அட்டன் பண்ணுறதே இல்லையோ இன்னமா? சரவண செல்வன், மிஸ்டர் சரவண செல்வன் ஓடிட்டா, நான் ப்ரெசென்ட் பண்ணிட்டேன். வா வா, இங்கே தானே இருக்க, வா. என்னவோ பர்ஃபார்ம் பண்ணுவியாமே, என்ன இப்படி பயப்படுறான்? போய் சொல்கிறேன். பாட்டா ஒன்றும் இல்லைப்பா. யார் இவன் ஃபஸ்ட் இயர் மேம். சரி, ஃபைனல் இயர்ஸுக்கு சான்ஸ் கொடுக்கலாமேன்னு பார்த்தேன். நோபடி இஸ் கம்மிங். அனிதா, கேட்ச் ஹோல்ட் ஆஃப் சம்படி. Achudan, for that, Achudan, you have any other talent? Any first year willing to do? இவ்வளோதான் ஃபஸ்ட் இயர். அங்கே ஃபஸ்ட் இயர் இல்லை, ரெஜிஸ்ட்ரேஷன் டெஸ்ட்கெல்லாம். அட போங்கப்பா, லாஸ்ட்டில் ஃபஸ்ட் இயர்ஸ் இருக்கீங்களா? யாரோ ஒருத்தர். நீ பாடுறியா? பிஜிஸ், அட்லீஸ்ட் பிஜிஸ். இலக்கியா வா, நீ ஆச்சப்பா. ஸ்டேஜ் கீழே பாடு. அப்பாடா, தேங்க்யூ. ஏதாவது ஒரு பாட்டு பாடு, நல்ல பாட்டா.
Any song suggestions from the audience? You want some song?
கண்ணக்கொரு வண்ணக்கிளி காதுக்கொரு கானக்குயில் நெஞ்சுக்கொரு வஞ்சிக் கொடி நீதானம்மா. தத்தித்தவழும் தங்கச்சிமிழே, பொங்கிப் பெருகும் சங்கத்தமிழே, முத்தம் தர நித்தம் வரும் நட்சத்திரம். யாரோடு இங்கு எனக்கென்ன பேச்சு, நீதானே கண்ணே நான் வாங்கும் மூச்சு. வாழ்ந்தாக வேண்டும் வா வா கண்ணே, ராசாத்தி ஒன்ன காணாத நெஞ்சு காத்தாடி போலாடுது. பொழுதாகி போச்சு விளக்கேத்தியாச்சு, பொன்மானே ஒன்ன தேடுது.
Mister, what's your name? Pranish will sing a song for us. All of you listen.
At the on spot, man, காலையில தமிழ் காலத்து அப்படி தான் பாடினாங்க. திடீர்னு யாருமே இல்லாமல் நாங்களாம் போய் பாடுறது.
நிலாவேவா செல்லாதேவா என்னாலும் உன் பொன்வானம் நான் என்னை நீதான் பிரிந்தாலும் நினைவாலே அணைப்பேன் நிலாவேவா செல்லாதேவா என்னாலும் உன் பொன்வானம் நான் காவேரியா கானல் நீரா பெண்மை என்ன உண்மை முள்வேலியா முல்லை பூவா சொல்லு கொஞ்சம் நில்லு அம்மாடியோ நீதான் இன்னும் சிறு பிள்ளை தாங்காதம்மா நெஞ்சம் நீயும் சொன்ன சொல்லை பூந்தேனே நீதானே சொல்லில் வைத்தாய் முல்லை நிலாவேவா செல்லாதேவா என்னாலும் உன் பொன்வானம்தான்.
பிரணேஷ் தானே? தேங்க்யூ பிரணேஷ், தட் வாஸ் வெரி வண்டர்ஃபுல். ஃபைனல் இயர் பாட்டு பாட போகிறேன். எவ்வளோ நாளை கூப்பிட்டேன், இப்போ தான் உன் காதில் விழுந்துச்சா? ஆ சரி, சான்ஸ் கொடுப்போம்.
ஹர்ஷத் குமார்.
உயிரே உயிரே வந்து என்னோடு கலந்து விடு உயிரே உயிரே என்னை உன்னோடு கலந்து விடு நினைவே நினைவே எந்த நெஞ்சோடு கலந்து விடு நிலவே நிலவே இந்த விண்ணோடு கலந்து விடு காதல் இருந்தால் எந்தன் கண்ணோடு கலந்து விடு காலம் தடுத்தால் இந்த மண்ணோடு கலந்து விடு உயிரே உயிரே வந்து என்னோடு கலந்து விடு நினைவே நினைவே இந்த நெஞ்சோடு கலந்து விடு என் சுவாச காற்று வரும் பாதை பார்த்து உயிர் தாங்கி நான் இருப்பேன் மலர் கொண்ட பெண்மை மாறாமல் போனால் மலை மீது தீ குளிப்பேன் என் உயிர் போகும் போனாலும் துயரில்லை பெண்ணே அதற்காக தான் பாடினேன் வரும் எதிர்காலம் வரும் எதிர்காலம் உன் மீது பழி போடும் பெண்ணே அதற்காக தான் வேண்டினேன் முதலா முடிவா அதை உன் கையில் கொடுத்து விட்டேன்.
இஸ்ரத்தா அர்ஷத் எக்ஸலண்ட் எக்ஸலண்ட், நல்ல ஒரு பிக் ஹேண்ட் கொடுப்பா. ஃபஸ்ட்டே வந்திருக்கலாமே. கீப் சிங்கிங் பவர் இது போடு, கிளாஸ் ப்ரெசன்டேஷன் போடு, லாஸ்ட்டாக இது வச்சுக்கலாம். நெக்ஸ்ட் ப்ரெசென்டர் குயிக்காவா.
Next, Hasima Maimuna will present on gestational diabetes mellitus, which focus on diabetes occurring during pregnancy and its impact on both mother and baby.
Good afternoon, one and all present here. I think everyone is energetic after a short session. I'm Hazima. Today I'm going to present on one of the most prevalent disease of the world, with prevalence as high as 15 to 35% in various areas of India. It is one of the leading cause of maternal and neonatal mortality. So what are the risk factors? Advanced maternal age, any insulin resistant causing condition like obesity, PCOS, metabolic X syndrome, any family history or previous history, or any previous bad obstetric history can cause this condition. And what is the pathophysiology? Pregnancy itself a diabetogenic state. The placental hormones like human placental lactogen, estrogen, progesterone and cortisol all causes some epigenetic modification and metabolic modification in the insulin sensitivity, causing insulin resistance, thereby resulting in hyperinsulinemia and maternal hyperglycemia, which in turn causes fetal hyperglycemia and fetal hyperinsulinemia. As insulin is an anabolic hormone, it causes fetal macrosomia. Then the hyperglycemia itself an inflammatory state. It causes formation of reactive oxygen species, which causes congenital malformation in the fetus and increased rate of stillbirth. And this is what we call the Pedersen hypothesis. And next, how are we going to diagnose this condition? In India, there is no screening test. There is only a direct diagnostic test. We follow dipstick criteria, where the women is subjected to 75 gram of glucose in 300 milliliter of water in the very first visit itself, and the cutoff value is 140 milligram per deciliter. If it is more, she will be considered as gestational diabetes. There is another two-step approach by ACOG guidelines also. And after which, there are some other early biomarkers also, like there is some alteration in the metabolomics, like changes in adiponectin and leptin levels, and there is some changes in microRNAs, which are non-coding RNA, which modifies the epigenetics by DNA methylation and histone acetylation. These are the early markers which can predict the incidence of gestational diabetes. And then how are we going to treat the patient? If the patient is found to be have gestational diabetes, then next page one. Then she will be provided with medical nutrition therapy, which is a controlled diet of 30 kilocalorie per kilogram per day. If it is already a obese female, it will be restricted to 24 kilocalorie per kilogram per day, out of which 30 to 50% will consider carbohydrate, and 20% of protein and 30% of fat, of which 30 to 50 gram of natural fiber is must. Along with that, she has to have 30 minutes of intermediate exercise every day. If it is not controlled, we have to test her again after 2 weeks of medical nutrition therapy. If it is well controlled, we can continue with that with regular screening. If it is not, we have to go for some pharmacotherapy. The approved drug are metformin, glibenclamide and insulin. Glibenclamide has increased risk of neonatal hypoglycemia, hence it is not used much now, and metformin has failure rate of 26 to 50%, hence insulin is the preferred drug. We use pre-mixed insulin with the rapid acting and intermediate acting insulin in the formulation of 30:70. Started with 2 units, up to 20 units can be given. Then periodic screening is important. Periodic screening of both mother and fetus. We have to screen the fetus of any congenital anomalies and any other macrosomia and polyhydramnios. We have to screen the mother for infections also. All this have to be carried out regularly. And if the mother is well controlled with the diet and medical therapy, we can deliver her at the time of 39 to 40 weeks. If it is not, we have to complete the preterm by 37 to 38 weeks. At last, I have to add about some new class of drug called as adipeutics, which is under research. One such drug is called as PATAS, PATAS, which is found to have a direct effect on the adipocyte itself. It's just modifying the epigenetic mechanism and increases the insulin sensitivity. Thank you all.
Hasima, short and very sweet. So you have told some ACOG guidelines. What is about India and Tamil Nadu as such? When you are going to look in for GDM, And how you are going to monitor?
Ma'am, in India and Tamil Nadu, at very first visit itself, we monitor the pregnant mother for glucose challenge test.
Very first visit, you check for sugars, and when you make a diagnosis of GDM?
Usually the placental hormones and everything will be peak at second or third trimester.
At 20 weeks. Actually, it was previously 20 weeks. Nowadays, this before 20 weeks, it is called as overt DM.
Yes,
But nowadays, they have clubbed this together. Latest guidelines, latest nomenclature is, even if it is a overt DM, this is called as gestational diabetes mellitus, and all complications, whatever you told, applies to overt DM as well as for GDM as such. So screening, and how frequently you will screen, and what will be the complications as such?
Ma'am, as per DIPSI criteria, if it is normal, means the blood sugar is normal, means at the first visit.
What is the target you will ask the patient to have?
120 milligram per deciliter.
Fasting should be less than
95 milligram.
90. Our criteria is 90, and postprandial at second hour will be less than 120. And that GTT, GCT is not nowadays available. 75 grams else is not available. Why? Because this is not practical. You can't ask the patient to go have 75 grams and come back again. So that is not there. On the first visit, you make a diagnosis. And what is the therapy for GDM?
Insulin therapy.
Insulin alone. The patient is on metformin, what will you do? The patient was a PCOS patient, was on metformin. She conceived only because of metformin. What will you do?
We can continue the metformin.
No,
if it is
no. Latest guidelines is stop metformin and replace insulin as early as possible to prevent all the fetal anomalies of hyperglycemia. Otherwise, very good, ma. Very nice. Thank you. Good presentation.
Hasina. Wait.
sorry, I'm sorry.
Good presentation was very good, crisp. Time la mudichite nalla irundhathu, well explained. Madam சொன்ன மாதிரி the importance of monitoring of these patients are very important. நிறைய பேருக்கு பார்த்தா diagnosis made only when fetal anomalies have been found. அதனால monitoring வந்து ரொம்ப முக்கியம். Plus the complications you have told இல்ல, planned deliveries இருக்குமா இல்லை உங்களுக்கு we can try normal labor?
Ma'am, if it is well controlled, we can go for normal delivery, ma'am. If the estimated fetal weight is more than 4 kilogram and she is not well controlled with the drug, means we have to plan elective C-section at 38 weeks, ma'am.
Yes. Mostly nowadays they plan C-section because இவங்கெல்லாம் precious babies-ஆக இருப்பாங்க, bad obstetric histories follow ஆயிருக்கும். அதனால் unexplained fetal death will happen around the delivery date. அதனால் they go for C-section. Good.
One more thing. What is SMBG?
Serial monitoring of blood glucose.
Self-monitoring. Okay. Self-monitoring of blood glucose. That is what you advise, because patient is always on pricking stage. You should ask them to take a sugar daily or alternate days or weekly. SMBG advice for a GDM patient daily or any intervals. Audience also can answer. SMBG is a must. SMBG is daily for GDM patient. Okay, daily, anytime during the day, and if it is postprandial, it should be less than 120. If it is in the fasting, even before lunch, before dinner, it should be less than 90. Okay. What common anomaly you can expect?
Cardiovascular anomalies. Or
renal anomaly. Okay. Okay. Good. Thank you.
Next, Srinidhi will present on neuroendocrine tumors which arise from hormone producing cell of the body.
Hello. Good evening to one and all present here today. My name is Srivari Rajan of 2022 batch, and today I'm here to give a brief overview of neuroendocrine tumors. As given in the name, it is basically any malignancy that occurs in the neuroendocrine cells that are found along the GI tract. It's a heterogeneous group of clinically relevant tumors that have a very broad array of syndromes that we will go over in my presentation. The classification, there are 3 major classifications. It is based on the differentiation and the functionality. The first classification is based on the functionality. So if the hormones produced are functional, it will come under functional hormones, and the hormones produced don't have any clinical significance to the body, it is non-functional. And then the second classification is based on the embryological location, so whether it is in the foregut, midgut or hindgut. This has significance because depending on which part of the body is located, it may give clues to whether the carcinoid will form into carcinoid syndrome. So the third classification is also associated with the grading, either grade 1, grade 2 or grade 3, depending on two protocols, which is the mitotic count and the Ki67. Okay, so now we're going to talk about the etiology. It's mainly genetic in nature. So depending on if it's a neuroendocrine carcinoid, these will be mainly caused by genetic issues or deletion of the RB1 gene or the TP53 gene. Neuroendocrine tumors, on the other hand, it is more aggressive in nature, and it is associated with the MEN1, MEN4 gene, or anything associated with the cyclin-dependent kinase. So in this case, anything that affects the cell signaling pathway or the genetic assessment of the genes within the cells that allow it to go into the next cell of cell reproduction. So and the symptoms that are commonly caused because of these nets are multiple endocrine neoplasms type 2, which is caused by MEN2, multiple endocrine neoplasm type 4, which is caused by MEN4, von Hippel-Lindau syndrome, and then neurofibromatosis type 1, TSC, and Pheochromocytoma. So next we're going to talk about the clinical manifestations. There are a wide range of clinical manifestations because there are many locations where these tumors can be found. So the major ones are basically flushing and diarrhea. Flushing is basically any kind of redness or violaceous erythema that is found along the upper body, mainly in the face and the neck, and it is more severe when there is bronchial manifestations. Abdominal manifestations, as I said earlier, it will include diarrhea, and it also have steatorrhea and abdominal pain. And then there are cardiac manifestations also. In this case, it will be there will be a ventricular thickening. There will be thickening of the tricuspid valve on the ventricular side, which will cause regurgitation and may eventually lead into heart failure. So, and then there are some pancreatic manifestations which are also highly variable. You can have glucagonoma, insulinoma, vipoma, depending on which part of the pancreas the tumors have proliferated. So, there is an important case that I'd like to mention. There was a 38-year-old female that presented to the OPD with severe pain in the left abdominal region that has been present for a year but has been unbearable over some time, as you can see here. And upon taking a CT scan, they discovered that there was a mass that was found which was about 11 centimeters in radius, and it was compressing the stomach, spleen and liver, which was causing the pain. And upon biopsy of the mass and histopathological analysis, they found out that it was in fact a neuroendocrine tumor. So in this case, tumor markers are not taken, but tumor markers actually have an important significance in the diagnosis, early diagnosis of these neuroendocrine tumors, because they are in fact rare and not as commonly found. So the tumor markers, there are four main types. So here we have traditional tumor markers, which are basically chromogranin A and neuron-specific enolase. They are economic, but they're not as accurate, so they're not used as much these days. And then specific tumor markers, they are basically, they take the peptides and the earlier onset of those peptides, which basically amino acids. They assess the peptides and the amino acids to detect any of the progenitors in order to diagnose the nets. So, human chorionic gonadotrophin is a major example. Its alpha and beta subunits are used to calculate medullary thyroid cancer and small cell carcinoma of the liver. Non-specific tumor markers are used to they are called non-specific in the sense that they assess the proteins that regulate the synthesis and management of the hormones that are produced by the neuroendocrine cells. So major example of these will be chromogranin A. B and C is the entire chromogranin family, but chromogranin A is the most common. The conditions that are associated will be, as I said earlier, the pheochromocytomas, paragangliomas, carcinoid syndromes, and so forth. So, and then the latest one that we have discovered is the neuroendocrine test. So basically, they will take a blood test and it will assess 5 major chemicals in the blood. So it will be CGA, NSE, IGF-2, glycoprotein hormones, and pancreastatin. So these have very high sensitivity and specificity. So it is one of the most promising tools for diagnosis in this day. So treatment is very wide and varying, since neuroendocrine tumors have such a vast variety of presentations. So we basically manage the symptoms. So we can avoid the precipitations of flushing. So alcohol, excessive exercise, heat, consumption of cheese, and certain drugs may also, like the SSAs, okay. Catecholamines, pentagastrin are also some drugs that increase the flushing. So we need to tell the patient to avoid themselves from taking these such lifestyle decisions. In the case for those who have heart failure as a clinical manifestation, they need to take diuretics. Wheezing, for they have to use bronchodilators. And then for people who are having diarrheal issues, they have to take loperamide. And then serotonin receptor and antagonists, somatostatin analogs, and the major ones are octreotide and lanreotide. And surgical manifestations are also done depending on where the tumor is formed and its size. And basically in the future, important developments that we have been coming up with focus mainly on the mTOR pathway, VGEF, and the PRTT. So basically, depending on where the receptors are on these neuroendocrine tumors, we are focusing on those to have a more localized treatment of these neuroendocrine tumors. Thank you.
Srinidhi, it was a very tough topic really. Neuroendocrine tumor is very rare. I have not seen a one so far. And what food, it's a very common food you would avoid?
Cheese, ma'am,
okay.
they said.
Anything else?
Cheese
is for
alcohol. Alcohol intake is also
okay. Very common. Any other food which will elevate your mood because it is serotonin involved? Banana, okay? Banana. You ask them not to take banana. So what is that valvular abnormality in your NET?
Ma'am, basically there'll be like
thickening. What is that?
There is
right-sided.
So on the ventricular
stenosis,
aspect
okay.
of the yes, ma'am.
This is tricuspid stenosis and pulmonary stenosis. Okay,
yes,
not mitral stenosis. Always mitral stenosis. The common cause will be mitral stenosis. Ka common cause enna? Rheumatic.
Rheumatic heart disease.
Rheumatic. Third, rheumatic. So that common MS with your rheumatic, but the carcinoid syndrome can have tricuspid stenosis and stenosis of the pulmonary.
Yes,
okay.
Srinidhi.
Srinidhi.
Okay, very good. நல்லா ஸ்டேபிளாக ப்ரெசென்ட் பண்ண ரொம்ப வாஸ்ட்டு, அதனால் கொஞ்சம் லிமிட் பண்ணியிருக்கலாம். வாட் யூ வாண்ட் டு ஷோங்கிறத இது பண்ணியிருக்கலாம். கேஸ் நீ போட்டது யூனிக்காக இருந்துச்சு. குட் ஜாப்.
தேங்க்யூ மேம்.
நெக்ஸ்ட்.
Next, Srinidhi will present on Pheochromocytoma, a rare tumor of the adrenal gland that can cause severe hypertension.
Very good evening to one and all present here. I am Srinidhi, a final year MBBS student. Today I am going to talk about a catecholamine secreting tumor called Pheochromocytoma. So by the term we can understand that pheo means dark, chroma means color, and cytoma means a tumor. So it is a dark colored tumor present in the adrenal medulla, composed of chromaffin cells which secretes excessive catecholamines. So when these tumors are present extra-adrenally along the sympathetic and parasympathetic ganglia, it's known as gangliomas. The causes for these tumors are not clearly known. It can be spontaneous or it can be associated with familial disorders such as MEN2, neurofibromatosis type 1 and VHL diseases. And the tumors are usually benign, and malignant types of these pheochromocytomas are usually very rare. And these pheochromocytomas are a very common cause for secondary hypertension, and the 0.1% of hypertensive patients who present to the OPD have pheochromocytoma. So these are the areas where the head and neck paragangliomas are commonly presented. And when we talk about the symptoms of pheochromocytoma, commonly the pheochromocytoma is called the great masquerader because it doesn't have any unique symptoms. It usually mimics the symptoms of hypertension and cardiac pathology commonly. So usually the patients are misdiagnosed with those conditions. So the diagnosis of pheochromocytoma is usually prolonged. So the major clinical features that the patient has is headache, profuse sweating, palpitation, accelerated phase of hypertension, or paroxysms. Paroxysms means a period where there is increased secretion of epinephrine, which causes anxiety or cardiac symptoms. So usually due to misdiagnosis of these conditions, patients are usually presented with the complications of hypertension such as stroke, MI, LV failure, and etc. So when we talk about the pathophysiology of pheochromocytoma, mainly the normal physiology of secretion of catecholamines starts from the tyrosine. From the tyrosine, it's converted to epinephrine in the adrenal medulla. So what happens is when in pheochromocytoma, the tumor cells start secreting these catecholamines, which results in excessive secretion of catecholamines in the body. The main two neurotransmitters are the epinephrine and norepinephrine. So what happens is when the norepinephrine is commonly secreted continuously from the tumor, which acts on the alpha adrenergic receptors, which causes peripheral vasoconstriction and results in increase in BP. So when we talk about the epinephrine, it is usually secreted in periodic manner, which causes the paroxysms. This usually acts along the beta-1 receptors of in the cardiac system, which causes tachycardia, arrhythmia, and palpitations kind of symptoms. So this is the pathophysiology of pheochromocytoma. So when we talk about the investigations, the specific investigation that are to be done to diagnose pheochromocytoma are a biochemical investigation, which includes urine analysis and plasma analysis. In urine, 24 hours metanephrines and 24 hours catecholamines can be tested, and in plasma, the free metanephrine levels and catecholamine levels can be tested. In this, the important thing is the plasma-free metanephrine levels that the test contains high sensitivity and specificity towards pheochromocytoma. And the common mistake is usually in biochemical testing, false positive findings are way more higher, so proper investigation should be done. So VMA is a test that is done previously, which is seldom in use now. And then when we see up the radiological investigation, there is CT, MRI, PET scan, and scintigraphy can be done. This is an example of unilateral adrenal mass presented in MRI, and this is a PT scan which shows in unilateral adrenal mass. And then if we see about the genetic studies, this is done in people who have familial history of pheochromocytoma or any familial history of those three conditions which we saw before, which is VHL disease, MEN type 2, and neurofibromatosis type 1. This can be done as a primordial prevention technique, so we can prevent the precipitation of the pheochromocytoma in those patients. So then if we talk about the treatment of pheochromocytoma, the only main treatment that can be done is your surgical resection of the tumor. So surgical resection can be done as total or partial adrenalectomy. And for paragangliomas in the head and neck, the surgery is usually very risky. So we can opt for radiotherapy techniques to suppress the tumor cells. And then the very important thing we have to keep in mind is your preoperative and intraoperative BP management, which is the very important thing in pheochromocytoma. So preoperatively, the patient is usually started on antihypertensive drugs before 2 weeks. The main drug that is given in pheochromocytoma is phenoxybenzamin, which is an alpha adrenergic blocker, and along with that, beta blocker or CCBs can be added. The important thing you have to keep in mind is only beta blocker should not be given for pheochromocytoma patients. Due to unopposed action of alpha-1, the hypertension can be worsened. So next comes your diet. In diet, salt intake should be increased in patients who is going to undergo pheochromocytoma surgery, because catecholamine-induced volume contraction is present in the patients. So after surgery, there can be episodes of hypotension or orthostatic hypotension can be precipitated. So, And then during intraoperative, hypertension and hypotension can be corrected by using nitroprusside infusion and volume infusion methods. And then when we talk about the recent advances that is made in the in the field of medicine to treat pheochromocytoma, there's a HIF alpha inhibitor drug which is used in patients having VHL disease, which suppresses the tumor growth. And the same goes to your tyrosine kinase inhibitors, which is currently in clinical trials. And then if we come to the investigation techniques, there is a gadolinium dot PET or CD scan, which has high sensitivity for metastatic progressive pheochromocytoma. And to add on to your curiosity, I have included a QR code to scan and to see about the case study of pheochromocytoma. Thank you.
Srinidhi, yes. Okay, that was a very nice presentation, Ma. You have got involved in pheochromocytoma, and you can see that in your mannerism also. What is this rule of 10 in pheo?
It usually follows a rule of 10, ma'am. That is, the 10% of pheochromocytoma is present extra-adrenally, and 10% is usually confined to your abdominal area, and 10% can be associated with familial conditions. 10% is usually seen in children, and 10% can be metastatic pheochromocytoma.
So ideally, 10% is extra-adrenal, 10% is bilateral, and 10% is malignant.
Yes, ma'am.
And other 10 now they have added is in children and with no hypertension. Okay. Pheochromocytoma diagnosis is very difficult as such. Patient will present with episodic headache, episodic hypertension, headache, and palpitation, sweating episodes. And what is this? Who is under nightmare with pheochromocytoma? Not the diagnosing physician. To whom this is a nightmare?
Patient.
Anesthetist. Okay. This BP will be very highly fluctuating during surgery. It is a big nightmare for them as such. Otherwise, very good, nice.
Thank you.
Srinidhi, excellent ma. Spontaneous flow, nalla oru class mari irundhuchu. Excellent, good.
Thank you.
Next ma.
Next, Jayan will present on Cushing syndrome, a condition caused by prolonged exposure to high levels of cortisol.
Good evening, one present here. Myself Jain. I'm here to present on Cushing syndrome. Cushing syndrome is caused due to excessive cortisol level in the body. Cortisol production can be increased due to two reasons: exogenous administration or endogenous production inside the body. What is cortisol? Cortisol is a pulsatile hormone. It is the metabolic hormone that is produced in our body. It is also known as stress hormone. The peak secretion will be seen during the daytime. Maximum secretion is during 12 p.m. and the minimum is seen during 12 a.m. that is at midnight. And over here we will see the diurnal variation of cortisol, and the etiology of Cushing syndrome will be, as I have already said, it is due to exogenous or endogenous causes. Endogenous causes will be can be classified as adrenal corticotropic hormone dependent or adrenal corticotropic independent. In adrenal corticotropic dependent, it can be due to pituitary adenoma or ectopic ACTH production. In pituitary adenoma, there will be increase in ACTH level as well as cortisol level. In ACTH independent level, there won't be any disturbance in the ACTH level. So it can be caused due to adrenal adenoma. In this, the normal physiology will be seen. Cortisol levels will be increased, and when the cortisol levels increases, a negative feedback will act upon the ACTH and further it decreases. In exogenous causes, which is the most common cause of all, it can be caused due to iatrogenic steroids. In this, the cortisol level will increase as well as the ACTH will decrease. Okay. Right now, the clinical features. Over here in this picture, we can see that the person has a moon-like face, and there will be buffalo hump. Central obesity will be seen. Purple striations will be seen. Purple striations means in the abdomen, majorly it will be seen in the abdomen, more than 1 centimeter in length. And the person can be seen with easy bruising. Thin extremities will be seen. The person will look similar to a frog. And proximal muscle will be seen. Muscle weakness can be seen. Apart from this, hypertension and immunosuppressions can be seen. In severe cases or ectopic ACTH production, hypertension plus hypokalemia will be associated. The clinical features can be classified into 6 types: metabolic effects, hormonal effects, cardiovascular effects, immunological effects, musculoskeletal effects, and neuropsychiatric effects. Okay. And then the screening test. The screening test can be divided into 3 methods. First method is 24 hours urine 24 hours urinary free cortisol. In this method, 24 hours urine sample is collected and cortisol level is measured. If there is increase in cortisol level, then it suggests Cushing syndrome. Next is 1 mg overnight dexamethasone suppression test. In this, at night 11 p.m. 1 mg dexamethasone is given, and next day morning 8 a.m. The cortisol level will be measured. If there is no suppression and the cortisol amount is still high, it suggests Cushing syndrome. The third method will be salivary late night salivary test. Saliva sample will be taken between 12 p.m. to 12 a.m., 11 p.m. to 12 a.m. If there is increased cortisol level in it, it suggests Cushing syndrome. And then the confirmation and differentiation. Confirmation test can be by measuring the plasma ACTH level. The normal plasma ACTH amount in will be 5 to 15 picogram per ml. If below 5 picogram per ml is seen, it can be due to ACTH independent. It can be ACTH independent. This can be further differentiated by CT or MRI scan of adrenal glands. If there is high adrenocorticotropic hormones, then it will be due to ACTH it is due to ACTH, and it can be classified based upon dexamethasone test or further imaging. Dexamethasone test, as we have already seen, if there is more suppression in cortisol level, it can suggest Cushing syndrome. If there is no suppression, it can be due to ACTH syndrome, ectopic ACTH syndrome. And the high dose dexamethasone test can be used to classify between 3 types: Cushing disease, ectopic ACTH syndrome, and adrenal tumor. The management can be seen as the primary first line management is surgery, that is transsphenoidal surgery. After that, the medical therapy can be given. The drugs that are commonly given are ketoconazole, mitotane, metropone, and osteostate. And supportive care must be given, that is the controlled hypertension, diabetes, and infections. And bone weakness, proximal muscle weakness will be seen. Further support must be given. Supplements should be given. Thank you.
Okay, Jen, what is Cushing syndrome and Cushing disease?
Cushing syndrome is
it's like your Parkinsonian and Parkinson's disease.
Cushing syndrome means
you have given somewhere. I thought you will be able to answer. See, Cushing disease is your block is there in the middle. Go find out. உனக்கு யாரோ ப்ரிப்பேர் பண்ணி கொடுத்துட்டாங்களா? Proxy. Last time change swapping. அப்படியா? Okay. So Cushing disease is pituitary adenoma. Okay. See there. Cushing syndrome. Yes. Okay. Cushing syndrome is where the cortisol is from outside, other than pituitary causes. Okay. Both are different. Totally different. Cushing disease, you have to address the adenoma. Cushing syndrome, it is iatrogenic and stop the steroids. Okay. Well done.
ஜெயன் காமன் கம்போஸ்டாக ப்ரெசென்ட் பண்ண இன்னும் கொஞ்சம் இன்வால்மெண்ட்டாக எனர்ஜெட்டிக்காக ப்ரெசென்ட் பண்ணும். யூ டோல்ட் த கீ பாயிண்ட்ஸா? யூ டோல்ட் தட். யூ டெல் தட். தட் இஸ் இம்பார்ட்டன்ட்.
The most common cause will be due to exogenous steroidal use, and the most common endogenous cause will be due to pituitary adenoma. If hypertension and hypokalemia is seen, it suggests that it is a severe disease or ectopic adrenal corticotropic hormone. If there is the earliest sign for Cushing's disease is loss of diurnal variation.
That's why you are doing all those tests. ஹைட்ரோஜெனிக் தான் இது எல்லாமே. குஷிங் சிண்ட்ரோம்னா அது ஒரு டிசீஸ்னு கிடையாது. we are only inducing it. அதை வந்து மைண்டில் வச்சுக்கிட்டு ஸ்டீராய்ட்ஸ் எங்கே யூஸ் பண்ணுமோ அங்கே மட்டும் யூஸ் பண்ணணும். ஓகேவா? குட் ஜாப். நெக்ஸ்ட்.
Finally, Sundarapandi will present on insulin analogs focusing on modified insulin used in the management of diabetes.
Good afternoon, one and all.
Only few audience is there, you can make louder.
Good afternoon, one and all. Myself Sundarapandi. Today my topic is insulin analogs. What are insulin analogs? What are insulin analogs? Insulin analogs are synthetic versions of insulin designed to mimic natural insulin release patterns. They are meant to be improve the they are meant to improve the glycemic control. The history of insulin analogs are in the early days. Insulin are extracted from the animal sources such as bovine and porcine source. Ma'am, initially the bovine source. Okay. These two animal sources they are initially extracted, ma'am. But there are many side effects such as hypoglycemia and immunological reactions, allergic reactions, such as they occurred. So after recombinant DNA technology, using E. coli, human insulin is produced in the year 1982 by company called Eli Lilly and company. Yes, ma'am. Ma'am. The classification are broadly the insulin analogs are classified into two: long acting and rapid acting and long acting. Long acting analogs are basal and fast acting analogs are prandial. Example are Lispro, Aspart and Glulysin. The fast acting analogs are the onset is very short, that 5 to 10 minutes the onset begins, and it attains the peak at 1 hour, and it longs as 3 to 5 hours. Long acting ma'am, அடுத்த பேஜ் டேக் இல்ல மேம், இதுல பாதி தான் மேம் இருக்கு. நான் ப்ரிப்பேர் பண்ணது பாதி இல்ல மேம். Can I skip that part and these these are some of the examples of rapid acting and long acting insulin analogs. These are some graphs that represents the actions of rapid acting insulin analogs. As you can see, there is a clear cut peak of action of these three insulin analogs, but the peak is very flattened as the action is very slow and delayed in long acting insulin. These insulin analogs are designed as per to mimic the human insulin's actions and pattern of release. icodec, this insulin is otherwise called as once weekly insulin. It is injected once weekly once, and that the action is prolonged through week. That's it.
You have anything more to tell? Sundara Pandi. Okay, Nilunga, you have some comments. So insulin analogs, you told it was 1982. When was it discovered? Insulin? Long back. So that is a big hallmark, you know that, no? Before that, type 1 diabetes patient will be dying at the first decade. There's a sure death. After discovery of insulin, it was a total changeover, and type 1 diabetics have a very normal lifespan till now. So when what was it discovered? Any idea? Who is the discoverers? Anybody?
Charles and
Banting Best, very good. Banting and Best in 1921. So this is the 1000th year we are celebrating. You are not observing, you are celebrating, because it is a big discovery as such for the medicine. Makkal, it's a big discovery as such. Okay, analogs now, as you told, is a recombinant technology. What is what to tell? Clinching advantage over the normal regular insulins, analogs. It is expensive, not that one.
No, ma'am. We can.
Classically, no. Anybody? No
hypoglycemia.
No hypoglycemia. So that is the thing. And nowadays we are using all the insulin analogs in pregnancy as such, because pregnancy is one state where the patient has to consume for her as well as for the baby. So there should be no hypoglycemia. That is the thing. We are using the Deglutec. That once weekly is we are not using. That is Deglutec is what is the ultra long acting insulin that is approved for GDM as such. Okay, pa.
May I know why that weekly once?
Weekly la patala, it's not practically, it's not there. It's only in the books.
Thank you.
Oi, Sundarapandi. லாஸ்ட் மினிட் ப்ரெசென்ட்டாக போல் இல்லை மேடம் சொல்லி ப்ரெசென்ட் பண்ணியா, குட் ஜாப். இன்னும் கொஞ்சம் ஸ்லைட்ஸ் ப்ரீவியஸாக பண்ணாங்க இல்லையா, இது மாதிரி கிளாரிட்டி இருக்கணும். என்ன ப்ரெசென்ட் பண்ணுறோம், எதுக்கு, ஏன் ஃபாஸ்ட் ஆக்டிங், ஒன்று வந்துக்கு ரீசன் அவுட் பண்ணணும். ப்ராக்டிக்கலாக என்ன யூஸ் பண்ணுறோம், மேடம் சொன்ன மாதிரி அது இது வரைக்கும் புக்கில் தான். கண்ட்ரோலு, மானிட்டரிங்கு எல்லாமே வந்து லாங் ஆக்டிங் வந்து பெஸ்ட்டு, கம்ஃபர்டபுளாக இருக்கும் யூஸ் பண்ணுறதுக்கு. ரிஸ்க் ஆஃப் ஹைப்போக்ளைசிமியா கிடையாது. ஸோ ஒன்று ஏன்னு சொல்லிட்டு யோசித்து படிக்கணும். இதெல்லாம் இருக்குது அப்படின்னு தெரிஞ்சால் மட்டும் பத்தாது. நிறைய சாய்ஸஸ் இருக்கும் மார்க்கெட்ஸில். பட் அந்த பேஷண்ட்டுக்கு எது சூட்டபிள்னு இண்டிவிஜுவலைஸ்டு தெரப்பி பண்ணணும். எப்போவுமே புக்கில் இருக்கிறத அப்படியே அப்ளை பண்ண முடியாது, வெப்சைட்டில் இருக்கிறதையும் அப்படியே அப்ளை பண்ண முடியாது. குட் ஜாப், குட். நாங்கள் கிவ் அஸ் சம் டைம்.
Thank you to all the participants for your informative and insightful presentations.
So yes, your serotonins are coming up, inducing sleep in you, I know, and we will wake up you with your endorphin. Come, please put that next slide. We want two people to enact this scene. Play the scene, play the scene. You can see the scenario. Two people can come forward and enact this scenario for us. With the dialogues. We will play it once. you can rehearse and come and enact with the dialogues. Play it from the first pa. Play it again. Okay. Who is ready? Boys or girls? Anybody? Who is ready? Come forward. I think our department, Tom and Jerry, are ready. Yes, Murgava sir and Ganapati sir are eagerly waiting. Vanga sir. Students. Vapa. Very good. Chedam. Yay. Who is going to be SK? Perenapa? Suri. Annamalai engira Suri. Ishwar engira SK. Innor mic kudungappa. Satyaraj engira Anbu, come.
நீங்கள் திருவிழாவை நடத்தாமல் போங்க.
நீங்கள் கரகத்தை தூக்காமல் போங்க.
ஆனால் எங்களுக்கு ஆடலும் பாடல் நிகழ்ச்சி போட்டே ஆகணும். ஆ
Very well, really presented, pa. Super. More than so far presentations, your presentation only I liked. Yes, thank you. Come. Oh, 3 people and the 3 பேரும் அதிலே வந்து ஷேர் பண்ணி. We have Sir Saravanan sir, please honor them with the prize. Prize வாங்கிட்டு once more பண்ணிடுங்கப்பா. போட்டோ போஸ்ட் கொடுங்க. போட்டோ போஸ்ட். உங்க மேபி 2 பேருக்கு ஏதாவது அரேஞ்ச் பண்றோம். பண்ணுங்களா? ஹெச்ஓடி மேம் மிஸ் பண்ணிட்டாங்க. ஏய் வா. என்ன டயலாக் இருக்கு சத்யராஜ்க்கு? இல்ல மேம். சும்மா ஸ்டாரிங் பண்ணு. அதுக்கு ஸ்டாரிங் பண்ணு.
நீங்கள் திருவிழாவை நடத்தாமல் போங்க.
நீங்கள் கரகத்தை தூக்காமல் போங்க.
ஆனால் எங்களுக்கு ஆடலும் பாடல் நிகழ்ச்சி போட்டே ஆகணும். ஆ
சொல்கிறேன். எங்கே அங்கே ஆடியன்ஸே காணோம், எல்லாம் ஓடி போயிடுச்சுங்க. சரி, சக ஸ்டூடெண்ட் வந்து ப்ரெசென்ட் பண்ணுறாங்கன்னா இப்படி தான் ஓடிடுவீங்களா? தோஸ் ஹூ சேட் டில் த எண்ட் ஆஃப் த செஷன் வில் பி கிவன் அட்டண்டன்ஸ். ஓஜி கிளாஸோட அட்டண்டன்ஸ். அதர்ஸ் வில் நாட் பி கிவன். சரியா? ஓகே. நம்ம காலையிலேருந்து எண்டோக்ரைன் ஹார்மோன்ஸ் எல்லாம் பார்த்துட்ருக்கோம். ஐ வாண்ட் சம் ஆன்சர்ஸ். இப்போது எப்படி உங்கள் ஹார்மோன்ஸை வந்து ஹார்மோனிக்குள்ளே கொண்டு வருவீங்க? சம் டிப்ஸ் கேன் யூ டெல் மீ? பிஜிஸ் வேண்டாம். ஸ்டூடெண்ட்ஸ் ஃபஸ்ட்டு. வெரி குட். ஸ்லீப். கிளாப் பண்ணுங்கப்பா. ஸ்லீப்பை ஃபஸ்ட்டு நார்மலைஸ் பண்ணணும். அந்த டைம் எப்போ தூங்கணும். மெடிடேஷன் வெரி குட் சாய்ஸ். அப்புறமா வாக்கிங், ரெகுலர் எக்ஸசைஸ் வெரி குட். வேறு என்னம்மா? நோ ஆல்கஹால் வெரி குட். டயட்டுன்னா என்ன அர்த்தம்? பேலன்ஸ் டயட், குட் நியூட்ரியன்ஸ். அப்புறம் டூயிங் த ஒர்க் ஆன் டைம். இல்லைன்னா டென்ஷன் ஆகிடுவீங்க. அப்போ தான் ஸ்ட்ரெஸ் ஃப்ரீ. அதாவது நிதானமாக ஹேண்டில் பண்ணுறது, முன்னாடியே கிளம்பிடுறது. அப்போ தான் லோ கார்டிசால் இருக்கும். வெரி குட். கார்டிசால் கண்ட்ரோல். என்னம்மா? ஆர்கானிக்காக போகிறது ரதர் தென் வெளியில் எக்ஸ்டர்னல் வெளியில் போய் சாப்பிடாமல் இருக்கிறது. அவாய்டிங் கெமிக்கல்ஸ். வெளியில் வந்து நிறைய கெமிக்கல்ஸ். மியூசிக்ஸ் வெரி குட். மியூசிக் காம்ஸ் வாட்? அவர் மைண்டு, சோலு, அதெல்லாம் ரிலேட்டட் வித் அவர் பாடி ஆர் நாட்? டிசீஸ் ஆர் நாட்? எஸ். வேறு ஏதாச்சும் இருக்கா? அவாய்ட் ஸ்ட்ரெஸ்ஃபுல் கண்டிஷன். யாராவது ஸ்ட்ரெஸ் கொடுக்குறாங்களா? அவாய்ட் தம். வெரி குட் சாய்ஸ். ஸ்டே அவே ஃப்ரம் நெகட்டிவ் பீப்புள், நெகட்டிவ் சரௌண்டிங்ஸ், நெகட்டிவ் டாக்ஸ். சம்மந்தம் இல்லாத பேசுகிறத வந்து அதுக்கு மிக்ஸ்டில் நம்ம இருக்கிறது. டிவியில் தேவையில்லாமல் நியூஸை பார்க்குறது, தேவையில்லாத ரீல்ஸை பார்த்து டென்ஷன் ஆகிறது இல்லை, அது எல்லாமே தேவையா நமக்கு? வி ஆர் இன் நோ வே ரிலேட்டட் டு தெம் இல்லையா? என்னம்மா? டேக்கிங் அ பிரேக், வெக்கேஷன், taking a break from your monotony, rejuvenating yourself, I'm coming back to work. சூப்பர், நிறைய சொல்லிட்டீங்களே. நல்லா படிக்கிறதா? எதை படிக்கணும்? பயோகெமிஸ்ட்ரி. அடப்பாவி, அப்போ தான் ஸ்ட்ரெஸ் ஏறிடும் இல்லை? யூ கேன் ரீட். ரீடிங் இஸ் அ வெரி குட் ஹேபிட். புக்கு படிச்சிங்கன்னா நல்லா ரிலாக்ஸேஷன் கிடைக்கும். தட்ஸ் ட்ரூ. யூ ஹாவ் டு சூஸ், கரெக்டான புக்ஸை சூஸ் பண்ணணும். ஓகே, அந்த எக்ஸ்க்ளமேஷனை போட்டுடலாம். மேரேஜ் இஸ் அ கான்ட்ரவர்சி மேம். மேரேஜ் பண்ணலாமா கூடாதான்? மேரேஜ்னால பீஸும் கிடைக்கலாம், அதவே போகலாம். கிட்ஸு தட் ஆல்சோ த அகெயின் த சேம். இப்படி எடுத்துக்கிட்டா இப்படி, அப்படி எடுத்துக்கிட்டா அப்படி. We are in the stage of love it seems ma'am. Later only we go into marriage phase. They are in the stage of love. Love பற்றி comments. Nowadays they talk about toxic relationship இல்லையா? So once you know that it is toxic, you stay away. Somebody was asked, it seems some lady, are you happy? Are you married? Yes, yes, I am married. So you have to thank your husband. Why should I thank him? He is in no way related to my happiness. Okay, I am always happy on my own, whether I am married or I have children or I am any age group, right? போட்டியாம்மா, நீங்கள் சொன்னதெல்லாம் அதுலேயே வந்துடுச்சா? வந்துடுச்சுல்ல?
ஒரு இன்ட்ரெஸ்டிங் ஃபேக்டர், the happiest people அப்படின்ட்டு போலிங் எடுத்ததுல it was found to be Norway, where majority was not married, single.
Any comments you have? No comments. Yes, exposure to heat to be reduced. அப்போ நான் ஏசி போட்டு உட்காந்துக்கணுமா? வெளியில் போகக்கூடாதா? அப்புறம் எப்படி வேறு வேலை எப்படி பார்க்குறது வெளியில் போகலனா? ஃபாரஸ்ட் டெவலப் பண்ணலாம். வேறு எப்படி கூல் பண்ணிக்கலாம்? ஹைட்ரேஷன் குட். பாடி எப்படி கூல் பண்ணுவீங்க? என்ன இந்த பக்கம் தான் என் பாயிண்ட்லாம் வருது, அந்த பக்கம் வேஸ்ட். காட்டன் க்ளோத்ஸ் ஸ்கின்னுக்கு வந்து நல்ல ஹில் ஸ்டேஷன் அப்பப்போ போகலாம். என்ன ஸ்கூட்டர் மாதிரி இதை காமிக்கிறேன். லூஸ் க்ளோத்ஸ், ரொம்ப டைட் ஃபிட்டின் பண்ணாமல். அப்புறம் ஸ்வெட்டுக்கு கொஞ்சம். ஃபுட்ஸில் என்ன பண்ணலாம்? ஃப்ரூட்ஸு, குக்கும்பர், கூலிங் ஃபுட்ஸ் எல்லாம் எடுத்துக்கலாம். காலையில் ஒன்று சொன்னாங்களே பெஸ்ட்டு ஃபுட்டு, பழைய சோறு, கஞ்சி, பாட்டில் வந்து வாட்டர் எடுத்துக்கலாம் இல்லையா? நிறைய இருக்குது கூல் பண்ணுறதுக்கு. இதில் ஸ்பைசஸில் கூல் பண்ணுறதுக்கு வெந்தயம், வெரி குட். ஸோ நிறைய விஷயம் இருக்குல்ல, நம்மளே நம்ம கூல் பண்ணிக்கணும். மைண்ட்லேயும் நமக்கு பாசிட்டிவ் இன்புட்ஸ் மட்டும் கொடுத்துக்கணும். நம்மளே நம்ம ப்ரைஸ் பண்ணிக்கணும், நம்மளே நம்ம அட்மையர் பண்ணிக்கணும், நம்மளே நம்ம நெகட்டிவ் தாட்ஸ் நெகட்டிவாக பேசக்கூடாது. ஓகே, SKY சுதர்ஷன கிரியா யோகா அப்படின்னு ஒன்று இருக்குது. நானே நேற்று தான் தெரிஞ்சுக்கிட்டேன். அப்படி ஒருத்தங்க திஸ் இஸ் ரிலேட்டட் டு ஹார்மோன் பேலன்ஸ். இங்கே போயிட்டு பாருங்கள், சிம்பிள் ப்ரீத்திங் டெக்னிக்ஸ் தட் கேன் எனேபிள் டு பிரிங் ஹார்மனி டு யுவர் ஹார்மோன்ஸ். ஓகே, உங்கள் ஹார்மோன்ஸை நல்லா ஃபங்க்ஷன் ஆக்க வைக்கிறதுக்கு சிம்பிள் எக்ஸசைஸ். ஐ யூஸ் டு ஸ்டார்ட் மை கிளாஸ் வித் ஸ்மால் 2 minutes மெடிடேஷன். அதில் டெஃபினட்டாக ப்ரீத்திங் இருக்கும். அப்போ தான் நம்ம ஃபோக்கஸ் வரும். அதுக்கப்புறம் தான் நம்ம ஏதாச்சும் லிசன் பண்ண முடியும். ஓகேவா? வாஸ் திஸ் யூஸ்ஃபுல் டு யூ? எஸ், யூ வில் டேக் ஹோம் ஆல், அப்ளை அட்லீஸ்ட் சம். ஓகே, தட் இஸ் த outcome of this CME. Now it's time to release the results of the e-poster. First of all, I would like to thank engala first year departments, faculties ku, you are all new but still you came forward to present. First I appreciate all the presenters. ரொம்ப present okay, அதுக்காக தான் மெனக்கட்டு மேடம் நான் கூப்பிட்டேன். So madam will announce the results. Madam, if you want to share, you can share a few words.
Okay. Good evening, one and all present here. That was a nice session, madam, nicely arranged, well organized, and credit goes to the whole biochemistry department, PGs, assistant professors, and most of all HOD biochemistry. She is young, she is very enthusiastic. Try to utilize her as much as possible. She is very academic also. So I loved all the 10 presentations. According to your thing, your final MBBS, you have come forward, you are very confident, and took the dais for you as such and presented very well. But we had to shortlist, no other go. Third prize, I will go with the third prize, shared by two. This is based on the content, how innovative they were and their presentation. And added to that, we have added how much they were answered as such, because there was a tie between 4 persons. So that thing which has decided with that is not reading from the text as such, and who have delivered from their mind and soul, as the madam told, mind and soul as such. So last two will be Akshini, who has done with thyroid in pregnancy, thyroid disorders in pregnancy. I like the way you presented. It was very enthusiastic, and you have delved into the subject as such. Nice, gum. And shared by Hasina, GDM. She was also very calm, composed. Others were very bit jittery, but she was very calm and composed. Yes. Kuduthulama illa solidva. Come to the dais, Hasina and Hazima, Akshini. Second prize, any suggestions? Sundara Pandi, Achudan. Yes, Saravana Selvan Ilya. Okay. Second prize is for Achudan for AUB. So me and madam liked the way of presentation and his knowledge on AUB. Yes. Good research. And first prize, Jane Rashini. Srinidhi, yes, Srinidhi. Srinidhi S. Pheochromocytoma. Big applause for Srinidhi S. Yes, Srinidhi. She has done a very good job. அடுத்தடுத்து பண்ணிட்டே இருங்க. That is my suggestion. Every time you get a stage or dais, don't differ. You have to do that. Good.
I'd like to call Srinidhi Rajan for collecting their participation birth certificate.
Other participants can come and get your
Is Srinidhi Rajan?
certificates.
call upon Saravana Selvan to collect his participation certificate. Yes, now I would like to call upon Tarshini. I would like to call upon Lisa Joyce. I would like to call upon K. Jayan. Now I would like to call upon Sundara Pandi. Congratulations to all winners and a warm appreciation to every participant. Your enthusiasm made Endo Explore truly memorable. I now ask my Professor of Department of Biochemistry to felicitate our judge, Dr. Vanilla ma'am.
I would like to thank each and everyone who participated. Last but not the least, என்னோட department faculties, PGs, students, first year students, volunteers. I am so thankful to all the staff in my department for making this CME a grand success. Please give a big round of applause for all of them. அவங்க இல்லைன்னா இந்த CME இன்னைக்கு பாசிபிள் கிடையாது. And I have been here only for the past 1.5 months. I am so very new. So எல்லா விதத்திலையும் இவங்க எல்லாரும் சப்போர்ட் பண்ணதுனால I am able to do a CME. That too because of our beloved dean. I am so thankful and thankful to madam for coming from Tanjavur for this event. Thank you so much, madam.
Audience தெரியுமா, Tamilmani ma'am is a great singer. We used to have her sing on every occasion. Short, we can make it last moment of joy. சின்னதா பாடுங்க.
A.R. Rahmana, Ilayaraja. Ilayaraja. Oh, madam, advanced. Ilayaraja la enna paattu? Unga paatte padirava? Paavenilla. ஏதாவது some choices கொடுங்கப்பா. உங்க எல்லாருக்கும் தான், இங்க இருக்கவங்களுக்கு தான், இங்க இருக்கவங்க தான், யார் கேட்குறீங்களோ அவங்களுக்கு தான் டெடிகேஷன். Give me some Ilayaraja choices, female songs. ஜானகி பாடினது நல்ல பாட்டு தான், ஆனால் எனக்கு என்னம்மா தெரியாதம்மா. சித்ரா சாங்ஸ் தான் நான் கொஞ்சம் பாடுவேன். லிரிக்ஸ் நல்லா தெரிஞ்ச சாங்காக போட்டு அது தெரியும். எதுக்கும் லிரிக்ஸ் வச்சுக்கிறேன்.
குழலூதும் கண்ணனுக்கு குயில் பாடும் பாட்டு கேக்குதா? குக்கு குக்கு குக்கு. என் குரலோடு மச்சாவுங்க குழலோச போட்டி போடுதா? குக்கு குக்கு குக்கு. இலையோட பூவும் தலையாட்டும் பாரு, இலையோட பூவும் காயும் தலையாட்டும் பாரு பாரு. குழலூதும் கண்ணனுக்கு குயில் பாடும் பாட்டு கேக்குதா? குக்கு குக்கு குக்கு. மலையோரம் வீசுற காது மல்லிய பூ பாடாதா? மழை மேகம் கூடுற போது வண்ணமயில் ஆடாதா? எம்மேனி தேனரம்பு என் பாட்டு பூங்கரம்பு. மச்சானா மெட்டெடுப்பே உன்னத்தான் கட்டி வைப்பே. சுவான ராகம் சொல்லி பாடட்டுமா? உனக்காச்சு எனக்காச்சு சரி ஜோடி நாமாச்சு கேளையா. குழலூதும் கண்ணனுக்கு குயில் பாடும் பாட்டு கேக்குதா? குக்கு குக்கு குக்கு. உந்தன் கஞ்சாடை விழுந்ததில் நெஞ்சம் நெஞ்சம் தரிகெட்டு தழும்புது நெஞ்சம். எந்த நூலாடை பறந்ததில் கொஞ்சம் கொஞ்சம் பிறைமுகம் பார்த்ததில் கொஞ்சம் ரத்தம் கொதி கொதிக்கும். உலை கொதித்திடும் நீர் குமிழ் போல சித்தம் துடி துடிக்கும். புயல் எதிர்த்திடும் ஓரிலை போல பனித்துளிதான் என்ன செய்யுமோ? மூங்கில் காட்டில் தீ விழும் பொழுது மூங்கில் காடென்று ஆயினல் மாது. கண்ணாளனே எனது கண்ணை நேற்றோடு காணவில்லை. என் கண்களை பறித்து கொண்டும் ஏன் இன்னும் பேசவில்லை? ஆளான ஒரு செய்தி அறியாமலே அலைப்பாயும் சிறு பேதை நானோ. உன் பேரும் என் பேரும் தெரியாமலே உள்ளங்கள் இடமாறும் ஏனோ. வாய்ப்பேசவே வாய்ப்பில்லையே வலி தீர வழி என்னவோ. தேங்க்யூ.
Thank you all for making this hybrid CM a grand success. Thank you.
அப்பா சார் அவங்க டீமாக இருக்காங்களா இல்லை ஒருத்தர்? மூணு பேர் இருக்காங்க சார். ஸோ ஐ வுட் லைக் டு தேங்க் அவர் ஏவி டீம்ப்பா. அவங்களால தான் இது வந்து ஆல் ஓவர் ரீச் ஆகிருக்கு. ஸோ ஹைப்ரிட் மோடு, அதனால தான் நிறைய ரெஜிஸ்ட்ரேஷன்ஸ், நிறைய பேர் இங்கேருந்து பார்க்குறதுக்கு ஸ்மூத்தாக அழகாக கொண்டு போயிருக்காங்க. டெக்னிக்கலாகவும் எங்களுக்கு ரொம்ப ஹெல்ப்ஃபுல்லாக இருந்தாங்க. வி வுட் லைக் டு அக்னாலேஜ் அண்ட் தேங்க் தெம். சார் அவங்கள வர சொல்லுங்கள் சார். அவரோட பேர்
Come here. மிஸ்டர் பாலமுருகன் கொடுத்துடலாம் வாங்க. Mr. Prabhakaran. We are very thankful to you, sir. Such a nice way. The screen, mic systems, hybrid mode, ellame sir da. Thank you so much. Mr. Sendil Nathan, please come, sir. Please come together. வாங்க எல்லாரும் ஒரு போட்டோ எடுத்துக்கலாம். Shall we stand on the stage? டேபிள் எடுத்துக்கலாமாம்மா? இங்கே கொஞ்சம் ஒரு ரோ உட்கார மாதிரி. சார் வாங்க.
Hip hip. Special thanks to Saravanan and Selvan who have coordinated the hand. Thank you, Saravanan.